Hello students, Instructor Hannah here for Chapter 1, Lesson 1.1, the medical record. So the medical record is a written or electronic record of important information regarding a patient. And the patient is an individual receiving medical care. The medical record functions to make decisions regarding the patient's care and treatment, to document results of treatment and patient's progress, to communicate information to authorized personnel in the medical office, and it serves as a legal document. Again, the medical record is a legal document. The law requires that a patient's care and treatment be documented correctly. Good documentation is critical to legally protect the healthcare provider and their staff. Incomplete records can cause serious problems. They may be used as evidence to show that a patient did not receive quality care, which is malpractice. Information is strictly confidential. It must not be read or discussed with anyone not directly involved in the care of the patient. This brings into play the HIPAA privacy rule. HIPAA stands for Health Insurance Portability and Accountability Act. This is a federal law that protects the patient's privacy. It went into effect April 14th, 2003. The purpose is to provide patients with more control over the use and disclosure of their health information, which is known as PHI, Protected Health Information. Who must comply with the HIPAA privacy rule? Anyone that uses, stores, maintains, or transmits health information, such as healthcare providers, health insurance plans, and healthcare billing services. There are very severe civil and criminal penalties for non-compliance with HIPAA law. Typically, most medical offices have a Notice of Privacy Practices, the NPP. This is a written document created by the medical office that explains to the patient how their PHI will be used and how the medical office will protect it. What is PHI? This is health information in any form. So it could be written on a chart or even on a piece of paper or printed out from the computer. It could be electronic, so on the health record, electronic health record, and it can be spoken and oral information. So if I'm talking to my coworker about my patient and their health information, that is protected. And this PHI contains patient identifiable information. So it could be the patient's name, their social security number, their telephone number, their address, insurance information, anything that could be traced back to the patient. A reasonable effort must be made by the medical office to provide that notice of privacy practices to each patient. And typically the patient must sign and return the form, and the medical office will retain that. Written consent for use or disclosure of PHI is not required for medical treatment, such as if a patient's referred to a specialist, emergency care provided at a hospital, and laboratory tests performed on a patient. So if your primary care provider is referring you to a specialist, they can release your medical information to assist the specialist. The emergency department can release information regarding your visit to your primary care provider to assist them in treating you after you've been to the emergency room. And your primary care provider can release information about your health to the laboratory or radiology to assist them in performing the test. So anybody regarding payment, so determining eligibility for insurance benefits. So this means that your healthcare provider may give PHI to your insurance company to assist in determining your benefits or getting a prior authorization so that they can give payment, and reviewing services provided for medical necessities. So the insurance company may ask for additional information before they will pay for something. And then any healthcare operations within in-house, such as quality assessment activities, contacting patients with information about their care or treatment, reviewing employee activities, and training healthcare students. Patients have the right to access their own medical records and request changes if they believe there are inaccuracies. So this medical record belongs to them, and the owner of it is the office, the medical office. So they are responsible for protecting the PHI from inappropriate access and must make every effort to limit the use of, disclosure, and request for PHI to the minimum necessary required to take care of the patient. So a request from insurance company for procedures performed on the patient, we can release that information, but we're only going to release the minimum amount necessary that the insurance company needs. And patients have a right to request an account of the transfer of their information for any purposes other than the treatment, payment, or healthcare operations. Businesses to whom the medical office discloses PHI must respect the HIPAA privacy rule, and the medical office must have written agreement with each business to handle the PHI in accordance with HIPAA law. So that might be medical laboratories, transcription services, law firms, accounting firms, software and hardware consultants, and billing services. So the medical office must implement for all employees a basic training program on privacy and security of PHI. So typically you'll go through a training refresher every year. It'll be titled HIPAA or privacy training.
Mm-hmm.
So the components of the medical record. The medical record consists of numerous documents, pre-printed forms, and also computer templates. Each has a specific function or purpose, and these documents are usually classified into the following categories: administrative, clinical, laboratory reports, diagnostic procedure reports, therapeutic services, hospital documents, and consent documents. So let's look at each of these. Administrative documents. These contain information necessary for the efficient record-keeping management of the medical office. And they would include the patient registration record, the notice of privacy practices acknowledgement form, and any correspondence not having to do with clinical information, such as correspondence with the insurance companies, attorneys, with the patient themselves, patient referral letters, and collection letters. The patient registration record consists of demographic and billing information. Usually all new patients must fill out this form, and typically the staff will enter the information into the computer. And the information is used for computerized functions such as scheduling appointments, posting patient transactions, processing patient statements, and insurance claims. Demographic information consists of the patient's full name, address, phone, such as home, work, and cell, their date of birth, their gender, marital status, and their employer. It will also consist of the billing information, which is the name of the responsible party. So that would be the name of the insured. So for example, I am under my husband's insurance, so he is the responsible party, okay? And then the patient's social security number, the address of the responsible party. So an example, you might have a child or adult child who can still be covered under their parents' insurance, and their address might be different. And then again, the name of the insured, so that would be the patient probably. And then the insurance company, typically you would want to get a copy of the insurance card like this, which includes the policy and the group number. Often the medical office will take a copy of the Social Security card as well as the patient's identification card or driver's license if they have one. Clinical documents. These are records and reports that assist the provider in the care and treatment of the patient. Typically include a health history report, physical exam report, progress notes, medication record, consultation reports, and any home health care reports. Oops. There we go. So the health history report is a collection of subjective data about the patient. Health history is obtained by either having the patient complete a pre-printed form, or it can also be filled out by the provider or a medical assistant during an interview, a one-on-one interview with the patient. A thorough history is obtained on every patient when they're new. And then in future visits, this provides information regarding changes in the patient's condition and treatment. The physical exam report includes an assessment of each part of the patient's body. The purpose is to provide objective data about the patient, and it assists the provider in determining the patient's state of health. And typically includes a summary of the provider's findings from each part of the patient's body. Progress notes, the purpose is to update the medical record with new information each time the patient visits or phones the office. So this would document the patient's health status from one visit to the next. It must include the date and time and the signature and credentials of the person making the entry. The medication record contains detailed information on the patient's medications. This includes prescription medications and over-the-counter medications. You'll usually see that referred to as OTC, over-the-counter, and then medications that are administered in the medical office. Most offices use two different forms, one for prescription and over-the-counter meds, and one for medications administered in the office. The consultation report is a narrative report based on the clinical opinion about a patient's condition. And this is usually by a consultant other than the primary provider, so a specialist such as a cardiologist. And the consultant's opinion is based on the review of the patient's record and an examination of the patient. Home health care reports. This is when a patient is visited by home health care. Could be medical and non-medical care in the patient's home. Home health care always must be ordered by a provider. And the purpose is to minimize the effect of disease or disability on the patient by promoting health, maintaining health, and restoring health. So typically a patient must be unable to leave the home for this care to qualify for home health care. So home health care could include nurses, aides, dietitians, physical therapists, occupational therapists, speech therapists, and social workers. Typically, once the patient is no longer homebound and recovers well enough to leave the home, home health care is usually discontinued. The services could include cardiac care, infusion IV therapy, respiratory therapy, pain management, diabetes management, rehabilitation, and maternal child care. A home health care summary report is sent to the patient's provider and may include observations and evaluations, type of care and service provided, medication instructions given to the patient, safety measures recommended for the home, diet, and the activities that are permitted. Okay, a laboratory report is an analysis or examination of body specimens. The purpose is to relay the results of lab tests to the provider to assist in the diagnosis and treatment of disease. Categories include hematology, clinical chemistry, immunology, microbiology, histology, cytology, parasitology, and urinalysis. A diagnostic procedure report would report the procedure performed to assist in the diagnosis, management, or treatment of a patient's condition. This is performed usually by a provider, an MA, or a trained technician. Interpretation of the results made by the provider, and they complete a written report. The written report includes a narrative description and interpretation of a diagnostic procedure, as well as clinical data. Types of diagnostic procedure reports could include electrocardiogram report, so an EKG, that's what this is right here, a Holter monitor report, spirometry, colonoscopy, radiology, diagnostic imaging. Those are just some examples. Health history, physical, lab, and diagnostic tests are all used to determine patient's state of health and arrive at a diagnosis. Diagnosis is the scientific method of determining and identifying a patient's condition. And so this is used to prescribe treatment and document change in a patient's illness after treatment.
Okay. Okay.
Therapeutic service reports document the assessments and treatments designed to restore a patient's ability to function. Therapeutic services include physical therapy, use of physical agents to restore function and promote healing following an illness or injury,
Just be careful.
such as therapeutic exercise, thermal modalities, hydrotherapy, electrical stimulation, and massage. Occupational therapy helps the patient learn new skills to adapt to a disabling condition to enable the patient to perform activities of daily living, ADL, and achieve as much independence as possible. Speech therapy is treatment for the correction of a speech impairment, maybe resulting from issues at birth or complications, disease, injury, or previous medical treatment. Hospital documents. These are prepared by the person responsible for the care of the patient in the hospital, known as the attending provider. Typically now, that would be a hospitalist. Okay, the attending provider is known as the hospitalist. And that is the provider who's going to follow the care of the patient throughout their stay at the hospital.
Mm-hmm.
And this is an original document kept on file at the hospital, but copies can be sent to the patient's provider. And this assists the patient's provider in reviewing the patient's hospital visit and then providing follow-up care after discharge. So examples of hospital documents are an H&P, history and physical report. This is done for anybody who is admitted to the hospital, so going from an outpatient status to an inpatient status. That's typically done by the hospitalist. Medical impressions, such as a tentative diagnosis, those are conclusions drawn to the patient's state of health. Then you would include an operative report if there's any surgical procedure performed, and that must be completed on all patients having surgery. You would, I'm going to skip here a little bit because typically the discharge summary comes at the end. So then you would have your pathology report, so description of any tissue removed and diagnosis. And you would also include any diagnostic reports, so any tests that were performed at the hospital, such as laboratory or any kind of diagnostic procedure. Those will each have their own report. And then you would have your discharge summary at the end of the inpatient stay, which is a summary of all events that occurred during the patient's hospitalization, and then their basically prognosis and any home instructions or follow-up instructions. There's usually a separate emergency department report that's obtained during the ED visit, and then that can be on its own, or that might preclude the H&P if the patient was admitted to the hospital. And typically the hospital will send copies to the patient's primary care provider. Consent documents. These are required to perform certain procedures. Pretty much all procedures require consent. And this is a release of information contained in the patient's medical record. And the types of consent forms are consent to
I'm
treatment,
recording.
and then a
I'm
release of
recording
medical information consent.
a video. So your mom's trying
So
to
the
keep
consent
everybody
to
quiet,
treatment
basically.
form is required for all surgical operations and all non-routine therapeutic and diagnostic procedures. This form is signed by the patient or their legally authorized representative, and this provides written evidence that a patient agrees to the medical procedures listed on the form. Not only that, it means that they are attesting to the fact that they understand the risks and benefits prior to signing the form. Okay, so this is known as informed consent. This means that the patient has received the following information before giving their consent. So the nature of their condition, the nature and purpose of their recommended procedure, the risks that are involved, and alternative treatment or other
She doesn't
procedures
want
that
pants.
might be available. And then the prognosis, which is the likely outcome of the procedure, and then any risk of declining or
2
delaying the
minutos.
procedure. So the consent to treatment form must be in language and terms that the patient can understand. So if it needs to be translated, that has to be done to make sure that the patient fully understands. And the patient must be given the opportunity to ask questions about the form. And it should not be signed until the patient has been provided with all of that necessary information on the previous slide. And the patient's signature must be witnessed. So usually that is the medical assistant's job to verify that it is the patient or the patient's authorized representative who is signing the form, and they actually watch them sign the form. Now, this does not mean that the medical assistant is attesting to the accuracy of the information on the form. That is up to the provider who is performing the surgery or procedure. A release of medical information form. This is not required for medical treatment, payment, and healthcare operations. So TPO, treatment, payment, operations, as stipulated by HIPAA, we talked about earlier. But it is required for purposes that are not part of treatment, payment, or healthcare operations, such as if the patient moves to another state and transfers their records, or if the patient decides to switch physicians or providers, then they must sign a form, and they can mail it or fax it if they're unable to come into the office. And this has to be retained on file before the medical office can release the information, the PHI, to whoever the patient has authorized to receive it. Okay, that concludes lesson 1.1. Hello students, instructor Hannah here for chapter 1, lesson 1.2. This is the types of medical records. So you have either a paper-based patient record, where most of the record is on paper. Some data might be stored on the computer, such as the registration information, but this is where the patient has a physical chart. Or you have the electronic medical record, where the entire medical record is stored in a database on the computer and there is no paper chart. Any paper records are scanned and added to the electronic medical record and then typically shredded. So the EMR, electronic medical record, is the most common form of record now. This is the computerized record of any health information regarding the patient, which includes care of the individual and the progress of patient's condition. The entire record is stored on a database. Sometimes you'll hear it referred to as the EHR, electronic health record. So you could hear it referred to as EMR or EHR. And the software can perform the following medical record functions: creation, storage, organization, editing, and retrieval of records. So the advantages are speed and productivity, quick retrieval of information, documents from outside facilities can be stored, no filing required, saves time and space, paper costs are reduced. Okay, so I've worked for the Palo Alto Medical Foundation in Santa Cruz for quite a long time now, before it was Palo Alto Medical Foundation. And we had a whole building full of charts, medical records building, entire warehouse full of our patient charts. So when we integrated to the electronic medical record, it took a long time to put all that information, scan all of those charts into the electronic health record. But once done, we were able to dispose of the charts after 7 years. And now that building houses the call center. So lots and lots of people sit there and answer the phones and send messages and schedule your appointments. So it's definitely more effective. So the efficiency, it includes checkboxes and drop-down lists. You can print customized education handouts and instructions for the patients, and you can also now electronically send new prescriptions and refills directly to the pharmacies. Accessibility, this means that the medical record can be available at any computer station and more than one person can view it at the same time. And it's accessible immediately if the patient calls the office. So back in the old days when we had patient charts, we would have to fight over who got the chart, especially if the patient had an appointment with one provider one day and another the next day. We'd have to try and figure out how to share it and transfer it. And then if the patient calls into the office with questions about their medical record, if that chart was in another location, then you weren't able to assist the patient. So disadvantages is that there's an initial cost that is a large financial investment, including purchase of hardware and software, and then software upgrades. The time investment, as I talked about, is considerable. Learning and using the system and on-site training and tech support, and it can take several months or longer, as well as transferring all those records into the electronic record, as I talked about earlier. Old records need to be manually scanned into the computer. That is a large job. So when we're talking about the health history, it usually is sectioned into these following: identification data. So this will include basic demographic info about the patient, such as their name, address, and date of birth. It should include the chief complaint, the present illness, the past history, family history, social history, review of systems, and then also a physical exam. So this is typically known as the health and physical. The chief complaint. So there are 2 parts to a full chief complaint. That's the main reason that the patient is there seeking care at that reason that you're here today. What is the reason for your visit? Why are you seeking care? And this is used as a foundation for the patient's present illness. And the MA is usually responsible for obtaining and recording the chief complaint. It can be entered on a pre-printed form, like a progress note, or directly into the EMR. And certain guidelines must be followed in recording. So the guidelines are, you want to use open-ended questions. Okay, so that means that is a question that cannot be answered with yes or no. Okay, so examples of that would be, what seems to be the problem? What are we seeing you for today? How can we help you today? Okay. Closed-ended questions are things like, so I heard document the chief complaint concisely and briefly. You're going to use the patient's own words as much as possible, right? And include the duration of the symptom. So the onset, when did it onset? So you want to avoid using names of diseases or diagnostic terms. So if the patient says they have a nosebleed, you're going to write nosebleed, not epistasis, which would be the medical term for it. Right? Classic. I thought it might help you if I listed my symptoms. That's a long list. I've seen those before. So when we're recording chief complaints, correct examples would be burning urination that has lasted for 2 days, pain in the right shoulder that started 2 weeks ago, shortness of breath for the past month. Incorrect examples, has not felt well for the last 2 weeks. So that's very vague, right? Has not felt well. Well, that could mean a lot of different things to a lot of different people. So it's not specific. Ear pain and fever, well, that's great. You just need to specify which ear, or if it's both, bilateral. And then you need to know how long both of these symptoms have been going on. You need the duration. Pain upon urination, indicative of a urinary tract infection. So again, we don't want to use the disease names. Okay, we don't want to pre-diagnose the patient. That is out of our scope of practice, right? And the duration is not listed. The present illness. This is an expansion of the chief complaint. So this is a full description of patient's current illness from the time of onset. This should be recorded on the same form as the chief complaint. Sometimes the medical assistant completes this. You're going to ask the patient more detailed questions to obtain a description of the chief complaint. And this does require skill and practice, learning how to ask the proper questions to obtain the correct information. Past history. This is the past medical status of the patient and past diagnosis. This assists the provider in providing optimal care. Typically, the patient completes this section, and it's usually in a checklist form, and the medical assistant can definitely assist if needed. Sometimes patients don't know exactly what medical diagnostic terms mean, and you need to put it in layman's terms for them. So the past history would include any major illness, childhood diseases, unusual infections, accidents and injuries, hospitalizations and operations, previous medical tests, immunizations, allergies, and what did that one list? Current medications. Yeah. Family history. Typically, the patient would complete this section, or they could verbally tell the medical assistant or the provider. And this is a review of health status of the patient's blood relatives. So parents, siblings, grandparents, aunts, uncles. This focuses on familial diseases, which is a disease that occurs in blood relatives more frequently than would be expected by chance. So examples of that would be cancer, heart disease, allergies, diabetes. So that's important information to have regarding your patient. Okay, so on each blood relative, it would include the state of their health, the presence of any significant disease, and if deceased, what was the cause of death. The social history, that includes information on a patient's lifestyle, such as health habits and living environment. And the purpose of that is because lifestyle may and can have an impact on a patient's condition. And if a major lifestyle change is necessary, support services might be recommended, such as smoking cessation. The social history should include the patient's education, occupation, both past and present, their living environment, their diet, their exercise, sleep patterns, any use of tobacco, alcohol, caffeine, recreational drugs, and that
Complete or
includes
what?
past and present, their sexual history, their personal history, and travel to foreign countries can
Did
be
you mix
pertinent.
it?
The review of systems. This is a
I'm gonna try
systematic
mine.
review
Maybe
of
yours just
each
has too
body
much cinnamon on
system.
top.
The purpose is to detect
Yeah.
any symptoms that have not yet been revealed. The provider typically completes this section, or you may give a checklist to the patient to complete. And it has a series of detailed and direct questions related to each body system. This assists the provider in determining the type and extent of physical exam required. Documenting in the medical record. Documenting is the process of recording information about a patient in the medical record. This is performed by personnel directly involved with the healthcare of the patient. This is a legal document, again, so it's very important to chart information completely and accurately.
You want to go get something to eat when she goes to sleep?
You want to write it right.
Jack in the Box.
Check the name on the record
Ow.
before making an entry, and check the
I
date
was
of
gonna say
birth as
Sonic, if they're
well,
open. I don't know
because
what
you
it was.
will have patients, you know,
Taco Bell?
John Smith. You could have quite a few John Smiths that are your
Fairly
patients, so you
11.
need to check the date of birth as well. And this is the best protection from professional liability and malpractice lawsuits, is good care and good documentation. If it wasn't documented, it wasn't done. This is so true. So if a procedure is excluded from the correct patient's record, from a legal standpoint, a procedure not documented was never performed. So medical treatments, procedures, and medications administered should be documented right away, immediately. Do not wait until later to chart. Do it and then chart it. Documentation guidelines. Check the name on the record before making an entry and date of birth. Include the date and time on all entries. Document accurately using clear and concise phrases. Be brief but complete. Avoid vagueness and duplication of information. You do not need to include the patient's name in entry. Begin each phrase with a capital letter and end with a period. Use standard abbreviations, medical terms, and symbols. This saves time and space, but first check your office policy for accepted terms. Spell correctly, use a dictionary if necessary. Document immediately after performing the procedure. If you delay, you may not remember certain aspects of the procedure. Never document in advance. And the individual performing the procedure should be the one documenting it. You're never going to document for somebody else. Okay, these are huge. So you're never going to document that you gave an injection before you do it, because what'll happen is you'll walk in there and the patient will say, I changed my mind, and walk out, and you might forget that you already documented that. And it's difficult to delete it from the medical record. So you don't ever want to have any falsities or inaccuracies in that patient's chart. That includes documenting for somebody else. You might have a staff member say, oh, I totally forgot to put this in. Could you just chart this for me really quick? I gave this injection. I'm so busy. Never, never do that. When you're documenting in a paper record, always use black ink. This provides a permanent record and it's less hard to reproduce. Make sure you write legibly, include the date and time on all entries, begin each new entry on a separate line and do not leave any blank space. Each entry is signed by the person entering it. You're going to include your first initial, full last name, and credentials. So Lori would sign hers L. Columbani, comma, CMA. When you are charting here, In the program, you will chart the first initial of your name, period, your last name, comma, and we will use SMA for student medical assistant as your credentials. Never ever erase, black out, or use whiteout on an entry. This reduces the credibility if involved in legal litigation. So it's pretty hard to justify the use of that in the court of law. Make sure you correct all errors using the proper method. To correct an error, you're going to draw a single line through the incorrect information because you need the information below it to remain legible, to show that you're not trying to hide anything. You're going to write the word error or ERR above the incorrect data, and you're going to include the date, first initial, last name, and credentials, and then insert the correct information next to the error. So here's an example. You have the date and time, Manto TV test, measurement, 10 millimeters. So Lori must have written that incorrectly and realized that it was actually 12 millimeters. So she puts a single line through the incorrect information, writes error, the date, and her initials, and then the correct information. Okay. Symptoms. Symptom is any change in the body or its functioning that indicates the presence of disease. So we have two types of symptoms, subjective and objective. Subjective is felt by the patient and cannot be observed by another person. So this could be nausea, pain, vertigo, pruritus, which is itching. So I try to remember that the subject, which is the patient, is the only one feeling the subjective symptom. Objective symptoms can be observed by another person, such as fever, we can test for that, right? Rash, coughing, cyanosis, which is a bluish tinge. So that's all things that we can see on the patient. So I like to remember objective can be observed. Documenting the patient's symptoms. The MA should have a thorough knowledge and be able to recognize common symptoms. And taking the patient's symptoms consists of obtaining the chief complaint and then getting additional information about the chief complaint. The MA takes the patient's symptoms during office visits and during phone conversations. Information obtained over the phone often determines if a patient needs to be seen in the office or in the emergency department, and that helps determine the immediacy of treatment needed. Other activities that need to be documented. Procedures performed on the patient, such as vital signs. So it will also be collection of data, administration of medications or vaccines, specimen collection and sending out to the lab, diagnostic procedures and laboratory tests. So if the patient does not undergo the test ordered, documented proof exists that the test was ordered. And this also refreshes the provider's memory that a test was ordered. It would include lab test results and any patient instructions given to the patient. So an MA may need to give instructions to the patient regarding medical care, such as wound care. It is very important to chart this information. A pre-printed instruction sheet may be used. Patient signs the form indicating that they have read and understand the instructions. The MA witnesses the signature. The original is filed in the chart and a copy is given to the patient. This legally protects the provider if the patient does not follow the instruction and causes harm to themselves. Other areas of documenting would be missed or canceled appointments, telephone calls from the patients, medication refills, and changes in medication dosage by the provider. And the best way to become great at documenting is to practice, practice, practice. Thank you. See you next time. This begins Chapter 2, Lesson 2.3. Bloodborne diseases. The biggest threats to healthcare workers are hepatitis B, hepatitis C, and HIV. Hepatitis is much easier to transmit than HIV. The chances of contracting an infection after a needle stick for hepatitis B infected blood is 6% to 30%. For hepatitis C infected blood, it's about 2%. And HIV infected blood is only 0.3% after a needle stick injury and 0.09% after a mucous membrane exposure. Hepatitis B is an infection of the liver caused by the hepatitis B virus, HBV. The most common means of transmission in a healthcare setting are through blood or blood components, such as serum or plasma. Healthcare workers are the most likely to contact Hep B through needle sticks. Again, that's a 6 to 30% chance of developing, and then cuts with contaminated sharps. Post-exposure prophylaxis. After exposure to hepatitis B virus, appropriate and timely prophylaxis can prevent HBV infection and subsequent development of chronic infection or liver disease. The mainstay of post-exposure prophylaxis, or PEP, is the hepatitis B vaccine, but in some circumstances, hepatitis B immune globulin can be recommended in addition to the vaccine for added protection. The hepatitis B vaccine, employers must offer the vaccine series free of charge to all employees within 10 days of their initial employment, and also anybody who has had or will have occupational exposure. Exceptions are if the employee has previously received the vaccine series, if the employee is immune to Hep B, and this would be proved with a blood titer test, if the vaccine is contraindicated for medical reasons, or any employee who declines must sign a waiver, and this is filed in the employee's OSHA record. And any employee who declines may later request the vaccine at any point in time, and they can receive it free of charge. Hepatitis C is an infection of the liver caused by the hepatitis C virus. There is no vaccine available for prevention of hepatitis C. The most likely means of contracting in a medical office would be a needle stick or other sharp injury. Chance of contracting is much lower than hepatitis B. It's down to about 1.8%. And 15 to 25% of people clear the virus from their bodies without treatment. HIV, human immunodeficiency virus. So first we'll talk about HIV, then we'll also talk about AIDS. Okay, AIDS is the acquired immunodeficiency syndrome, AIDS. This is a chronic disease of the immune system, which eventually destroys the body's ability to fight off infection. And AIDS is caused by the retrovirus known as HIV. It's an RNA virus that inserts a DNA copy of its genome into the host cell in order to replicate. So HIV is the virus and the infection, and AIDS is a condition which actually happens to be stage 3 of the HIV infection. So it's one of the later stages in the infection. So HIV is not transmitted through casual contact, such as hugging a family member, holding hands, anything like that. It's spread primarily through sexual contact, sharing needles with infected individuals, and untreated HIV-infected women can transfer to their infant during their pregnancy, during birth, and through breastfeeding. The risk of AIDS is low to health workers. The risk after exposure is 0.3%. So that means 1 in 300 workers who is exposed will contract it. Because HIV is unstable, it's not easily transmitted that way. But it's extremely serious, so it warrants strict adherence of OSHA bloodborne pathogen standard by all healthcare workers. Most HIV carriers are asymptomatic. They may be unaware of their infection. Precautions minimizing risks of exposure to blood and body fluids should be taken with all patients at all times. So this is what we mean by standard precautions. It's a means of protection from all bloodborne pathogens such as HIV, hepatitis B, hepatitis C. And it's standard because we use the same exact level of protection with every single patient that we come in contact with, regardless of whether we know what their status is, HIV, Hep B, Hep C. You basically treat every patient as if they have it. So this is from the CDC. If you download the slides, you can click on the link to get more information regarding the CDC's HIV and occupational exposure. So the risk of occupational HIV transmission varies by the type of exposure, but if you get splashed with bodily fluid that is HIV infected, it's pretty near zero to actually get transmission, even if there's blood in them. If fluid splashes to intact skin or mucous membranes, extremely low risk, even if blood is involved. And if you get a percutaneous needle stick injury, it's still less than 1% likely that you will be transmitted HIV. Okay, let's watch some videos.
The name HIV almost always refers to HIV-1, the more virulent and infective type. The human immunodeficiency virus, or HIV, targets cells of the immune system. When the immune system starts to fail, this is termed immunodeficiency. In the final stage of the disease's progression, a patient is said to have acquired immunodeficiency syndrome, or AIDS. AIDS is not the virus, but rather a set of symptoms that result from the virus. It is defined as either having a T-cell count below 200 cells per millimeter cubed of blood, or as having HIV and at least one opportunistic infection associated with AIDS, regardless of T-cell count. An opportunistic infection is an infection caused by pathogens that would normally not be a problem, but which take advantage of an opportunity, such as a compromised immune system. HIV targets CD4 positive cells, in other words, cells that bear the CD4 glycoprotein on their membrane, such as regulatory and helper T cells, monocytes, macrophages, and dendritic cells. CD4 is a co-receptor of the T cell receptor, allowing T cells to communicate with antigen-presenting cells such as dendritic cells. In order to understand how HIV impacts the immune system, we must first understand the difference between innate and adaptive immunity. The innate immune system consists of generalized barriers to pathogenic invasion. This includes physical barriers like your skin, cell-destroying stomach acid, the inflammatory response, and cells like macrophages, neutrophils, and mast cells that recognize molecules common to pathogens. Meanwhile, the adaptive immune system brings out pathogen-specific weaponry. This response is thanks to B and T cells, which recognize antigens, bits of a pathogen that allow for its recognition. When dendritic cells, a type of antigen-presenting cell on the bridge between the innate and adaptive immune systems, enter lymph nodes, B cells produce antibodies to bind the specific invader, marking it for destruction by other cells. There are 4 kinds of T cells, and the relevant ones here are cytotoxic and helper T cells. Cytotoxic T cells bind and lyse the pathogen. Helper T cells are necessary for the activation of both cytotoxic T cells and B cells, so without them, the adaptive immune response can't be activated. Antibodies don't get produced and infected cells aren't lysed. Unfortunately, helper T cells are CD4 positive and the main target of HIV. As the infection progresses, there is a substantial loss of these cells. The immune system fights back by producing more T cells, some of which differentiate into helper T cells. This fight for supremacy continues for years, until the virus eventually tips the scales. The body loses its ability to produce T cells, and even the weakest pathogens become problematic.
If you like this video, please like and subscribe. It would help.
Here's part 2.
HIV is a single-stranded positive-sense enveloped retrovirus. Each virion is made up of a lipid bilayer with a capsid inside it containing 2 copies of an RNA genome, as well as reverse transcriptase, protease, and integrase. The viral envelope is derived from the lipid bilayer of a host cell and has glycoproteins sticking out of it necessary for the virus to infect cells. These glycoproteins, GP120 and GP41, together form GP160. A trimer with 3 pairs of GP120 and GP41 glycoproteins forms an envelope spike complex. The capsid is a protein shell that protects the genome. Reverse transcriptase, integrase, and protease get to work once HIV is inside a host cell, and we'll get to that soon. First, let's follow HIV's life cycle. Infection most commonly results from sexual contact, though it is also possible to contract HIV from contaminated needles or, in rare cases, from blood products such as blood transfusions. It is also possible for babies to get HIV from their mothers while in utero or from breastfeeding. Fortunately, you can't get HIV from casual contact, the air, water, or mosquitoes. How does HIV enter cells? GP120 binds the CD4 glycoprotein. This triggers a conformational change that exposes binding sites for a coreceptor, either CCR5 or CXCR4. CCR5 is found on T cells, macrophages, monocytes, and dendritic cells, while CXCR4 is found exclusively on T cells. Anyway, further conformational changes reveal the fusion peptides of GP41. These fusion peptides are inserted into the host cell membrane, and HIV's viral envelope can now fuse to it. The presence of both the CD4 glycoprotein and its coreceptor are essential for HIV to enter a host cell. Since almost all HIV-1 isolates are successfully transmitted using the CCR5 coreceptor, people with homogeneous mutations in their CCR5 are basically immune to HIV, and even heterozygous mutations can slow the infection's progression. HIV's single-stranded RNA gets reverse transcribed by reverse transcriptase into a double-stranded piece of DNA. As the reverse transcriptase goes about this process, the capsid uncoats. The double-stranded piece of DNA associates with integrase and is brought into the nucleus. There, integrase integrates the HIV DNA into the cell's genome. This DNA is termed proviral DNA, and viral RNAs get transcribed from it. Many other retroviruses wait until mitosis, when the nuclear membrane is broken down, to get their genome integrated. But HIV interacts with proteins of the nuclear pore and gets admitted. Once HIV's proviral DNA is integrated into the host cell's genome, it cannot be eliminated except by killing the host cell. The viral DNA is transcribed and translated into viral polyproteins, which move to the surface of the cell and form an immature HIV. This HIV pushes itself out of the cell, grabbing part of the cell's membrane to form the viral envelope. Protease comes in and cleaves the polyproteins at 9 cleavage sites to create mature protein components. And now we have a new HIV virion.
If you like this video, please like and subscribe.
And here's part 3.
There are 3 stages of HIV infection: the acute infection, the chronic or latent phase, and AIDS. The acute infection begins when HIV enters the body and establishes an infection. Some people get no symptoms during this period, though typically there will be flu-like or mononucleosis-like symptoms that decline over 1 to 2 months. Initially, replication occurs within immune cells at the site of infection, or in peripheral blood mononuclear cells. At the start of the infection process, HIV is usually R5 tropic, or M tropic. Viral tropism is viral preference for particular co-receptors. M-tropic HIV is a strain of HIV that enters and infects cells that have CCR5 co-receptors. So again, T cells, macrophages, monocytes, and dendritic cells. HIV is infamous for its high rate of mutation. HIV's RNA is about 9,200 nucleotide bases long, and reverse transcriptase introduces a mutation about once per 2,000 incorporated nucleotides. With the rate of viral replication being so high, a second strain of virus sometimes develops, X4 tropic or T tropic HIV. T tropic HIV binds to the CXCR4 coreceptor, which is found exclusively on T cells. This is very bad news, as it speeds up viral progression. M-tropic and T-tropic strains can coexist in the body. There is also another reason why HIV might start off as M-tropic and eventually develop into a T-tropic strain. CCR5 is generally expressed by memory T cells, while CXCR4 is expressed by naive CD4 T cells. Normally, memory cells divide about 10 times faster than naive CD4 T cells. Hence, T-tropic virus would be disadvantaged during early infection. However, as the disease progresses, naive cell division is as frequent as that of memory cells. That is when there tends to be a shift in tropism. Sentinel dendritic cells in mucosal tissue are one of the first cell populations that HIV encounters during sexual transmission. They are important in establishing a successful host infection from a small viral pool. HIV cannot productively infect the dendritic cells, since they have low levels of the receptors HIV needs to enter, and HIV gets degraded if internalized. However, dendritic cells capture virions that are later transmitted to T lymphocytes. HIV's GP120 sticks to the adhesion molecule DC sign and other C-type lectin receptors on the surface of dendritic cells. The virus is carried around in deep folds in the dendritic cell's surface. Dendritic cells travel to the lymph nodes, where there are tons of T cells, HIV's ideal target, and the HIV begins to spread like wildfire. One way in which dendritic cells can transfer HIV to T cells is via an infectious synapse, in which the dendritic cells concentrate intact virions at the point of contact with a T cell, and induce recruitment of CD4 and CCR5 on the T cell. The bulk of CD4 positive T cell loss occurs in the first few weeks post-infection. The greatest number of casualties occur in the intestinal mucosa, where most of the body's lymphocytes occur, and where the majority of T cells express the CCR5 co-receptor. There is now a big spike in HIV replication and the amount of virus in a patient's blood. At this time, there can be several million viral particles per milliliter of blood, and there is a large drop in circulating helper T cells. This acute viremia, in other words, virus presence in the blood, typically results in the activation of the CD8 positive cytotoxic T cells, as well as B cells. The cytotoxic T cells kill infected cells, and B cells produce antibodies. This counterattack lowers the amount of viral replication. T cell counts rebound, though not to pre-infection levels. The infected individual now enters the chronic phase. During the chronic stage, little virus is detectable in the peripheral blood. However, HIV continues to replicate, causing general immune activation. Dendritic cells secrete inflammatory cytokines and interferons, which alter T cell proliferation and differentiation, contributing to the immune dysregulation characteristic of the chronic stage. However, the immune response to HIV is not strong enough to stop viral replication from continuing within the lymphoid tissues. Meanwhile, macrophages serve as long-lived reservoirs of virus, resistant to drug treatments and to attacks from the immune system. Infected macrophages accumulate large internal vacuoles containing virus. These vacuoles can lounge about inside the macrophage or travel into the plasma membrane, releasing their viral content into the extracellular space. Reasons for dropping CD4 positive T cell counts differ in the acute and chronic stages. After initial infection, T cell depletion results from HIV-induced cell lysis and the killing of infected cells by cytotoxic T cells. However, at the chronic stage, generalized immune activation combined with the gradual loss of the ability of the immune system to generate new T cells results in a slow decline in T cell numbers. And now we come to the final stage of HIV infection, AIDS. A healthy level of T cells is 500 to 1600 cells per millimeter cubed. When T cells fall below 200 cells per millimeter cubed, the immune system is severely compromised. With emergence from latency, there is a loss of normal lymph node architecture, resulting in persistent generalized lymphadenopathy. Opportunistic infections become common. Apart from weight loss, chills, fatigue, and a persistent fever, AIDS patients suffer from constant diarrhea from infectious parasites, recurring pneumonia, and fungal infections. Certain cancers that are normally rare, such as Kaposi's sarcoma and non-Hodgkin lymphoma, start to cause lesions of skin and other soft tissues. In the end, people don't die from HIV. They die from infections that a healthy immune system would fight off. Although there is currently no cure for HIV, antiretroviral medications can manage levels of HIV, keeping T cell counts high enough to prevent the infection progressing into AIDS. This treatment is not a single medication, but a combination of drugs. Without treatment, the average survival time after infection is 11 years, and after diagnosis of AIDS, 3 years. With daily access to medication, HIV-positive people can expect to live almost as long as those without the virus, and are less likely to infect others.
If you like this video, please like and subscribe. It would help me make more.
Okay, so that ends our lesson 2.3. Students, this is Ma125, Introduction to EKG. So, EKG was invented by Willem Einthoven. He was a Dutch doctor and physiologist and a brilliant scientist. He invented the first EKG machine in 1903 and received the Nobel Prize for Medicine in 1924. EKG terminology. We're going to talk about electrocardiography. That is the process of recording the electrical activity of the heart. Electrocardiograph is the instrument used to record the electrical activity of the heart. And electrocardiogram is the record of the electrical activity of the heart. It's the contraction of the heart muscle, which is the myocardium, with rate and rhythm, which is the time required for the electrical impulse to travel through the heart. And it's usually abbreviated EKG or ECG. So, is this an electrocardiogram, graph, or graphy? This is the machine that we use here in the lab. That is the electrocardiograph. Is this an electrocardiogram, electrocardiograph, or electrocardiography? This tracing is the electrocardiogram. It's the record of the electrical activity of the heart. Would this be electrocardiogram, electrocardiograph, or electrocardiography? This is the process of recording the ECG, the electrocardiography. So this person performing the test could be called an electrocardiographer. Why do we use it? To collect baseline information to complete during a physical exam, often before surgery to assess the cardiac risk during surgery or find any underlying cardiac disease. Definitely to evaluate symptoms such as chest pain, shortness of breath, dizziness, or palpitations. It can detect an arrhythmia or abnormal heart rhythm, and it can detect cardiac ischemia, which is inadequate blood flow. It can diagnose damage from a myocardial infarction, which is a heart attack, can determine presence of hypertrophy, which is enlargement of the heart, can detect myocarditis, inflammation of the heart muscle, and it can detect pericarditis, inflammation of the lining of the heart. Assess effect of different drugs on the heart and determine the presence of electrolyte imbalances, can assess progress of rheumatic fever, and detect congenital heart defects. The limitations are it is often used in combination with other things to obtain a complete assessment of cardiac functioning because it cannot detect all cardiac disorders. It cannot always detect impending heart disease or predict the future. It only records about 10 seconds of the heart's electrical activity, so it may not detect intermittent arrhythmias. The test is performed while patient is in a resting state, and a lot of times symptoms do not appear at a resting state. And it's usually used in combination with the patient's symptoms and health history, physical exam, and additional diagnostic and laboratory tests. What is the medical assistant's role? The MA is frequently responsible for recording EKGs in the medical office. So the MA must have knowledge and skill in patient preparation, operating the electrocardiograph, identifying and eliminating artifacts, which is interference on the EKG, and the care and maintenance of the electrocardiograph. Several types of electrocardiographs are available. Can have single channel or multi-channel, and the type used will depend on the specialty and preference of the clinician. Most medical offices use a multi-channel electrocardiograph with 3 channels. The 3 basic tools that we need to successfully run an EKG are the electrocardiograph, the machine, you need electrodes, and you need lead wires. So the machine is electric or battery powered, and it reads and interprets the electrical and mechanical activity of the heart. The electrodes are sticky pads that adhere to the patient's skin and sense the electrical and mechanical activity. And then the lead wires are connected from the electrodes to the electrocardiograph to allow the information to go from the patient to the electrodes through the lead wires into the machine where it can be evaluated. Electrodes are also known as sensors, and they are sticky with a tab that is not sticky. The sticky part directly adheres to the patient's skin and picks up the electrical impulses given off by the heart. The conducts impulse into the EKG unit through the lead wires, and usually they are disposable, single use. They contain an adhesive for firm adherence to the patient's skin without adhesive on the tab to allow attachment of the lead clip. And the adhesive contains a thin layer of a metallic substance, which is a good conductor of electricity. Metal conducts electricity, right? So in this one, this is the electrode sticky part, and this is the non-sticky tab. Here it is again with an alligator clip attached, hooked onto the non-sticky tab. And usually sometimes they'll have a backing that you take off, like a sticker. And here's the electrolyte and adhesive gel on the electrode, and no electrolyte or adhesive on the tab. So again, they contain an electrolyte gel. That's a chemical that helps conduct the electrical current, as skin is a poor conductor of electricity. They come in a foil-lined pouch to keep them safe from the light and heat. And each pouch usually has 10 cards like this inside. And each card contains 10 electrodes. 1, 2, 3, 4, 5. 5 more on this side. They'll break apart in the middle. The foil-lined pouch preserves moisture to prevent electrodes from drying out, because dried out electrolyte gel is unable to transmit a good EKG signal. So the MA should check the electrode expiration date before applying. Also, you should look at them and see if they're dried out or crusty or discolored, then they probably went bad. You want to store the electrodes in a cool area away from heat and light. And once you open them, cut them open, should store them in a sealed bag. The term lead can have two different meanings. The lead can be the actual wire connected to both the electrode and the machine, or it can also be an electrocardiographic picture of the heart. So we're getting different pictures of the heart during the EKG. Those leads provide different photographs of the heart's activity by looking at the heart electrically and mechanically from different directions or orientations. And this creates a tracing of the electrical activity of the heart between two electrodes. Each lead provides an electrical photograph of the heart's activity from a different angle. So the more leads you have, the better the chance of recognizing abnormalities. So there are different ways to run EKGs with different quantities of leads, but the more you have, the better pictures you'll get, the more pictures. So you can have a single channel EKG unit with only one lead recorded at a time, which gives one view of the heart, and you'll get just a one single tracing. Or a multi-channel EKG unit, which records multiple leads at a time, gives multiple views of the heart, and it's used most often to record an EKG. So this one has, looks like 1, 2, 3, 4, 5, 6. This is a 6-lead electrocardiograph. Here in the lab, we have 12-lead EKG machines. This is a standard multi-channel, and it uses 10 electrodes, which is why there was 10 per card, and 10 lead wires to give you 12 different views of the heart from 12 different angles. And what we see on the page is a waveform, which is basically a 3D view of the heart. By seeing all the different leads together, you can get a good view of the heart from all different angles. And this helps locate potential problem areas. So I worked with a cardiologist once who would just say, can you get a 12 lead on the patient? So he wouldn't even say the word EKG or the acronym AKG. He just wanted 12 different views of the patient's heart. So you might hear it referred to that. The lead wires, there's 10 of those usually on a 12 lead machine, and they're connected to clips, and then it hooks directly into a hub and then directly into the machine, into the electrocardiograph. Each lead wire has a specific designation and code, which labeled according to where they should be connected. And so you can see different colors here on each one. And then this part here is the connection for a clip. We have alligator clips and we have banana clips in the lab. So hopefully you'll get a chance to use with both. The alligator clip must lay flat and make good contact with the electrode to get a good quality EKG. Lead wires and clips are fragile, so you want to handle with care. So creating an EKG. You've got your electrodes, your lead wires, the cable connecting to the electrocardiograph with an amplifier and a galvanometer, and the heated stylus. There should be a power cord, but often they have batteries in them as well. So how is it created? Electrodes are placed on the patient's limbs and chest, usually upper arms and calves, and then the chest. You can use the ankle or the wrist instead of the upper arms or the calves. And teeny impulses given off by the heart are transmitted to the EKG unit through the electrodes, to the clips, to the lead wires, to the hub, etc. And the current travels to the amplifier inside the unit, which is required to amplify the electrical impulses because they are very tiny. The galvanometer then transforms the amplified electrical impulses into the mechanical motion, and the stylus, which is a heated pen-like instrument, moves on the thermal paper, recording the electrical activity of the heart. Some machines can be linked with the office computer and go directly into the electronic medical record. Typically, it's wirelessly. It just connects over the Wi-Fi, or you could actually plug in the machine through a USB port to a computer. And then a digital image of the EKG is sent to the computer, where software analyzes it and displays the result on the screen. And then it's stored in the patient's chart in their EMR. And copies can be printed out as needed. And the report is reviewed and interpreted by a physician. Depends on where you are. Sometimes it might be just the ordering physician. You would perform the EKG and then just give it back to them or send it to them to review. Where I work at PAMF, actually all EKGs get reviewed by a cardiologist, and they make the final interpretation. And when they do that and result it gets sent back to the ordering provider so that they can use the results to diagnose or treat their patient. So the tracing must be interpreted by a provider. I'm going to say provider because not always has to be a physician. You could have a nurse practitioner or a physician assistant interpreting it. And also, in the ER or on an ambulance, you could have a paramedic or a nurse also interpreting the EKG. But for our purposes, we're always going to be giving that result typically to somebody, to a physician or a provider. Medical assistants cannot interpret an EKG, but we must be able to identify artifacts on the EKG tracing, which are irregular and erratic markings on the printout. This is an artifact right here. It's electrical interference caused by the patient's tensed muscles. So again, MAs cannot interpret or result EKGs. We do need to know how to understand them though, because if you are performing one and the patient's having a heart attack, you need to know what that looks like so you don't just say, okay, you're good to go and send them on their way, right? So that's what we're going to learn how to do. Minimal preparation is required. If you get the chance to provide the patient with instructions prior to the test, before they're coming in, so maybe they call and say, I need an EKG for a pre-op clearance, or, this doctor ordered one, when can I come for it? if you say, schedule them an appointment to come for it the next day, maybe, you would let them know not to apply body lotion, oil, or powder. That is a typo there. It should be powder on the day of the test, because it can cause the electrodes to come loose, or they won't even stick at all and attach properly. You're going to advise them to wear a shirt or blouse that can easily be removed or even just unbuttoned. And then also they should not wear tights or leggings or tight pants, because usually they have to pull up the bottom of their pants to apply the lower limb leads. You're going to put them in a room that should be quiet, private, and a comfortable temperature, and also away from any large machinery or electrical interferences. So, important to get a good tracing. The patient should be relaxed and comfortable. You can help them relax by explaining the procedure. It always helps if you ask them if they've had it done before. If they have, then you can just remind them of these points, but if not, they may be very nervous or scared. So you're going to let them know that it's a painless, non-invasive procedure that records the electrical activity of their heart. You're going to place sticky tabs along their chest and limbs, or arms and legs. And their body and the machine will be connected by wires, but absolutely no electricity will be going into their body. And the actual test itself only takes a few seconds, and it's the setup that takes the most amount of time. And you're going to enter their data into the machine, into the electrocardiograph, and you always want to turn so that you're facing the patient, and you can verbally confirm all data with them as you're entering it. You're going to have the patient remove clothing from the waist up and provide female patients with a gown or a cape. Or, as I said, if they have a button-up shirt, they can leave that, they can unbutton it. And the gown or cape should open in the front so that you can access where you need to put the chest electrodes and leads. You're going to ask the patient to remove their shoes, but they can leave their socks on. And the lower leg must be uncovered and easily accessible. That's why restrictive pants, socks, and tights are not easy to get around. Might have to remove those. And you're going to have them remove all jewelry and electronics. So watches, belts, keys, cell phones, and pockets. These can all cause electrical interference. I've also found that patients' glasses can do that as well. So you might have to have them take those off as well. If they don't have a purse or a bag that they can place those items in, you can put a towel down on an exam room counter and have them place everything there so that they can see it. You're always going to make sure you ask if they have any questions before proceeding, and ask if they need to use the restroom, because if they have to go really bad, they're not going to be relaxed and comfortable during the test. You're going to offer them the option to lay down and pull out the footrest if they're on an exam table. Offer pillows to support their head and feet, and offer a blanket to provide warmth if they're cold, and especially if they're half undressed. And you're going to allow them time to undress. So you might have to assist them into the supine position, which is laying down flat on the back. And you're going to properly drape the patient to prevent exposure so that they are not uncomfortable. The arms and legs must not dangle off the table. So you're going to make sure they have their arms at their side and that they're not hanging off the table, and put out the footrest so that their legs aren't dangling off the table. This will prevent artifacts. Patients who have back pain or difficulty breathing laying down flat can be placed in the Fowler's position. That is this one right here, which is with the back of the table up and the patient's back at a 45-degree angle. Before running the test, you're going to ensure that the patient is comfortable. You're going to ask them to relax and lie still, but breathe normally. A lot of times people will try and hold their breath while they're taking the test, and that is not going to give you a good result. So remind them to just breathe normally, and they should not be talking. So sometimes you have to tell patients, please hold off on talking for now. I'll be happy to answer your questions after the test is complete. So hairy areas may need to be shaved, and that's only if you're having difficulty getting the electrode to stick onto the patient's skin. So it's not something that we do routinely anymore, but sometimes it is necessary. You oftentimes will clean the placement areas with a skin prep pad ahead of time before placing the electrode on. So depending on your site's policy, you might use something like a benzalkonium chloride antiseptic towelette. Some people use alcohol. There's kind of conflicting data on whether or not that might actually interfere with the electrical impulse transmission through the electrode. So I'm going to leave that up to wherever it is that you're working and performing the EKG, whether they're going to have you prep the patient or not, and what they're going to have you use. You're always going to want to start with the arms and legs first and explain to the patient why you're using the skin prep pad and warn them that it might be cold. And this kind of shows them what to expect before you put the electrodes on and the leads. So 10 electrodes are placed all over on the limbs and chest. 4 of them are on the limbs, so 2 on the arms and 2 on the legs. You're going to place the limb electrodes first. I usually place them on the fleshy parts of the upper arms, and then on the fleshy part, kind of on the calf, on the lower legs. And the tabs of the electrodes should always be facing the belly button. So if you're placing them on the arms, the tabs should be facing downward. And if you're placing them on the legs, the tabs should be facing upward. You're going to put 6 electrodes on the chest, and these are placed at very specific points along the chest. And the tabs should be facing downward toward the belly button. And you're always going to ask permission before you touch a patient at all, especially on the chest area. And you're going to explain to them why you need to do this using non-medical terms. So you're not going to say, I need to palpate you or anything like that. You're going to ask, is it okay if I feel around on your chest so I can find the right place to put the electrodes? So the limb electrodes, a little bit more flexible as far as the placement. Okay, we talked about even ankles or wrists, or it could even be upper shoulder if you needed to for some reason, or even upper thigh, but ideally calf and fleshy part of the arm. So the leads will be labeled. So you'll have one labeled LA for left arm and one RA for right arm. Another one will be LL for left leg, and another one will be RL for right leg. The right leg is the grounding electrode. Okay, see how that one's green here? Right leg. So that means that it's never actually used for the EKG tracing. So it's never actually transmitting electrical impulses to the machine. It is simply there to have an exit point for the electricity in the case of some sort of electrical surge, that the patient does not get electrocuted. So it is absolutely necessary to have the right leg electrode and lead hooked up to obtain the tracing, but you should know that that is the grounding electrode. Again, you're going to apply the limb electrodes first, right arm, right leg, left leg. Okay. And like I said, those don't have to be exact. Usually we put it on the fleshy part of the calf muscle and the outside of the upper arm. But sometimes the patient might have things going on anatomically or could have an amputation, and that might not be possible. So you can be flexible with the limb electrode placement and work around the patient's specific situation. But yes, that is my preferred placement for leg electrodes, not directly on the shin bone, okay, because bone is not a good conductor of electricity, but muscle is. So just medial of the shin bone on the most fleshy part. Also, if you can get it on the side here, they might have less hair to interfere. The 6 chest electrodes are also often known as the precordial leads, and they are called V1, V2, V3, V4, V5, and V6. And these electrodes must be placed at their specific correct locations in order to get an accurate tracing, and they must be placed in the right order. So this is going to be your map for the chest electrode placement. I'm going to take a quick pause there before we talk about that. Okay, we're going to pick back up here with the chest electrode placements. Oh, whoops. There we go. V1 goes in the 4th intercostal space, just to the right of the sternum. So that'll be the patient's right. Usually you'll be looking at them opposite, so it'll be to the left of the sternum from your view. It's the patient's right. V2 goes directly across from that in the 4th intercostal space, right? The intercostal space is in between the ribs. So we have the first space, right? First rib goes underneath the collarbone, right? First rib, first space right below it. Second rib, second intercostal space right below it. Third rib, third intercostal space. Fourth rib, fourth intercostal space here. So in the 4th intercostal space, just to the patient's left of their sternum. V3 goes midway between V2 and V4. V4 goes in the 5th intercostal space on the left mid-clavicular line. So you're going to locate the clavicle on the patient's left side, right? And you're going to find the sternal notch, and you're going to find the acromion process, and you're going to then locate the middle, so the mid-clavicular line right in the middle, and you're going to just draw an imaginary line down until you hit the 5th intercostal space. That's going to be V4. V5 goes in the 5th intercostal space on the left anterior axillary line, midway between V4 and V6. And V6 goes also in the 5th intercostal space in the left mid-axillary line. So mid-axillary would be finding the center of the axilla or the armpit and then drawing a line down from the middle there. And you'll notice that it kind of makes a little C curve here around the patient's heart, because even though all 3 of these are in the same intercostal space, the ribs curve around the chest, right? Okay, when you're charting the EKG here in the lab, you're going to make sure you put the date and time, the test that was performed, and here we're going to be doing 12 lead EKG, any observations or patient reactions, and who the report was given to, and then your sign off. So your name and your credentials. So first initial of your first name, your last name, comma, and then you will be SMA for student medical assistant. Caring for the EKG machinery. So when you're done, you're going to make sure you clean it with a soft cloth and mild detergent if it got soiled. That would be to remove any surface dirt and dust. You're not going to use any commercial solvents or abrasives because that may damage the finish of the machine. You're going to clean the lead wires and the cables and the power cords regularly with a cloth moistened with disinfectant cleaner. Never immerse the cables in cleaning solution as they are electrical. Inspect the cables frequently for cracks or fraying and replace if needed. We do have extras here in the lab. If any of them, sometimes the casing will crack open. And you're going to check and clean the clips after each use. So you're going to clean them with an alcohol wipe because gel from the electrode can interfere with the transmission. And you're going to be sure that the clips fit snugly on the metal tip of each wire. Okay, we'll take a break there and pick up back with Holter monitors on our next lecture. 1. The Holter monitor is a portable ambulatory monitoring system that records the electrical activity of the heart for typically at least 24 hours, but it could also be 48 hours or even longer than that. It depends on the type of monitor. And it can detect cardiac abnormalities. It can also detect the absence of cardiac abnormalities, which can be very important in ruling out certain diagnoses. And these can occur while the patient is engaged in normal daily routine. And the monitor is designed so that the patient is able to maintain daily activities with minimal inconveniences. So it's similar to a resting EKG in that the electrical impulses given off by the heart are picked up by electrodes and transmitted through lead wires to a recording device. But it's different than a resting EKG because with a resting EKG, only about 10 seconds of the heart's activity is recorded. So it's a very quick and brief snapshot. And the Holter monitor records the heartbeat continuously for an extended period of time. So you can catch a lot more and get a lot more information from a Holter monitor. They are typically lightweight and battery powered and can be clipped onto a belt around the waist, such as this gentleman here, or hung with a strap around the patient's neck, or they can wear it like a purse. And it usually is set with a timer and automatically stops recording after the monitoring period is completed. So depending on what the provider ordered, it might shut off at 24 hours or 48 hours. Or we'll look at some at the end of here that are actually wireless and look like Band-Aids, and you leave them on for as long as they'll stick on. So sometimes 10 to 14 days. And these are used to diagnose cardiac rate, rhythm, and conduction abnormalities, most frequently to assess the rate and rhythm of the heart during daily activities. They can evaluate unexplained chest pain, dizziness, or syncopal episodes, and discover arrhythmias that are not picked up on a routine 12-lead EKG, because a Holter can record approximately 100,000 heartbeats in a 24-hour period. So it's a lot more information. They can detect myocardial ischemia, and assess the effectiveness of medications, especially antiarrhythmic medications. Oftentimes, medical offices will have their own Holter monitors that the MA will be responsible for preparing the patient, applying and removing the monitor, and instructing the patient in the preparation requirements and the guidelines to follow while they are wearing the monitor. So you're going to make sure you let the patient know, usually before they come in to have the Holter monitor placed, that they should bathe or shower right before, because they will not be able to until they're done wearing the monitor. So if it's a 24-hour, that's not usually that big of a deal. But if it's going to be one they're going to have on for 48 hours, they usually would like to bathe right before. It's very important that they don't apply lotion, oil, or powder to their chest before or during the test, because that'll make it very difficult to apply the electrodes and for them to stay on. Unless the physician specifies otherwise, they should take all their normal medications at their usual time. And they should wear loose, comfortable clothing. A shirt or a blouse that buttons up and down the front is very helpful for applying the electrodes and then just rebuttoning over the leads and the electrodes. This gives it a much easier application, and it can also prevent the electrodes from rubbing against clothing and becoming loose and coming off. The electrodes are different from the ones we use for the 12 lead for the resting EKG. They're usually thicker and they have foam in them, and they have an adhesive backing, and they are often round or rectangular in shape, and they have an electrode plate and a snap that attaches to the lead wire, and then a central sponge pad that contains the electrolyte gel, And these are disposable, discard after you use them. So here's the electrode snap on this one, and on the other side is the adhesive backing with the sponge pad saturated with an electrolyte to enhance impulse transmission. And here's another picture of it with the electrode plate, which is metal, the sponge pad, and the adhesive backing. Some of the newer Holter monitors use 4 to 7 electrodes, depending on the brand, and these are placed at various locations on the chest. And depending on the number of electrodes and location, there should be a diagram inside the operating manual and on a placement chart. And so each brand of monitor might be designed for a little bit different placement of the electrode. So it's really important to make sure that you're familiar with the type and brand of Holter monitor that you're placing, and that you are placing electrodes in the correct place, and also instructing the patient on that as well, because oftentimes these electrodes will come off or need to be replaced. You can send the patient with replacement ones, and as long as they have the diagram and they are competent, they should be able to reapply it in the correct way to continue their monitoring. Typically, you'll have them keep a diary. There we go. So the patient diary, they should document all activities and emotional states, and specifically with the time that they experienced it. Any physical symptoms experienced during activity should be indicated next to the activity, and then the recordings are compared with the diary to determine if that activity or emotional state or symptom, it correlates or corresponds with anything on the EKG tracing. So if there's any abnormalities, it's very important to note if they are related to the activity or the symptom or the emotional state. It's also very helpful to know if they are not. Okay, oftentimes people will be having symptoms that are unexplained, and you might have a Holter monitor just to rule out any cardiac abnormalities. So that's also very important information to note, and can be very reassuring for a patient that even though they're getting chest pain, there's no abnormalities on their Holter monitor corresponding with that. Now, that doesn't mean necessarily that they're not going to do any further tests, but it can be reassuring sometimes for patients. So here's a sample diary. The person at 7 a.m. took their medicine, had no symptoms. 7:30, ate breakfast, no symptoms. And then driving to work at 8 a.m., they were probably in traffic, so their heart rate sped up and felt fast to them. And then at 9 a.m., they met with their boss, and their heart felt even faster. They were probably getting palpitations. So it's not surprising, but it's important to then be able to look at the tracing at the corresponding time and see if there was any abnormalities there. And here's another diary with the time, activity, and the symptom. So patients should participate in normal everyday activities unless prohibited by a physician or by a provider. And this can determine their heart function during a normal day. So most routine activities can be performed, except those that could damage the monitor, such as showering, bathing, or swimming, water. Those monitors are not waterproof. Also, they want to avoid any vigorous physical exercise that could cause excessive sweating, because that can loosen the electrodes. And it can also cause artifacts, handling or removing the monitor from the pouch, or touching or moving the electrodes or the lead wires. They should not use electric blankets, hair dryers, electric shavers, heating pads, microwave ovens, or an electric toothbrush, because these can all cause electrical interference artifacts on the tracing. If a lead wire detaches from an electrode, they should snap it back on as soon as possible. That's pretty easy. They just snap on and off. And then they should record the information in the diary so it doesn't look like a pause or a abnormality on the tracing. If an electrode comes loose, they can press down around the edges of the electrode and re-adhere it. They can also put tape over it, apply tape to restore the contact like this patient has done, and then recorded the information in the diary. And if the electrode comes off and cannot be replaced, they should contact the office to see what should be done. But typically I send patients home with additional electrodes to reapply as some of them get worn and cannot be re-adhered. So additional activities to record in the diary. Again, physical exercise, walking, housework, gardening, employment-related activities, going up or down stairs. Also periods of inactivity, such as lying down or sitting in a chair. Those can cause your heart rate to drop. So it's important to note what's going on at that time. Driving, smoking, urinating, and bowel movements, meals, especially caffeine and alcohol, sexual intercourse, and anytime you take your medications, as well as when sleeping. That's important to note as well. Patients should also record emotional states in the diary, such as anger, excitement, anxiety, fear, and laughter. And they should always report symptoms such as shortness of breath, chest pain, neck, arm, or face pain, palpitations or racing heart, skipped beats, nausea, vomiting, dizziness, faintness, anything like that. Definitely important to note, as well as any additional symptoms. Some Holter monitors have an event marker button, and this is used along with the patient diary for correlation and evaluation. So the patient should be instructed to depress the button when experiencing a symptom, and then this flags the tracing and records that point in time on the tracing, and then they should record the time and nature of the symptom in the diary. So again, depressing the button places a signal on the recording and highlights it when the patient feels a symptom. So the interpreting provider, it's helpful for them to be able to go right to that point in time and decide if the patient's symptoms are having concurrent EKG abnormalities or not. So tachycardia is an abnormally fast heartbeat, but toothbrushing can also look like ventricular tachycardia, which is quite dangerous and can be deadly. So while wearing a Holter monitor, the patient must record in their diary when they're brushing their teeth. Otherwise, it can look like they were having VTach, which would be major cause for concern. So at the end of the monitoring period, the Holter monitor will be removed, and sometimes they may be coming back into the office to have it removed, or they can remove it themselves and then return it. And then the information on the card is uploaded to a computer. Now, so this can be done in the office if the office has the specialized software to upload it and then review it. So the software will perform calculations on the data and prepare an EKG summary report. This is reviewed and interpreted by the physician, along with the patient's diary for comparison with the abnormalities any present. And then this can be printed out and stored in a paper-based record, or it can be stored electronically in the EMR. So some companies even have a direct interface with EMR so that it goes directly into the patient's chart. Sometimes this can be outsourced, just as a side note, that because all of this, 48 hours or even 2 weeks of data has to be, it actually gets reviewed by a technician, usually by a EKG technician. And they help prepare their summary report for the provider to interpret. And unless the clinic has somebody with those capabilities, this is often outsourced. At PAMF Cardiology, we have a couple companies that we work with, iRhythm being one of them, that they actually take the monitors. The monitors get sent directly to them. They extract the data from the monitor directly, and then they prepare the report and send it to the cardiologist for interpretation. So at the end of the recording period, you're always going to want to remove the battery, and these actually get discarded because we don't ever want to worry about using half-used batteries. And then also you never leave the battery in there because it can damage the monitor and the batteries can corrode. I don't know if you've ever seen that. When you leave batteries in toys and stuff, it can get that white crusty stuff on it. That's corrosion. You're going to clean the casing of the monitor, the cables, and the lead wires using a soft cloth moistened with a mild disinfectant, and clean the snap of each lead wire with alcohol to eliminate any electrolyte gel. And these get stored in a dry, dust-free area. These are pictures of the wireless monitors that we often use. This one right here is the one provided by iRhythm. It's called a Zeo Patch monitor. This is another one called the Pix. I actually haven't seen that in person. But these are really handy because they are wireless. And once they're adhered, after usually the initial 48 hours, they've got a pretty good stick on there, and you can actually take a brief shower with them or work out and maybe sweat a little bit. But the idea is that you get these applied for you, right? A technician applies these so that it's done correctly. And then the patient has a bit more freedom than those traditional Holter monitors with all the wires and the electrodes that come off and on easily. And then these just stay on for as long as they will stay on. So they typically come off, anywhere between 10 and 14 days, but it also depends on the patient's skin and how much they're sweating, and if they're more oily than others. And then when it comes off, they usually they come with a box that's already stamped and self-addressed to send back to the company for the company to analyze the data and then provide the report. So these are really handy devices. Sometimes you'll hear them called Band-Aid monitors because they kind of just look like a big Band-Aid. And they do have that event button on them right here. You can press on it, and it will mark the tracing, just like we showed on the other one. Okay, that concludes the introduction to Holter monitoring. Lecture 10.2, Atrial Arrhythmias. Irregularities in the atrial activity. Our first and probably most common atrial arrhythmia is premature atrial contraction, or PAC. And a lot of times they come not alone, so you might have PACs, plural. So isolated occur singularly, or we might get multiple PACs, which we'll talk about in a minute. So the rhythm is regular, right? Because irregular, because the R waves are not coming at regular intervals. The P wave in the PAC right here is going to be premature and abnormal or completely hidden, like in this one right here. And the PR interval is going to be less than 0.2 seconds and less than 0.12 seconds for the QRS, so abnormal. So the PAC is just a contraction of the atria occurring early. So the beat comes before the next normal beat is due. So it's coming from somewhere outside of the SA node. Somewhere else in the atria is firing and causing the atria to contract sooner than the SA node would like them to. So the P wave is going to have a different shape than that of a P wave of a normal beat coming from the SA node. And then the QRS complex and the T wave are going to appear normal because it does conduct along the conduction pathway normally. So you have your normal rhythm going along here, normal P waves, and then all of a sudden you're getting an early QRS here before it would have come on its own. So these are actually really common and in healthy individuals. Definitely stimulants can increase the occurrence of them, so caffeine and tobacco. But if people are getting a lot of them frequently, It can lead to some serious atrial arrhythmias, and it could be indicative of structural heart disease. But we're talking, a very large amount of PACs in a very short period of time. So typically, they're quite benign and no need for treatment. Atrial tachycardia. So heart rate's 140 to 250, so higher than our sinus tach. Rhythm is still regular, and the P wave is usually very difficult to see because it's hidden in the QRS. So the PR interval is quite short, less than 0.2 seconds, and the QRS is going to be less than 0.12 seconds. So PAT is what we call paroxysmal atrial tachycardia. So paroxysmal just means that it comes and goes kind of abruptly, often without a known cause. So it's an abrupt episode of tachycardia that typically just starts and then stops suddenly. And the atrial rate is going to be 150 to 250 beats per minute. So we're getting into a faster zone there than your typical sinus tach. And it typically only lasts a few seconds, and then the heart rate returns to normal. And of course, the EKG cycles are going to be very close together because they're coming so fast. And then here you can see that the PAT broke and it returned to a nice normal rhythm. PAT is a very common rhythm disorder, and it can often occur in young, healthy patients, especially young adults that have otherwise normal hearts. But it can also occur in patients with heart disease as well. And it's harmless, it's benign, but it can often cause quite severe symptoms during the episodes. So there are treatments that can help the patients who are suffering from those symptoms. So those are sudden pounding or fluttering in the chest, feeling lightheaded or dizzy, getting very breathless or having difficulty breathing, and then having a very acute and severe feeling of apprehension or impending doom is often a symptom that patients will describe. And then they could actually pass out and experience a syncopal episode. So along those same lines is AVNRT, which is atrial ventricular nodal reentry tachycardia, where basically, let's see if I have a picture here. No. Basically, it's similar to PAT, but the conduction pathway kind of gets stuck in a circular loop in the atrium right above the AV node. That's why it's called a reentry tachycardia. Similar, same treatment for the PAT if the patients are symptomatic. Okay, atrial flutter. So this is a very fast heart rate, 220 to 430 in the atrium, and then typically it can be up to 300 in the ventricles. The rhythm it's kind of regular. And the P waves give a very sawtooth appearance. This is a typical A flutter right here where it looks like sawtooth, like a saw. You're not going to have a PR interval per se because there's usually so many P waves for each R wave. So it's pretty much impossible to calculate. And then the QRS is going to be less than 0.12 seconds. So basically, this is when the atria begin beating in a rapid and regular fluttering pattern. Quite fast, right? So you're going to have more than one P wave before each QRS complex, sometimes up to 8 P waves, which creates this sawtooth appearance between the QRS complexes. The QRS complexes are going to be normal, except for the fact that the T wave is usually lost within all those P waves. And then the ventricular rate can vary depending on how many of these, how well these P waves in the atria are actually conducting down the pathway into the ventricles, right? So atrial flutter can occur in patients who have mitral valve disease, CAD, coronary artery disease, chronic lung disease, hyperthyroidism can cause it, pulmonary embolism, alcohol and stimulants, diet pills, cold medicines, caffeine, etc. The most common place that I see it is perioperatively, so either right before or right after surgery. Definitely open heart surgery, that's very common, but it's actually not unusual for people to come up with an A flutter on the monitor, even if they're just having, knee surgery or hand surgery or something too. So similar to A flutter is atrial fibrillation, or AFib. So in AFib, it's extremely irregular, the fibrillation. So that's the main difference between flutter and fib. Is flutter actually is quite regular, but fibrillating waves between the heartbeats are completely irregular and erratic. So the atria is actually quivering in a fluttering motion rather than getting a complete contraction and squeeze. And so it's giving, incomplete, irregular contractions. The rate can be quite high if untreated, 350 to 500 beats per minute. And it's very irregular and erratic. The P waves have no distinct pattern or shape because it's so rapid that they're just not contracting completely. The QRS complexes are normal because once that conduction actually makes it down into the ventricles are able to contract normally, but they're just not going to be regular, and they're not going to have a definite pattern. So the ventricular rate could be rapid, or it could actually be normal, if the intrinsic rate of the AV node and the Purkinje fibers are able to take over. They can regulate the ventricular heart rate. So as you see here, this is actually fairly, normal. It's not fast. It's not tachycardic here. But the P waves are really irregular, and there's no, set amount in between the QRS complexes like we saw in the flutter. So AFib is actually a really common arrhythmia that can occur in otherwise healthy individuals. It's often idiopathic, which means we don't actually know exactly what causes it all the time, right? But it is when there's, some sort of damage to some of the pacemaker cells in the atria. Uncontrolled hypertension can cause it. So we do know that there are a few things that can increase a patient's risk for AFib. Heart disease, pulmonary hypertension. It's not uncommon to have perioperatively, kind of like A flutter. Congenital heart disease, rheumatic heart disease with mitral valve damage, CAD, and then other mitral valve diseases. And then stress, excessive alcohol consumption, and I don't have it on here actually, but a really strong indicator is obstructive sleep apnea, or OSA. So a patient who is untreated and having severe apnea can also can kind of cause their heart to go into AFib. So AFib comes with a high risk of stroke, because as the blood's kind of hanging out in the atriums, because they're not contracting and squeezing completely and pushing that blood down to the ventricles, the blood actually pools up and can form a clot. So there's actually this very small area over off of the left atrium that is prone to blood pooling and clotting in there. So when they finally do get pushed through, then they can, get pushed out to the rest of the body and block an artery, and cause severe complications such as stroke or a deep vein thrombosis, also if it makes its way into a vein. Also, if it's uncontrolled, the heart rates are extremely fast, chronically, then that can cause heart failure. Definitely, people can feel very fatigued. They often feel short of breath, and then it can lead to additional rhythm problems, and it can lead to sudden cardiac arrest if left untreated with a high heart rate for a long time. So typically, let's see if we have the treatment here. No. So typically we would treat a patient with anticoagulation to, quote, thin the blood, unquote, to keep them protected from a stroke or a clot. And then you treat the fast heart rate, usually with antiarrhythmic medications or a beta blocker, something to slow down the heart rate and keep it controlled. And if people are asymptomatic from AFib, which is not unusual, they can actually live, quite a long time with atrial fibrillation, as long as they are protected against stroke with an anticoagulation therapy, and then as long as their heart rates are well controlled and are not going fast chronically, which causes a lot of stress on the heart. So just to look again, because people often get confused between atrial flutter and atrial fibrillation. For flutter, the impulses are traveling in a circular course in the atria. So it's rapid with regular waves. And then with AFib, the impulses are totally chaotic and random. And so the waves are very irregular. Okay. So atrial ventricular block, or AV block, often known as a heart block. There's a lot of different kinds of heart block, so it's kind of a general term, but basically it just means that there's a portion of the conduction system that is slowing or disrupting the normal conduction through the heart. So there's 3 degrees. First degree is the least severe, and it's often no symptoms, and it can be seen in well-trained athletes. And it typically comes along with a prolonged PR interval, so greater than 0.2 seconds. Second degree AV heart block is when the heart can actually skip beats, so the beat is getting stuck at the AV node and not making its way down to the ventricles for them to contract. The PR interval tends to lengthen in each interval. Kind of, if you were to look at these ones before the QRS complex disappears, or the dropped QRS, you'll notice that the PR interval is getting a little bit longer, and then it just doesn't make it at all, and then it might go back to normal right after the dropped QRS. So this can often be treated with a pacemaker to help kickstart the heart wherever it's getting blocked, and then prevent it from becoming worse, or prevent the patient from actually fainting and hurting themselves or somebody else. So third degree, or complete heart block, is when the atria and the ventricles basically are beating just completely independently from each other, and there's no relationship between the P waves and the QRS complexes like there should be. So it severely limits the heart's ability to adequately pump blood out to the body. And so this is typically a quite emergent situation and requires very quick implantation of a permanent pacemaker. So the P waves and QRS complexes are totally independent of each other, but they can be regular. But you have a P wave here with no QRS, Another one here. Okay, so that's the end of lesson 10.2. Hello students, welcome to our first recorded lecture for Ma170. Today we are going to be talking about nutrients. This is lesson 21.1. Okay, so nutrition is the study of nutrients in food, including how the body uses them and their relationship to our health. A nutrient is a chemical substance that's found in food that is needed by the body for survival and well-being. Good nutrition is an important component of health and the well-being of an individual. Inadequate nutrition can result in poor health and cause disease. Medical assistants should have knowledge of basic nutritional principles and the recommended nutritional therapy for common conditions and diseases. While MAs are not qualified to conduct nutritional assessments or recommend nutrition therapy, because this is the responsibility of a registered dietitian usually, or a physician, or other mid-level provider. But MAs should make sure to adhere to these guidelines to stay within the scope of practice for a medical assistance. So medical assistance, it is within our scope of practice to provide education on nutrition therapy once it has been prescribed by a provider, a healthcare provider. Okay, so that's why we're going to spend the whole week this week learning about nutrition. So nutrients, there are 6 classes of nutrients divided according to their chemical structure and role in nourishing the body. There's carbohydrates, fat, protein, vitamins, minerals, and water. So the 3 primary functions of nutrients in the body are to provide energy for the body, build, repair, and maintain the tissues in the body, and assist in the regulation of our body processes. There are 2 different types of nutrients: macronutrients, which are required by the body in large amounts, and then micronutrients, which are required by the body in small amounts. And if you recall some of our basic terminology, macro means large and micro means small. So macronutrients are containing of carbohydrates, fat, and protein. So those are the 3 nutrients that we need in large amounts, and they provide our body with the kilocalories that we need to yield energy to perform our body functions. A kilocalorie, or a kcal, which is often just referred to as a calorie, is a measurement of a unit of energy. So it is the amount of heat needed to raise the temperature of 1 kilogram of water 1 degree Celsius. So it's actually a very specific measurement. That is how we measure quantities of our nutrients. So carbohydrates, which consist of 4 kilocalories per gram, our body uses these as short-term energy. Fat consists of 9 calories per gram. Our body uses this as a more long-term fuel source. And then protein, which is also 4 calories per gram. This is used by the body for building, maintaining, and repairing tissues. It can be also used as an energy source, but our body much prefers to use carbohydrates for energy. It's a much easier process. So micronutrients as we said, are very small amounts that are required by the body. And this includes vitamins and minerals that are not broken down by the body, and they are used in the form in which they are absorbed. Okay, so we'll go back to our macronutrients. Carbohydrates are organic compounds which are made up of carbon, hydrogen, and oxygen. And 45 to 65% of our daily caloric intake should be carbohydrates. Through digestion, carbohydrates are broken down into sugar units and then converted into glucose by the body. Glucose is the chief source of energy for the body, and it's our preferred source of energy for the CNS, or central nervous system. And the body needs to maintain a constant blood glucose level to ensure continuous energy supply. So we've got two different classifications of carbohydrates. Simple, which means that they're made up of 1 or 2 sugar units. Monosaccharides have 1 sugar unit, and disaccharides consist of 2 sugar units. Remember that mono means 1 and di means 2. So these are some examples of simple carbohydrates. Some yummy stuff, but not exactly nutritionally dense, right? So the simple carbohydrates will provide an immediate source of energy for the body because they are very quickly converted to glucose for use as energy. These are found in processed foods and refined sugars such as candy, cake, cookies, pastries, sweetened beverages like sodas, and then just table sugar, syrup, and honey. So these are really empty calorie foods or low nutrient density. So we'll talk more about density later on, which basically means that they're not really doing a lot for us in the long term, right? They're going to give us a really quick source of energy, but they don't contain any vitamins or nutrients that are going to sustain our body functions for a long period of time. They also naturally occur in milk, fruits, and vegetables. So complex carbohydrates, another classification of carbs, is these are polysaccharides. So they're made up of many sugar units strung together in a long chain, right? So compared to monosaccharides and disaccharides, which are simple carbs, the complex ones are made up of much more sugar units. And these come from plant-based foods such as pasta, rice, bread, cereal, potatoes, and legumes, which we have some pictures of here. So complex carbs provide a more steady supply of energy for the body, and that's because of the many sugar units that they consist takes longer for the body to break down. So this leads to a less dramatic rise in blood sugar level. And then the fiber part of it as well, a complex carb consists of many sugar units, and then the fiber can be soluble or insoluble, which we will talk about here. So dietary fiber, soluble fiber delays emptying of the stomach and makes you feel fuller longer. So this can assist in weight control and also helps to lower blood cholesterol and protect against heart disease. So these are some examples of complex carbs that are high in soluble fiber. Insoluble fiber does not dissolve in water, and so it passes through the GI tract intact, and it provides roughage or bulk in the diet. It helps promote normal elimination and prevent constipation, and it reduces the risk of diverticular cancer and then other forms of cancer as well. Okay, so our next macronutrient is fat. This is also known as lipids. These are organic compounds that do not dissolve in water. They're composed of carbon, hydrogen, and oxygen. They do provide long-term energy because our body can store it in unlimited quantities. And there's a big misconception still that fat is bad for the body and it only leads to weight gain, but this is not true. Our bodies need fat, right? The lipids in our blood transport the fat-soluble vitamins that are absolutely important to our good function. And then it also assists in the transmission of nerve impulses, and it provides a very nice insulation and cushion for our organs in the body. So there's different types of fat in our diets. There's saturated, unsaturated, which can be broken down into monounsaturated and polyunsaturated. And then there's trans fat and cholesterol and triglycerides. So saturated fat is primarily coming from fatty animal sources. So bacon, sausage, poultry skin, whole fat dairy products, and then also some plant sources such as palm and coconut oil. And it raises the total blood cholesterol, which we know increases our risk of heart disease. And the American Heart Association recommends limiting saturated fat to no more than 7% of the total calories consumed each day. So that's a fairly small amount. Here's some examples of saturated fat items. Unsaturated fat is primarily from plant sources, and they tend to have a protective effect against heart disease, which is the opposite from the saturated fats. And these should be 2/3 or more of the total fat consumed each day. And there are two types: monounsaturated, which is the most protective against heart disease, and then polyunsaturated. So remember, mono is one and poly is multiple. So trans fat does not occur naturally in our foods. This is formed from hydrogenation, which means we're adding hydrogen ions to unsaturated fat, which then turns it into a specific saturated fat called trans fat. So this is a chemical process that is done, in the food factories, etc. So it makes these fats more stable and less likely to turn rancid. So it extends the shelf life of processed foods. And it also gives food a more desirable taste and texture. But it raises the total blood cholesterol, and so no more than 1% of our diet should be trans fat. Cholesterol is actually not a true fat. It's a white, waxy, fat-like substance that is absolutely essential for normal body function. So it's an important component of cellular membranes. It's used in the production of hormones and bile. A portion of it is also manufactured by the liver. And other portion comes from diet, so our dietary cholesterol. That is only found in animal products. And we do know that high blood cholesterol can cause atherosclerosis, which is a buildup of fatty deposits on the walls of arteries all over the body. Triglycerides, this is a chemical form in which fat exists in food and the body, and it's derived from the synthesis of the food by the body. So excess glucose or protein in the body is synthesized into triglycerides and then stored as adipose tissue. Some of it remains in the bloodstream and our major source of energy for the body. But excess triglycerides in the bloodstream increases the risk for heart disease, and actually extremely high levels of triglycerides causes pancreatitis, which is never good when the pancreas shuts down. So we want to keep an eye on our triglycerides as well. Protein, this is our last macronutrient. It contains nitrogen in addition to the carbon, hydrogen, and oxygen that is in fats and carbohydrates. The nitrogen enables protein to build, maintain, and repair body tissues. So this is the primary structure in making up muscle, bone, skin, hair, enzymes, antibodies, and hormones. So it's really important to the function of our bodies. It also aids in fluid balance and muscle contractions. And the amount of activity that we perform each day determines our individual protein requirements. So some people, their bodies require a much higher amount of protein than others depending on what they're doing. So amino acids are smaller units of protein, and that is how protein is broken down through digestion. So the amino acids are arranged in different combinations depending on where they're being used by the body. But these are often referred to as the building blocks of life. There's 20 of them. 9 of them are essential and cannot be made by the body. They must come from the food that we consume. 11 are non-essential because these can be synthesized by our own bodies. So you want to pay close attention to the 9 essential ones, right? And make sure that you're including those in your diet. So a complete protein contains all the amino acids that are needed by the body. And the sources include animal-based foods. So we've got milk, chicken, steak, fish, eggs. An incomplete protein lacks 1 or more of the 20 amino acids, and those are sourced from plant-based foods. Now you can have complementary proteins, which are 2 or more incomplete protein sources that combine to include all of the essential amino acids. Okay, so vitamins are micronutrients. This is an organic compound required in small amounts for normal growth and development. They occur naturally in foods and also may be added to processed foods to increase their nutritional value. Most vitamins cannot be produced by the body, and most are obtained from food. So there's 2 different types of vitamins. There's water-soluble, which dissolve in water, and fat-soluble, which dissolve in fat. Water-soluble vitamins cannot be stored by the body. They need to be consumed every day. So this includes all of the B vitamins, 1, 2, 3, 5, 6, 7, 9, 12, and vitamin C. They help to regulate metabolism, they facilitate our nervous system function, they help to maintain healthy skin, and they help to convert food into fuel or energy instead of storage. Now, the fat-soluble vitamins can be stored by the body, so we don't need to consume these as often as the water-soluble vitamins. And these ones are vitamin A, vitamin D, vitamin E, and vitamin K. These help to maintain our vision, skin, and mucous membranes. They regulate our calcium and phosphorus absorption. They support normal blood clotting, aid in bone development, and help to protect our red blood cells. Now there's another class of vitamins known as antioxidants. These are vitamins A, C, and E. So there's a molecule that inhibits the oxidation of other molecules. Oxidation reactions can produce free radicals that can damage our body cells. And then these damaged body cells are thought to contribute to aging and then other bad diseases such as cancer and heart disease. So the antioxidant vitamins are antioxidation, so they actually help to protect against this chemical reaction. Minerals are other micronutrient. These are naturally occurring inorganic substance that is essential to proper functioning of the body. They're highly concentrated in foods of animal origin, But vegetarians can obtain adequate mineral intake by consuming grains, nuts, and dark green leafy vegetables. So there's two categories of minerals. Major minerals are required in larger amounts, and then trace minerals are required in smaller amounts. So major minerals, we need about 100 milligrams per day as an adult. These are found in the body at 5 grams or higher. So if anything's less than 5 grams, that would be a trace mineral. These assist in bone and tooth health. They help to regulate the blood pressure. They are essential in balancing our water and acid-base ratios. And these include calcium, magnesium, phosphorus, potassium chloride, and sodium. And here's an example of some good calcium food sources. So trace minerals, there's only 50 milligrams per day required in the adult diet, and these are found in the body in levels less than 5 grams, 5 grams or less. They assist in proper metabolism and structure. They also assist in immune and blood system functioning, and these are iron, copper, zinc, manganese, fluoride, selenium, iodine, chromium, and molybdenum. Okay, our last nutrient is water. So humans can live only about 3 days without any water. It's a universal solvent of the body. It allows nutrients to dissolve in water and then be transported throughout the body. It allows for transport of substances in and out of cells. It's a solvent that's great for ridding the body of waste products. It helps to cushion the shock to bones and joints. And it also helps to cool the body's internal temperature. It's obtained in the body by our consumption of fluids or foods with high water content. It's also a byproduct of chemical reactions that occur in the body. And we lose it from the body by urinating, perspiring, breathing, our feces elimination, and then vomiting. Not the best way to lose it. Okay, so that's the end of lesson 21.1. We'll pick back up at 21.2. Is lesson 21.2, tools for healthy nutrition and nutritional therapy. My Plate. So this is a nutritional guide that is available at www.choosemyplate.gov. It is a food circle with a plate and glass divided into 5 food groups. And this helps to encourage Americans to include these specific proportions of these food groups on their plate every time they eat. So, one big section here is vegetables and then fruits. So half of the plate should consist of fruits and vegetables, with the amount of vegetables being a bit more than the amount of fruits, right? Because we learned about sugars, which naturally occur in fruit, so we want to limit those amounts and consume a bit more vegetables than fruit. Protein should be about a quarter of the plate, and grains should be about a quarter of the plate. There should be 1 serving of dairy with each meal. And so there's different ways to get that serving, right? It could be a glass of milk or a yogurt or a serving size of cheese. There's lots of different ways. And this helps to avoid any oversized portions, which is the most important message of My Plate. So the 2015 Dietary Guidelines for Americans work with My Plate to provide recommendations that support sound or good nutrition. So this is for anyone over the age of 2, and then those at risk for chronic disease. And the guidelines get updated every 5 years. So we're probably behind a little bit, right? This curriculum was published in 2018, so there would actually be 2020 guidelines that we probably should look at after we're finished with this lecture. Anyway, the 2015 guidelines focus on achieving and maintaining a healthy eating pattern, and they want people to pay attention to their caloric limits and also obtain regular physical activity. If they follow this eating pattern, it's more predictive of overall health status than actual individual nutrients is. Food labeling. So this is required by the FDA, the Food and Drug Administration. It is mandatory for packaged foods, and it's voluntary for raw produce. And the labeling is to provide consumers with accurate information about the nutrients and the ingredients in that food. So this would include the common name of the product, name and address of manufacturer, packer, or distributor, the net quantity of contents in terms of their weight, measure, or count inside the package, how many of them, and then also the nutrient contents, so the nutrition facts panel. And then it will list the ingredients in descending order of predominance by weight. So the very first ingredient will be the one that is in the largest amount, and then the last ingredient will be the smallest. So descending, right, from largest to smallest. Okay, so let's look at those again. So here we have our serving size and then the servings per package, right? So that's actually really important to notice. A lot of people will say, oh, well, one serving is only 250 calories, but then they'll eat the whole package or the whole box. Well, you have to look at how many times you need to multiply that, right? So if there's 2 servings in this container and you consume the whole thing, then you're actually getting 500 calories, right? You're getting double these amounts because it's 2 servings. Then you have the amount of calories and the amount of calories from fat. This is, and then it breaks it down per the percent daily value. Right, so right here you can see that the percent daily values are based on a 2,000 calorie diet. So your dietary needs may actually be, they should be maybe higher than that or lower than that. And just depends. Everybody has a little bit different caloric need depending on their lifestyle, how sedentary they are or not, right? So the more activities we are doing, the higher our daily caloric need would be. But they're basing this off of a 2,000, which is about average for Americans, right? So they're saying that if you are consuming 2,000 calories a day, 18% of it, you're getting this, whatever this was, say it was cookies, right? There's 2 cookies in this container or package. There was 12 grams of fat, so that's 24, right? So that would give you double 18% of the total amount of fat that you should be eating for that day. I hope that makes sense. Okay, so here's the nutrients that should be limited right here are fat, total fat, saturated fat, trans fat, cholesterol, and sodium, right? These are the ones that we definitely want to make sure that we're limiting to a certain amount every day. Additional nutrients that should be obtained in adequate amounts, right? So carbohydrates, fiber, sugar, protein, and then vitamins and minerals. So those are all ones that we need for sure. The footnote on the daily values, right? So I kind of explained that, right? Based off of a 2,000 calorie day per day diet or 2,500 calories per day, maybe for somebody who's working out or pregnant or lactating, they need more calories every day. All right. Yeah, we looked at our additional nutrients. So, just to review, I probably covered all of this already. The serving size and servings per package, right? This indicates the size of one single serving. And a packaged food almost always contains more than one serving. The amount of calories, this can assist us in our weight management. And so we need to pay attention to the number of servings that we're consuming every day. The percent daily value, again, that's the percentage of a nutrient that's being provided in that single serving of food compared with what our requirements are for an entire day. And as I said, this is always going to be based off of a 2,000 calorie per day diet, as that's pretty much the average. The nutrients that should be limited, those are the ones that we know we need to limit because they can be connected to health problems if we consume them in unlimited quantities. And those are fat, cholesterol, and sodium. Nutrients that should be obtained in adequate amounts, because they're essentially important to our health, are vitamins A, vitamin C, calcium, and iron. The footnote with the daily values, again, that's going to include the minimum or maximum daily values for the key nutrients. Most are goals that we want to stay below, but the fiber is at the minimum level, so we can actually go above that daily value of fiber. And then the additional nutrients, the carbohydrates, they're going to be broken down into their simple and complex types. Sugar is included under simple. Remember, that's one of our simple carbs. And then protein. Most Americans consume more protein than they need. A lot of people put a lot of emphasis on protein and how important it is. And so now we're finding that people are actually consuming way more than they need. And we'll probably learn about this later on, but it can actually become quite problematic for our kidneys because our bodies need to break down all of that excess protein. So we'll learn about that more. And again, the ingredient list in descending order of weight, highest weight down to the lowest weight. So this can help make healthy food choices. So, for example, if you're avoiding sugar and trans fats, you're going to want to make sure you select minimally processed foods because anything that's been processed, it's gone through that chemical reaction where we now have trans fats in it. And then you can also quickly scan the ingredient list for any ingredient that you might have an allergy to or an intolerance to. All right. So here's an example of an ingredient list that's pretty short. Whole grain wheat, wheat bran, raisins, oat fiber, sugar, and sea salt. It's probably some sort of cereal or granola, yeah. Here's an example of an ingredient list that is pretty long, right? Here's our corn flour is the most, the ingredient with the most amount, right? Followed by high fructose corn syrup, which is just another way of saying some really bad sugar. Oat flour, brown sugar, partially hydrogenated vegetable oil, salt, sodium citrate, natural and artificial flavors, trisodium phosphate, fruit juice concentrate, malic acid, red 40, that's a dye, niacinamide, yellow 5, blue 1, some more dyes, not usually very good for you, thiamine, mononitrate, pyridoxine, hydrochloride, and then BHT. So I might think twice about eating that. So nutrition therapy. This is the application of the science of nutrition to promote optimal health and also to treat illness. It's really important for the medical treatment plan for managing certain diseases and conditions. And a registered dietitian is qualified to assess nutritional status of a patient and then recommend appropriate therapy. Now, you will get other qualified and licensed practitioners prescribing nutritional therapy as well, such as your cardiologist would probably prescribe you a
specific diet if you have high blood pressure or if you have heart disease, right? So it doesn't have to come from a registered dietitian, but they can also often refer patients to RDs, registered dietitians, to have them assist in helping patients really come up with a good plan when they've been prescribed certain diets or nutritional therapy. We talked about this earlier. The medical assistant should have basic knowledge of nutrition, but we are not qualified to recommend any nutrition therapy because that's essentially a prescription, right? But we can definitely assist the providers and practitioners in helping to educate the patients once they have a prescribed nutritional therapy. So one of the conditions that would require nutritional therapy are weight management, so being overweight or obese. So they'll put together a set of practices and behaviors to help keep the person's weight at a healthy level. And it usually depends on the number of calories consumed compared with the number of calories used. So you'll hear people talk about calories in, calories out quite often. The commonly prescribed idea is that if you can create a deficit between the amount of calories coming in and the calories going out, that you should lose weight. So obesity is the accumulation of body fat to the extent where it may have an adverse effect on the individual's health and well-being. And it's one of the most common chronic health problems, especially in America. 69% of adults in the U.S. are overweight or obese, so that's a lot. It's associated with premature death. It's the leading cause of preventable death. And the primary cause of obesity is excessive food intake combined with a lack of physical exercise. It sounds so simple, right? You eat too much and you don't move enough, you're going to end up overweight and eventually obese. But it's not quite always that simple, right? So, treatment plan for obesity. The nutritional therapy would include the selection of an appropriate eating plan, setting firm but reasonable weight loss goals, so slow and steady, right? Not fast or quick. The goal would be no more than 1 to 2 pounds lost per week because this is sustainable and usually people have much more success long term in maintaining the weight loss if they lose it at a slow and steady rate. Again, I talked about that caloric deficit, right? So moderately reducing the number of calories coming in so that more calories are used than are taken in. And it's important to choose a program that is medically proven and is best suited to the patient's needs. So we want to avoid the patient trying fad diets. We'll talk about some of those as well. Additionally, a physical exercise program, because this increases the number of calories burned, which helps contribute to that caloric deficit, which will result in loss of weight. Recommended would be 150 minutes of moderate intensity activity per week. So you could, the patient could decide that they can do 30 minutes at a time, right? And then you would divide that up. So 150 divided by 30 would be 5. So that means 5 days a week, they're going to perform 30 minutes of moderate intensity activity, right? And then they could have 2 days off to rest. But 2 days a week, they should also engage in muscle strengthening exercises. So that could be on those days off, or they could add it on to the days that they're performing the moderate intensity activity. Another really important part of a treatment plan for obesity is behavior modification. So it's important to change the behaviors that contributed to the weight gain in the first place, right? So first those behaviors have to be identified, and then the best thing to do is to then take steps to replace those specific behaviors with alternative, healthier behaviors that the individual can turn to, so that the weight loss can be maintained and sustained for long term, for hopefully the rest of their life. So another disease that requires a specific nutrition therapy is cardiovascular disease. This is the leading cause of death in the United States. Most common is atherosclerosis in the coronary arteries. So this is referred to as CAD, coronary artery disease. High total blood cholesterol is a risk factor. Actually, we'll talk about this probably in Ma125, but specifically it's the bad cholesterol, right? Not the good cholesterol. The bad cholesterol, the LDL, low density lipoprotein, that causes the plaque buildup of the atherosclerosis along the arterial walls. So the TLC, Therapeutic Life Changes Eating Plan, is a set of guidelines for a heart-healthy diet. It helps to reduce the intake of dietary cholesterol, reduce the intake of saturated fat, and then increase the intake of soluble fiber. Hypertension is the most common life-threatening disease in Americans. The incidence of hypertension has increased as a result of our aging population and then also our increased rate of obesity. So hypertension is chronic high blood pressure. This can cause severe damage to the heart, the brain, the kidneys, and the eyes. Extremely high blood pressure can also cause a stroke. The early detection and treatment can prevent hypertension and all of the associated complications that come along with it. The DASH eating plan, stands for Dietary Approaches to Stop Hypertension. So it's one of the first things that a provider will do once identifying hypertension in an individual. And it's important to note that that doesn't just mean that your patient came into the office one day and their blood pressure was high. It's a chronic, high blood pressure. It's not just one reading. So anyway, the DASH diet is an approach to healthy eating that really all individuals can follow. So some people who are pre-hypertensive would be prescribed this diet as well. So not only just those with hypertension, but people who have a family history of it, or their blood pressure is trending higher but not quite hypertensive yet, they can benefit from this as well. So it's a balanced diet that's low in saturated fat, low in total fat, low in cholesterol, and most importantly, low in sodium. It's going to be high in fruits and veg and whole grains, legumes, and low-fat dairy. So this diet can also help prevent obesity, osteoporosis, diabetes, cancer, heart disease, and stroke, because a lot of these are associated with hypertension as well. So sodium intake. We know for a fact that most Americans consume way too much sodium. This is particularly important for hypertensive individuals, so people with high blood pressure, to lower their sodium intake. Because the plasma in our blood consists primarily of water, decreasing in sodium results in decrease of blood volume, which is therefore less resistance or force of the blood against our arterial walls, right? So there's a lot of things that affect blood pressure, which is the force of the blood against the walls of the arteries, so the pressure, and one of them is volume. Another one is constriction, right? That atherosclerosis that we just talked about. So CAD and hypertension often tend to go together because the atherosclerosis on the arterial walls is almost like if you're putting a kink in a hose, you're really increasing the pressure on the rest of the artery walls when you've got a significant narrowing in one place or multiple places. Diabetes. So this is a lifelong condition, basically in which the body is not able to use glucose for energy because of a problem with insulin, right? So remember, glucose is the best source of energy for our bodies. So this can develop when the body produces either no insulin or very little insulin, or when our bodies cannot effectively use the insulin that it does produce. So 26 million Americans have diabetes, and an additional 79 million are pre-diabetic. This is amazing. So what happens? So obviously not all of those 79 million are becoming full-on diabetics, right? So hopefully they're turning that around with diet and lifestyle modifications. Recall that there are two types of diabetes. There's type 1, where these people are insulin dependent, right? So that means that their bodies aren't creating any insulin usually. And then type 2, which is not insulin dependent, so it can be managed. Type 2 can be managed with other medications and diet, non-insulin medications. So type 1 is an autoimmune defect that actually destroys the insulin-producing cells inside the pancreas. That's where insulin is produced. And then the body can no longer produce its own insulin, and it must be administered by injection. Nutritional therapy for type 1 diabetes focuses on just maintaining a good, steady control of the blood glucose levels. And these individuals need to track the amount and the type of carbohydrates they're consuming. And the nutritional therapy usually includes the exchange list system, and then counting carbs, and the MyPlate example. So we'll look at the exchange list system. This organizes foods into 6 groups based on their carbohydrate, protein, and fat content. The exchange means a food serving, and the patient must have an individualized plan that specifies the number and type of exchanges for meals and snacks, and this will stabilize their blood glucose levels. So here you can see one serving here of each of these items contains about 15 grams of carbohydrates. So this is the suggested serving size of these fruit items. The carbohydrate counting method is more flexible than the exchange method, and the carbohydrate content of the food is measured in grams against the amount that is administered. So typically 1 unit of insulin helps to process or metabolize 15 grams of carbohydrate. So the patient must be able to calculate the carbohydrate content of every food that they consume, and they usually can find this on food labels or other nutritional sources, right? And then they have to keep track of how many carbohydrates they are consuming, and then they know how many units of insulin to administer themselves. The MyPlate method is the most basic. It's appropriate for those with a low literacy skills or those who are kind of mentally challenged or just aren't able to do the exchange or the carbohydrate counting. And remember, it consists of 50% fruits and veg, 25% protein, and then 25% starchy foods, which also includes starchy vegetables because those produce the highest insulin response. And keeping to 25% starch at every meal or snack helps to control the blood glucose levels. So this is counting as our carbohydrate. Type 2 diabetes is more likely to occur in those aging over 40 years of age, and the biggest risk factor is excess body weight. They may have insulin resistance, which means that their body still produces insulin but is not able to use it effectively. So the nutritional therapy for type 2 diabetes could include controlling portion sizes, limiting concentrated sweets, emphasizing low glycemic index foods. You'll hear this referred to as the GI for glycemic index. and then increasing soluble fiber and attaining a healthy weight and also maintaining it. So lactose intolerance, this is when the body is unable to fully digest the lactose, which is the specific type of sugar that occurs in milk. So this is caused by a deficiency of lactase in our bodies, which is an enzyme that's produced in the small intestine. So some people just don't have enough lactase being produced for them to be able to consume lactose without getting the following symptoms. Things like abdominal bloating and cramping, right? This is after consuming something with lactose in it. Flatulence, which is gas, diarrhea, borborygmy, which is gurgling or rumbling sounds in the abdomen, and then nausea. So here's some common foods that contain lactose, milk, ice cream, gelato, butter, cheese. And then you can get foods that have actually had the lactose portion removed from them. So lactate is where they're putting the milk through a chemical process to remove the lactose. So the nutritional therapy for lactose intolerance would be obviously to avoid or limit the foods that you consume that contain milk or milk products. Consuming with a meal also can help reduce symptoms. And then switching to one of those lactose-free products or substitutes, or cultured milk products like yogurt. And then you can also take lactase enzyme supplements. So you basically just replace that lactase enzyme that your body's not producing by taking it in a supplemental, usually a pill form. Celiac disease. So this is an autoimmune disorder of the digestive tract where the immune system attacks gluten. So the villi are the finger-like extensions that line the small intestine and help to increase the surface area for increased absorption of nutrients into the bloodstream. And in people with celiac disease, gluten irritates the small intestine, which damages the villi. And then that results in decreased surface area for absorption and causes malabsorption of nutrients. So bad absorption, right? So this can actually be pretty serious. Then there's also non-celiac gluten sensitivities. So these are the people who just cannot tolerate gluten, but luckily for them, there's actually no damage to the villi of the small intestine. And it's estimated that 18 million Americans have non-celiac gluten sensitivity, which is 6 times the number of people who actually have true celiac disease. So any people in either of these categories are going to want to avoid all of these types of foods. Anything with noodles or pasta, bread, grain cereals, obviously cookies, beer, some fun stuff. And symptoms of gluten intolerance, the first ones can be similar to lactose intolerance, right? So abdominal bloating and flatulence, diarrhea, constipation, abdominal pain, but then also weight loss due to malabsorption of nutrients, headache, fatigue, joint pain, brain fog, depression, and this one's a funny one to me, foul-smelling stool. I don't know that any stool actually smells good, so I think that's kind of funny, but apparently it could smell worse than other people. So the nutritional therapy would be gluten-free foods, right? So excluding foods that contain wheat, barley, rye, or triticale. Eating these gluten-free foods, you could eat beans, nuts, seeds, eggs, meat, poultry, fish, seafood, fruits and vegetables, and dairy. So still plenty of good foods to get nutrients from. And then you can get gluten-free grains such as buckwheat, cornmeal, flax, quinoa, rice, soy, and then they can actually remove the gluten from oats. So you can replace these items. You can make cornmeal bread or bread with buckwheat instead of regular flour, wheat flour. So there's other ways. There's lots of ways to get around it. And then there are just plain old food allergies, right? So common ones are milk, eggs, wheat, fish and shellfish, soybeans, the tree nuts such as peanuts, and then cashews, pecans, walnuts, Brazil nuts, hazelnuts, almonds, and coconuts. Strawberries, tomatoes, peppers. These are kind of common things that people can have allergic reactions to after consuming them. Symptoms of food allergies usually include a skin rash or hives, swelling and itching, wheezing, shortness of breath, difficulty swallowing, abdominal cramping and pain, nausea and vomiting, and diarrhea. So nutrition therapy, if there's a suspected food allergy, would first be to eliminate it, right? The elimination diet. So you remove the offending food, and that's really easy to do when an individual is allergic just to one or two foods. Another therapy would be the rotation diet. So this limits the number of times a food is ingested, which can lead to a gradual desensitization of that food. And this is used for mild to moderate food allergies, right? If you're getting anaphylaxis from something, you're probably not going to go with the rotation diet. But just some moderate or mild symptoms, rash, you could do this, and it can actually improve the allergy. And then denaturation, which is when they expose the food to heat, which can reduce or alter the chemical structure and then change it enough to where an individual could eat it. You can also take medications and supplements to suppress the allergic response, but that can often make the allergy worse over time. You can orally take in digestive enzymes, which help to break down the offending thing into smaller, less allergenic molecules. Antacids cause the blood pH to become more alkaline, which can relieve allergy symptoms. So taking, Tums or something like that. And then vitamin C and vitamin B5 actually are known to possibly assist in helping to control the allergic reactions to food allergies. So that concludes our last lecture for this week, and we'll see you next week. Welcome to a brief introduction of Chapter 4, Vital Signs. Vital signs are objective guideposts that help determine a person's state of health. Vital signs consist of temperature, pulse, respiration, and blood pressure. Sometimes pulse oximetry might be routinely ordered as part of a patient workup, or more likely when a patient complains of respiratory problems, but it depends on the office policy. But typically, we obtain 4 vital signs on most standard office visits, and that is temperature, pulse, respiration, and blood pressure. Vitals are usually checked during each office visit to establish the patient's state of health and get a baseline of their normal measurements against which future measurements can be compared. Vitals are usually taken in the same order: temperature first, then pulse and respiration simultaneously, and blood pressure last. And the reason for this is that typically it takes about 5 minutes for someone's blood pressure to normalize after they've walked around. So, you bring your patient into the exam room and have them sit and check their medications and allergies, get the chief complaint, and then start your vital signs. So by the time you get to blood pressure, hopefully they've been sitting calmly for about 5 minutes, so you'll get a nice accurate reading. to lesson 4.1, temperature. So the normal body temperature range is 97 to 99 degrees Fahrenheit, which is the same as 36.1 degrees Celsius to 37.2 degrees Celsius. So anywhere between those two numbers is considered normal, with the average falling right in the middle at 98.6 degrees Fahrenheit or 37 degrees Celsius. Usually we're recording it in Fahrenheit in this country. So low-grade fever would be 99 to 100.4 degrees Fahrenheit. A fever, which is the medical term is pyrexia, is anything above 100.4 degrees Fahrenheit, which means that the heat being produced in the body is greater than the heat being lost. Hyperpyrexia, so extremely high fever, is if it goes above 105.8 degrees Fahrenheit, and this is very serious and can be very dangerous. So just the medical terminology review, pyrexia is a fever, which is a temperature greater than 100.4 degrees Fahrenheit. Febrile means that the patient is marked by fever, or if something is caused by fever, it would be considered febrile. And afebrile means free from fever, or a meaning without. Fever is a common symptom of illness, but not really an illness of itself. It's often a sign of inflammation and infection, or a pathogen invading the body, acting as a pyrogen. And so a pyrogen is any substance that produces a fever. So this could be, a virus, a bacteria, a parasite, any kind of pathogen. Most fevers are self-limiting, which means that the temperature returns to normal after the disease process is completed. So they kind of self-solve, self-cure themselves. Normal fluctuations occur throughout the day. Oops. Various factors affect body temperature. Daily variations and fluctuations occur during sleep metabolism, and muscle contractions slow down, which causes temperature to be lowest in the morning typically, before your metabolism and muscle contractions increase. Emotional states, so strong emotions can increase temperature, such as crying or extreme anger. And infants and young children often cry during exams, so you'll see their body temperatures rise. Age, so infants and young children have a higher core temperature because their heat regulating system is not yet fully established. The elderly people have lower temperature because they have less subcutaneous fat. They tend to exercise less, and they also lose thermoregulatory control as they age. Environment, cold weather obviously decreases the core temperature, and hot weather increases the core temperature. Exercise causes an increase in voluntary muscle contractions, which raises the body temperature. And then patients' normal body temperature. So some patients just normally run low or high. So you'll see that as a trend if you review your patient's chart. Pregnancy and ovulation, when the metabolism is increased, this raises temperature as well. We have 5 sites for assessing body temperature: mouth, axilla, rectum, ear, and then forehead, as you all are quite familiar with now. We can also use actually any area of the skin to measure with an infrared thermometer. Oral temperature is convenient and one of the most common routes. When the MA records the temperature, we assume generally that it's taken orally unless otherwise noted. There's a rich blood supply under the tongue, which is the site for the placement of a thermometer, an oral thermometer. Most importantly, the patient must keep their mouth closed to provide a closed space and not allow any air to come in and possibly affect the temperature and give a false low reading. Axillary is taken under the armpit, which is the axilla. This is recommended for toddlers and preschoolers who have trouble holding a thermometer under their tongue. And it's also recommended for mouth breathing patients. So anybody who's unable to breathe through the nose, it would be impossible for them to close their lips and seal their lips around an oral thermometer probe. As well as anybody who's just had oral surgery, it would be quite difficult for them to have that in their mouth as well. Electronic thermometers are most frequently used in the medical office. They're portable, and you can measure oral, axillary, and rectal temperature with them. And they generally work pretty quickly. They measure the temperature fast, between 4 to 20 seconds, and the results are digitally displayed. You can also toggle between Fahrenheit and Celsius readings. And they have interchangeable probes. So the blue probe is the one you'll see most often. That is for taking oral and axillary temperature. And the red probe is for rectal. It's important to note that the axillary temperature measures 1 degree Fahrenheit lower than the oral route. So it's very important to notate when you're taking the temperature via the axillary method. And typically you would put an A with a circle around it, or if you're in the electronic health record, there'll be a button to push next to the reading, and you could choose axillary. So it wouldn't be surprising to see a reading a little bit lower than average or even lower than normal if it was taken via the axilla, because it should always be 1 degree lower than the patient's oral temperature. Looks like we're missing a slide there. Rectal temperature. So the rectum is a mostly closed cavity, so that provides an extremely accurate reading. This will always measure 1 degree higher than the oral route, and it's very important to make a notation that the temperature was taken through the rectal route, so an R with a circle in it if you're charting by hand, and pick the rectal choice in the electronic health record. It's recommended for infants and young children, patients that are unconscious, mouth breathing patients, and anytime you need a greater accuracy. It should not be used in newborns due to the danger of rectal damage. The oral temperature is oral, meaning ear. Use the tympanic membrane thermometer. The ear provides a closed cavity that is easily accessible, and it provides instantaneous results. It's easier to measure in preschool children and uncooperative children and patients who can't have their temperature taken orally. The tympanic membrane thermometer is always used in the ear. It detects the heat rays that are coming from the eardrum, and it functions basically like a camera, takes a picture of the heat waves and calculates the temperature from the wave energy and converts it into a temperature equivalent. With the tympanic probe placement, it's very important that it's put properly in the patient's ear. This is the most important thing in obtaining an accurate temperature. It's really important that you straighten the ear canal, because the ear canal has an S shape that can obstruct the view of the tympanic membrane from the little camera sensor in the probe. So you must straighten the ear canal. In adults, you gently pull the upper part of the ear up and back, so in this direction. And in children, you would gently pull down and back, children under 3. The tympanic membrane thermometer should not be used with a patient with inflammation of the external ear canal because you would not want to cause any pain or discomfort. You would not use it if there's discharge, such as blood or pus. And excessive cerumen buildup can cause a falsely low temperature reading. There's some serum in there. It can be used in a patient with otitis media because that is much further down in the ear canal. So you're not going to touch any inflamed areas with the thermometer probe. And a normal amount of cerumen is fine. That ends lesson 4.1. Welcome to lesson 4.2 on pulse. What creates the pulse? That is when the left ventricle of the heart contracts and blood is forced into the aorta, which is the largest artery in the body, which is already filled with blood, and then it expands to accept blood from the left ventricle. This creates a pulsating wave that travels through the arteries of the body, and the wave is known as the pulse. Pulse rate is the number of heartbeats in 1 minute. So we measure that in beats per minute or BPM. So the heart rate is determined by taking the pulse rate. Normal pulse rates vary widely by age group. The normal healthy adult range is 60 to 100 beats per minute. So make sure you memorize that, with the average falling usually between 70 to 80. Tachycardia is an abnormally fast heart rate, so anything more than 100 beats per minute. And bradycardia is an abnormally slow heart rate, so anything below 60 beats per minute is considered bradycardia. The pulse rhythm is the interval between heartbeats. A normal rhythm would have the same interval between beats, so an equal amount of time. Dysrhythmia or arrhythmia is when there are unequal or irregular intervals between the beats. And if that's the case, the provider may order additional tests, such as checking an apical to radial pulse, an electrocardiogram or EKG, or a Holter monitor, which is a longer EKG recording. The pulse volume is the strength of the heartbeat. So this is the amount of blood pumped into the aorta by each contraction. The volume should remain constant. If it's strong, the pulse will feel normal and full. Thready is when the pulse feels weak, and bounding is when the pulse feels very strong and very full. Factors that affect the pulse rate: one is age. As age increases, the pulse rate decreases. So children have a much faster pulse rate than adults. Gender: women typically have faster pulse rates. Physical activity: obviously when you're exercising, that increases the pulse rate. And emotional states can also increase pulse rate temporarily, such as feelings of anxiety, fear, excitement, or anger. Metabolism: an increased body metabolism increases the pulse rate. So example, during pregnancy, the mother's pulse rate is usually much faster than normal when not pregnant. Fever can increase the pulse. And physical fitness can actually often decrease the pulse. So somebody who's extremely physically fit or a high-level athlete will have a much lower resting heart rate. Medications can increase or decrease pulse rates, sometimes on purpose,
as the desired effect, or sometimes there are just side effects of a medication that can do that. So the table 4.4 should be in your textbook, has the pulse rates of various age groups. Infant, which is birth to 1 year, is 120 to 160. Toddlers are 90 to 140. Preschool children, 80 to 110. School age child, 75 to 105. So you can see how they're getting lower as the child ages. And then adolescents are the same as adults, so 60 to 100. And then after somebody turns 60, tends to get lower, 67 to 80. And then, as I said, well-trained athletes, you'll often see them down in the 40s. So anything 40 to 60, which would be considered bradycardic, but for them, that's their normal resting heart rate. But for our purposes, we're going to focus on memorizing the normal adult rate, which is 60 to 100. So a pulse can be measured usually typically by palpation at any pulse site, except for at the apical site, we use a stethoscope to listen to the pulse. And palpate means to touch or feel. So to palpate a pulse, we apply a moderate pressure with the pads of our 2 to 3 middle fingers. Using excessive pressure can obstruct the pulse. So if you push too hard, then you won't be able to feel it at all. And too little pressure, you also may not be able to feel it. And we don't ever want to use our thumb when we're checking a pulse, because our thumb tends to have our own pulse in it, and it can be hard to differentiate between ours and our patients. The pulse is felt most strongly when a superficial artery is held against a firm tissue, such as a bone. So there's many, many locations on the body that can be used to take a pulse. And we'll look at all of them individually: radial, apical, brachial, ulnar, temporal, carotid, femoral, popliteal, posterior tibial, and dorsalis pedis. So the radial artery is the most common site used, and it's on the wrist, just under the thumb, so on the radius side of the arm, located in the groove. It's easily accessible, shouldn't cause any discomfort to the patient as long as you're not pushing too hard on there. And sometimes people use this to monitor their own heart rate as well. The apical pulse is at the apex of the heart, which is at the bottom. And this is a much stronger beat there and can be easily heard as opposed to other pulse sites because it's the strongest right there at the heart. And you can take this if you're having any difficulty feeling the radial pulse, and also if the pulse is abnormally slow or also rapid, it can help you get a better count. And we usually use this for infants and children up to 3 years old because the other sites are difficult to palpate on small children. So this is the one that we use a stethoscope for to listen. The chest piece of the stethoscope is placed over the apex of the heart, which is the very bottom point. And you'll usually find that in the 5th intercostal space. So that would be just below the 5th rib is the intercostal space in between rib 5 and rib 6. On the stethoscope, you'll notice 2 chest pieces. The large one is called the diaphragm, and the small one on the opposite side is called the bell. If you have both types, you can actually rotate it, grasp the tubing, and then you can turn the chest piece, and whichever one is facing down is the one that is in the on position. So you want to make sure that you have it on for the side that you want to use, the correct chest piece. Otherwise, you will not be able to hear anything. And we'll look at that in the lab this week. The stethoscope is our instrument for amplifying and hearing sounds produced by the body. And it has earpieces, binaural side pieces, tubing, and then the chest piece. You're always going to make sure that you turn the earpieces forward so that you can hear the sounds. So typically they tend to have an angling to them. And so you want to make sure you position them forward in your ears because this follows the direction of the ear canal. If you have them facing backward, you probably won't be able to hear anything. The brachial pulse on the brachial artery is located in the antecubital space at the front of the elbow, and it's always in the medial aspect of the arm. Okay, so that means towards the medium or towards the middle, right? And this is the one we usually use to take blood pressure. The ulnar pulse is on the pinky side of the wrist, so that would be opposite from the radial artery. And typically it's not as strong, so a provider might use it to assess the circulation to the hand, but it's not going to be as good for being able to get the pulse rate. The temporal pulse is in front of the ear, just below eye level. And you can use this with some other pulse sites, such as the radial is not accessible. And it's easy to access in children. Carotid is on the anterior side of the neck, slightly to one side of the midline. So the midline would be from the ear straight down. So it's just a little bit forward of that. This is a really great site to find quickly. Typically, you'll see this used in situations of where we're using CPR because it's very easy to get to. So yeah, in adults during cardiac arrest, you can use it to measure in children, also monitoring pulse during exercise. But this one you have to be careful with because it can be uncomfortable if you're pushing on the neck there. The femoral pulse is in the middle of the groin where the femoral artery is. And this is used to measure in infants, children, and you could also use it in adults during cardiac arrest. But typically this isn't something you'd be doing on an adult because it's in kind of a private area in the groin. And so a provider would definitely use this to assess circulation though in the lower leg. They're concerned that there's a blockage in an artery. The popliteal pulse is at the back of the knee, and it's felt most easily when the knee is slightly flexed. And you can use this to measure blood pressure when the brachial is not accessible and also to assess circulation to the lower leg. The posterior tibial, or you'll often hear this referred to as PT, is in the inner ankle, just posterior to the ankle bone, right there. And this would just be used to assess circulation to the foot. The dorsalis pedis is on the upper surface of the foot between the first and second metatarsals, so the big toe and the next one over. And again, used to assess circulation to the foot. When we're charting and taking it, the pulse, we're going to do typically for 30 seconds. So you'll find the pulse and begin counting and time it for 30 seconds. And then whatever number you get, you're going to multiply by 2 so that we know what the BPM is, the beats per minute, for 60 seconds. So you will always get an even number. No matter if you get an odd number for 30 seconds, anytime you multiply that by 2, it will turn into an even number. So if we're taking a manual pulse, you should never be recording an odd number. Otherwise, we know we did something wrong there. If the patient has an arrhythmia, if it is not regular, then we'll count the pulse rate for 60 seconds. And then in that case, you might get an odd number because it's exact. You're going to make sure you record any abnormalities in the rhythm or the volume. A normal pulse would be recorded as regular and strong, or even and regular. Sometimes you'll hear the term RRR, regular rate and rhythm. And that concludes lesson 4.2. Lesson 4.4, blood pressure.
Equipment needed for checking blood pressure is a stethoscope, a sphygmomanometer, and a cuff. There are 3 measurements for checking blood pressure, or 3 methods. 1 is palpatory, 2 is oscillatory, and 3 is oscillometric. The palpatory method is the most commonly used, where it's probably not actually the most common, probably the least common. This is where you're feeling the radial pulse, and we put an occlusive cuff on the arm and inflate it above the level at which the pulse became impalpable. So you're feeling it, you're pumping up the cuff, and then you no longer feel it. So that's when you can stop inflating the cuff. And then you're going to slowly and gradually deflate it while watching the manometer. And the level at which the pulse becomes palpable again is your systolic pressure. The oscillatory method is the most commonly used. This is where we apply the cuff 1 inch above the elbow crease, palpate the brachial artery, then place the stethoscope lightly over it, the chest piece, inflate the cuff above the systolic level, which you could have determined already by the palpatory method, or you could also take an average of the patient's past readings, and then slowly lower the pressure in the cuff. And the level at which the carotid cuff sound is heard is the systolic pressure, and the level at which all sound disappears is the diastolic pressure. The oscillometric method is with the use of a sensor. So it uses the sphygmomanometer cuff, just like the oscillatory method, but then with the pressure sensor or transducer to observe oscillations in the cuff pressure. The pressure sensor within the inflated cuff detects the pulsation of the artery wall as a pressure vibration, and the interpretation of those small vibrations provide the blood pressure value. And typically it will give you the systolic, diastolic, and the pulse rate as well. The sphygmomanometer is the instrument used to measure blood pressure. Generally, we use an aneroid sphygmomanometer, which is a gauge with the scale calibrated in millimeters. The needle points to the calibrations, and the needle must always start at 0 before beginning taking the blood pressure. If the manometer is not correctly calibrated and the needle is not at 0, it's going to give you an abnormally high reading. It's going to be inaccurate. We have a variety of blood pressure cuff sizes, and the size of the cuff refers to actually the inner bladder that is inside the outer covering. So typically you have an outer covering, usually made of something like nylon that can easily be sanitized. And then there's a bladder inside, almost like a thick rubber balloon. So the inner bladder of the cuff should encircle 80% of the arm circumference, or wherever you're taking the blood pressure, but typically we use the upper arm. And it should be wide enough to cover 2/3 of distance from the axilla to the antecubital space, so the armpit to the crease. And the cuff must fit properly to get an accurate reading. If you have an improperly fitted cuff, the blood pressure reading will be inaccurate. So usually the cuffs will have measuring markers on them to ensure that it's fitting properly. So we usually have a child cuff used for children or very small adults with thin arms. There's an adult cuff, which is used for average size arm, and a large cuff used for adults or teens with larger than average sized arms. And then a thigh cuff used for thigh or adults with large arms. If the cuff is too small, the reading will be falsely high. If the cuff is too large, the reading will be falsely low. The cuff should fit snugly. Center should be directly over the brachial artery. So typically you'll find an arterial marker on the cuff, maybe with an arrow, and this should be placed directly on top of, above the, and pointing to the brachial artery, which you're going to palpate first so you know where it is. This way it allows complete compression of the artery, and then they usually have Velcro to secure the cuff. So again, remember, cuff is too small, your reading will be too high, will be falsely high. And if the cuff is too large, the reading will be falsely low. What is the blood pressure? This is the force exerted by the blood on the walls of the arteries. So systole is the phase when the heart contracts or tightens, and that's when blood is pushed out of the heart, which creates pressure on the artery walls. So the systolic pressure is the point of highest pressure on arterial walls. So this will always be our highest, our first number for blood pressure. Diastole is the phase when the heart relaxes in between contractions. So the diastolic pressure is the point of lowest pressure on arterial walls, and that's because the heart is relaxed. So blood pressure is usually abbreviated BP, and the measurement is expressed as a fraction. So the numerator, the top number, will be the systolic pressure, or the higher number. And the denominator will be, the bottom number will be the diastolic pressure, or the lower number. And it's measured in millimeters of mercury, which is abbreviated mm, and Hg is the elemental sign for mercury. So the guidelines currently are a normal blood pressure for an adult should be less than 120/80 millimeters of mercury. So notice that there is really no lower boundary, but we definitely have an upper boundary of 120/80. So pre-hypertension, hypertension is abnormally high blood pressure, would be anything from 120 to 139 systolic, and it could be and or anything 80 to 89 diastolic. So you could have one number be prehypertensive or both of them. And we take the BP pretty much at every office visit so that we can compare the readings over time, and it gives us a good index of a baseline BP. If it rises or falls of 20 to 30 millimeters of mercury, that would be significant for the patient, even if it's still in normal range. So if you could have a patient whose normal resting BP is, say, 90/60, and then if it all of a sudden jumps to 120/80, even though that's still in normal range, that could be a cause for concern or indicate something's going on with that patient. So hypertension, again, is high blood pressure or excessive pressure on the arterial walls. And hypotension is low blood pressure, so reduced pressure on arterial walls. Typically, it's below 95/60 would be considered hypotensive. Factors affecting blood pressure: age. As age increases, the blood pressure gradually increases because aging causes a loss of elasticity in the arterial walls, which causes an increase in pressure. So here's our average optimal blood pressures for age. Newborns, pretty low. 1 month old, 85/54. 1 year, 95/65. 6 years old, etc. And then eventually get up to adults, which should be 120/80 or below, less than. Gender. So after puberty, women tend to have a lower blood pressure than men of the same age. But then after menopause, women's blood pressure tends to be higher. So you can get variations throughout the course of the day. Typically, blood pressure is lower in the morning and then gets higher in the afternoon. Strong emotional states can increase blood pressure, such as anger, fear, and excitement. So, of course, we always want to try and have our patient be as calm as possible when we're checking their blood pressure. So, if your patient's really, really anxious or upset, it might not be the best time to take it. Exercise temporarily increases BP. If the patient's been involved in physical activity, you want to try and allow them to rest before taking their blood pressure. Usually takes about 20 to 30 minutes to normalize after working out for an extended period of time. If a patient just ran up the stairs to get to their appointment on time and rushed into the exam room, it shouldn't take 20 to 30 minutes, right? Hopefully by the time you finish checking them in, it'll have normalized. But if not, it's not unreasonable at all to wait to check the patient's blood pressure until even after the bulk of their visit with the provider. Blood pressure varies based on body position. So you're going to make a notation if the patient is in another position other than just sitting, which is the typical normal position we would want them in to check their blood pressure. And of course, medications can increase or decrease the blood pressure depending on the type. So it's always important to record any prescriptions and over-the-counter medications in the patient's chart. Other factors, pain will definitely increase the BP. Recently eating, smoking, and if their bladder is very full, that can raise the blood pressure. The carrot cough sounds. So these are the sounds that determine the systolic and diastolic blood pressure readings when we're taking it using the oscillatory method. So when the bladder of the cuff is inflated, the brachial artery gets compressed. So no sounds should be heard through the stethoscope. As we deflate the cuff, always at a speed of 2 to 3 millimeters of mercury per second, you'll begin to hear sounds as the blood begins to flow freely. And then as it begins to flow freely, you should no longer hear sounds. So that very first sound will be our systolic. And when the sound can no longer be heard, when the blood is flowing freely, that is the diastolic. So we want to, this is ideal, right? Tell the patient not to consume any caffeine or tobacco for 30 minutes before checking their blood pressure. It's pretty hard to change that once they've already gotten into their visit with you, if they just had their cup of coffee or just consumed some tobacco. But as I mentioned before, you always want to have them seated in and kind of calm and quiet for at least 5 minutes before taking their blood pressure. So we do everything else first and kind of save that for last. And always use the proper cuff size. You don't want to take the blood pressure over clothing because it can interfere with the ability to hear the sounds and could result in an inaccurate blood pressure reading. So either roll up the patient's sleeve. A lot of times this will make it too tight though. If it's a tight-fitting long sleeve shirt, then this causes compression of the artery before you even get the cuff on. So like this patient has here, in that case, you would have the patient just slip their arm out of the sleeve. You want to have the arm positioned at heart level, and it should be well supported. So ideally on a table or a counter or something, or armrest. Palms should be facing upwards so that you can get into the antecubital space and find the brachial artery. If the arm is above heart level, then the blood pressure is going to be falsely low because it's has a hard time traveling up in the arteries of the arm. Remember, gravity, everything tends to flow better downward. You definitely want to avoid getting extra sounds from the cuff. A lot of times you'll get kind of scratchy noises or movement, or if the tubing is hitting your chest piece of the stethoscope, it will make it very hard to hear those karate cough sounds. So extra sounds can interfere with your accurate measurement. You want to make sure you have 1 to 2 inches between the bottom of this cuff here and the antecubital space, the bend in the elbow. That way you're preventing the stethoscope from touching the cuff. If the cuff is or the tubing is touching the chest piece of the stethoscope, you'll hear it. You want to compress the brachial artery completely with the center of the cuff directly over the artery. As I said before, most cuffs have an arrow. Right here, this one says artery with an arrow pointing down. And notice here you also have a range, so you can see where the cuff should meet. And if it doesn't close within that range, then it's either too big or too small. As I said, avoid extra sounds from the tubing. So try and free it so it hangs freely and doesn't touch the stethoscope. You don't want it to rub against anything. You'll definitely hear the extraneous sounds, and it makes it very hard to hear the actual karate cough sounds and get an accurate measurement. Very, very important that you release the pressure at a moderate, steady rate of 2 to 3 millimeters of mercury per second. So this takes a lot of practice in controlling whatever mechanism you have for pumping up the air and then releasing it. Because you want the needle to move down the sphygmomanometer at a rate of 2 to 3 millimeters per second. So that's a tick mark. Every single tick mark on there is 1 millimeter. If you release it too quickly or too slowly, you're going to miss the sounds and miss the reading that correlates with the sound or absence of sound. So you'll get a false reading. Avoid venous congestion, right? So if you have to take the blood pressure again, if you need to recheck it, and it has to be on the same arm, you want to make sure you wait at least, I would say 2 minutes. 1 is probably a little not long enough. This allows any blood still trapped in the veins to be released, because if we've already compressed them once, they get kind of trapped in there. So you could either, if you need to recheck it right away, try and use the other arm, right? Or wait the appropriate amount of time to recheck it in the same arm. Often in a new patient, you're going to want to measure and record the BP in both arms, because you're going to normally get a small difference or variance of 5 to 10 millimeters of mercury between the two arms. And then, of course, we're going to take the higher initial reading as our what we would consider as the blood pressure for the day. But oftentimes I will record it in both arms. You might get some with a much larger variance than 5 to 10 millimeters. And that's definitely something you want to alert the provider to. Basically, what that could indicate is that there's probably some sort of arterial blockage, affecting the reading in one of the arms. Okay, so that concludes lesson 4.4. Okay, this is chapter 14, lesson 14.2. Disorders of the lymphatic and immune systems. Immunodeficiency. So there's one form of immunodeficiency is acquired immunodeficiency syndrome, which is AIDS, AIDS. This destroys T helper cells, and it makes the individual susceptible to opportunistic infections. And there's also malignancies that come along with that, such as the Kaposi sarcoma and wasting syndrome. There's many opportunistic infections that often affect individuals with AIDS, such as candidiasis, cryptococcus, cryptosporidiosis, cytomegalovirus, herpes simplex, histoplasmosis, Mycobacterium avium intracellular infection, pneumocystis, pneumonia, toxoplasmosis, and tuberculosis. There are drugs to treat acquired immunodeficiency syndrome. One is the reverse transcriptase inhibitors, RTIs. These inhibit viral enzyme called reverse transcriptase. Protease inhibitors inhibit the viral proteolytic enzyme, and a combination of the both is known as HAART, or highly active antiretroviral therapy. A hypersensitivity, this is an allergy which is an abnormal sensitivity that's acquired by exposure to an antigen. So this can range all the way from something pretty mild as allergic rhinitis or hay fever to something very severe such as anaphylaxis. Other allergies are atopic dermatitis, asthma, and urticaria, which is hives. Tumors. So the most common is lymphomas. These are malignant tumors of the lymph nodes and lymph tissue. You have Hodgkin lymphoma, which involves the Reed-Sternberg cell, and then non-Hodgkin lymphoma, which is either a follicular lymphoma or a large cell lymphoma. Multiple myeloma is a malignant tumor of bone marrow cells. Thymoma is a tumor of the thymus gland. This is often associated with myasthenia gravis. Patients may have other autoimmune disorders such as lupus, erythematosus, and rheumatoid arthritis. Here's the staging of Hodgkin lymphoma. Stage 1 is the involvement of a single lymph node or a single group of nodes, such as this one right here near the thymus, the mediastinal. Stage 2 is involvement of 2 or more sites on the same side of the diaphragm. That one often involves the mediastinum. Stage 3 is when the disease is on both sides of the diaphragm, so above and below it, and this may include the spleen or a localized extranodal disease. And stage 4 is when it's widespread extralymphatic involvement, so it's including the liver, the bone marrow, lung, or skin. What is a malignant condition that's often associated with AIDS? Does anybody remember? That is C, the Kaposi sarcoma. Laboratory tests that are often run on the lymph system is a CD4 plus cell count. This measures the number of the helper T cells in the bloodstream with patients with AIDS. So this is a good kind of marker for patients with AIDS. When their T cells are extremely low, they will often go into isolation to protect themselves from other acquired diseases and viruses. The ELISA test detects anti-HIV antibodies, and then the Western blot is given as follow-up. Immunoelectrophoresis. This separates the immunoglobulins, which is the IgG, IgM, IgE, IgA, and IgD. And then a viral load test measures the amount of AIDS virus or HIV in the bloodstream. A clinical procedure that's often performed on the lymph is a CT scan or computed tomography. This is X-ray imaging that produces cross-sectional and then other views of anatomic structures. These X-ray views show abnormalities of lymphoid organs such as lymph nodes, spleen, and thymus gland. So our abbreviations are AIDS or AIDS, CD4 plus cell, which is the helper cell, CD8 plus cell, the cytotoxic cell, CMV, cytomegalovirus, Crypto or Cryptococcus, ELISA, which is the enzyme-linked immunosorbent assay, GCSF, granulocyte colony stimulating factor, GM-CSF, granulocyte macrophage colony stimulating factor, HAART, highly active antiretroviral therapy, Histo or histoplasmosis, HIV, which is the human immunodeficiency virus, HSV, which is herpes simplex virus, IgA, D, E, G, and M are the immunoglobulins, IL-38 all the way to IL-5 are the interleukins, KS is Kaposi sarcoma, MAI is Mycobacterium avium intracellular complex. The MOAB is the monoclonal antibody. NHL is non-Hodgkin lymphoma. PCP, pneumocystis pneumonia. PI or protease inhibitor. RTI, reverse transcriptase inhibitor. SCID, severe combined immunodeficiency disease. Treg are the regulatory T cells or suppressor T cells, and toxo is toxoplasmosis. Our combining forms review are axilo, cervico, immuno, inguino, lympho, lymphatino. There they are again. Spleno, thymo, and toxo. Suffixes are cytosis, edema, globulin, megaly, oid, and pathy. Penia, phylaxis, poiesis, stitial, suppression. Our prefixes are ana, auto, hyper, inter, retro. And what is the name of the fluid that lies between cells throughout the body? It is C, interstitial. What's the malignant tumor of the lymph nodes and spleen marked by the presence of Reed-Sternberg cells in lymph nodes? That is the Hodgkin lymphoma. Reed-Sternberg means Hodgkin. Lymphoma is the tumor. And that's the end of lesson 14.2. Hello students, chapter 14, we're going to start with lesson 14.1. So lymph is the clear watery fluid that surrounds body cells and flows in a system of the vessels throughout the body. The lymph fluid originates in blood. It's rich in lymphocytes and monocytes. It flows in the lymph capillaries and vessels, also flows through the lymph nodes and lymphatic organs, which are the liver, spleen, thymus, and nodes, and it helps absorb lipids in the intestines. The functions of the lymphatic system: transport proteins and fluid that have leaked back into the bloodstream. So these have leaked out of the bloodstream and it brings them back. Lymphatic vessels absorb lipids from the intestines and then transport them to the bloodstream. And lymphocytes and monocytes protect the body by attacking foreign cells and organisms on the cellular level. So the structures of interstitial fluid and lymph capillaries are blood and lymph capillaries, lymph vessel, interstitial fluid, and tissue cells. So here's an illustration. Blood from the arteries, the tissue cells. Interstitial fluid is the light green, dark green is the lymph capillaries, and here's the blood capillaries intertwined, and then the blood makes its way to the veins and then the heart. And the fluid, the lymph fluid, flows to the upper chest. So So again, lymph originates from the blood and filters out of teeny blood capillaries into the spaces in between the cells. The fluid that surrounds the cells of the body is called interstitial fluid, and this passes continuously back and forth into the lymph capillaries that have very thin walls. And then those weave through the tissue spaces. The lymph passes through the larger lymphatic vessels, through clusters of lymph tissue, and then finally it reaches the large lymphatic vessels in the upper chest. The lymph enters these large lymphatic vessels, and then those empty it into the bloodstream. So here's a larger illustration. Oxygen-rich blood coming out of the heart to the arteries, arterioles, down into the small blood capillaries, intertwined through the tissue cells with the lymph capillaries. Deoxygenated blood then goes into the venules and veins, right side of the heart. And the lymph vessels continue through the lymph node and then back into the veins. For the anatomy, we have the lymph capillaries and vessels, and then the lymph nodes, which are located in the cervical region, which is the neck, axillary, which is the armpit, mediastinal, which is the middle of the chest, mesenteric, which is in the intestinal, para-aortic, which is in the lumbar region, and then inguinal, which is in the groin. So inside the lymph nodes, you have macrophages, and these help to eat up or phagocytose foreign substances. You have B cells, which are lymphocytes. These produce antibodies, and they mature first in the bone marrow. And then you have T cells, which are also lymphocytes that attack bacteria and other foreign cells, and those originate in the thymus gland. The spleen, which is located inside the ribs, behind the diaphragm and the stomach. The purpose of the spleen is to destroy old red blood cells, and it filters the microorganisms and other foreign material out of the blood. It activates the lymphocytes during blood filtration, so the B cells then become activated B lymphocytes so that they can produce antibodies. And then the activated T cells attack the foreign materials. And the spleen also stores blood, especially red blood cells, which are erythrocytes, and platelets. The thymus gland, which is right there in the center of the chest, right above the mediastinum, right below the thyroid. This provides immunity beginning as early as while you're in the fetus, and then into early years of growth. It makes the cells immunocompetent in early life, and early removal from it impairs, so if you remove it from an animal or a human, it impairs its ability to make antibodies and then produce cells to fight antigens. So it's not a good thing to remove. Additional parts of the immune system are the leukocytes, or white blood cells. There's neutrophils, monocytes, and macrophages. The lymphoid organs, which are lymph nodes, the spleen, thymus gland, tonsils, and adenoids. These all produce lymphocytes and antibodies. And immunity is the body's ability to resist foreign organisms and toxins that damage tissues and organs. You can have natural immunity or adaptive immunity. So natural immunity is when your resistance is present at birth. So it does not depend on prior exposure to an antigen. So natural immunity would be provided by phagocytosis, macrophages, and then other natural killer cells inside the body. Adaptive immunity is when the body has the ability to recognize and remember specific antigens in a specific immune response. So the T and B cells, lymphocytes, provide this. Antibodies that are produced after exposure to an antigen. There's memory, which is secondary exposure, vaccination, immunoglobulins, and also maternal antibodies can be passed from mother to baby. The B cells are responsible for humoral immunity. These originate in the bone marrow from stem cells. They produce antibodies after exposure to specific antigens such as viruses and bacteria. A B cell matures into a plasma cell that produces antibodies called immunoglobulins to block the future effects of that specific antigen. The T cells are responsible for cell-mediated immunity, so this does not involve antibodies like the B cells. Cytotoxic T cells attach to and directly kill the antibodies. Other T cells secrete cytokines, which are interferons and interleukins that help cells respond to antigens. Helper T cells promote antibody synthesis by B cells and stimulate other T cells. And then suppressor T cells, which are regulatory or also called Tregs, these inhibit B and T cells and prevent them from attacking the body's own good cells. So those are important. And then dendritic cells are a macrophage derived from monocytes. They recognize and digest foreign antigens, and then they present antigens on the surface to stimulate B and T cells. They can transfer immunity by exposing the dendritic cells in a culture and then transfuse them and get them to stimulate the T and B cells. Some examples of immunotherapy are monoclonal antibodies, or MOAB. This is when multiple copies of cells or genes that kill tumor cells are made. This is passive immunotherapy. Vaccines, which contain antigens from the patient's tumor cells, then they stimulate the patient's own T cells to recognize and kill the cancerous cells. This is active immunotherapy. And then you can transfer immune cells in bone marrow transplants. The T lymphocytes from a donor can replace a patient's immune system with new cells that recognize the tumor cells as foreign and then kill them. So we'll review the vocabulary. Adaptive immunity is the ability to recognize and remember specific antigens and then mount an attack on them. Adenoids are the mass of lymphatic tissue in the nasopharynx. An antibody is a protein produced by B cells to destroy antigens. The antigen is the substance that the body recognizes as foreign that evokes an immune response. Axillary nodes are the lymph nodes in the armpit. A B cell is a lymphocyte that matures into a plasma cell to secrete antibodies. Cell-mediated immunity. These are the T cells that respond to antigens and destroy them. Cervical nodes. These are lymph nodes in the neck region. A complement system. These are proteins in the blood that help antibodies and kill their target. Cytokines are proteins secreted by cytotoxic T cells to aid in antigen destruction. Cytotoxic T cell is the lymphocyte that directly kills antigens. A dendritic cell is an antigen-presenting cell. This shows T and B cells what to attack. Helper T cells are the lymphocytes that aid B cells and stimulate T cells. Humoral immunity. These are when the B cells produce antibodies after exposure to specific antigens. This is a type of adaptive immunity. Immunity is the body's ability to resist foreign organisms and toxins that damage tissues and organs. Immunoglobulins are antibodies secreted by plasma cells in response to the presence of an antigen. Immunotherapy is the use of immune cells, antibodies, or vaccines to treat or prevent disease. Inguinal nodes are the lymph nodes in the groin region. Interferons are proteins secreted by T cells and other cells to aid and regulate the immune response. Interleukins are proteins that stimulate the growth of B and T lymphocytes. Interstitial fluid is the fluid in the spaces between cells, and it becomes lymph in lymph capillaries. Lymph is the thin, watery fluid within the lymphatic vessels, and it's collected from tissues throughout the body. Lymph capillaries are the teeniest vessels of the lymphatic system. Lymphoid organs are the lymph nodes, spleen, and thymus gland. The lymph node is a collection of stationary, solid lymphatic tissue along the vessels, the lymph vessels. And the lymph vessel is the carrier of the lymph through the body. A macrophage is a large phagocyte found in lymph nodes and other tissues of the body. Mediastinal nodes are the lymph nodes in the area between the lungs in the thoracic cavity. Mesenteric nodes are the lymph nodes in the mesentery. Monoclonal antibody is an antibody produced in a laboratory to attack antigens and to destroy cells. Natural immunity is the protection that an individual is born with to fight infection. Para-aortic nodes are the lymph nodes near the aorta in the lumbar area of the body. Lymphocyte that secretes antibodies, that's the plasma cell. It matures from B lymphocytes. The right lymphatic duct is the vessel in the chest that drains lymph from the upper right part of the body and empties into a large neck vein. Spleen is the organ in the left upper quadrant of the abdomen that destroys worn-out red blood cells. It activates lymphocytes and it stores blood. Suppressor T cells or Treg cells are lymphocytes that inhibit the activity of B and T cells. The T cell is the lymphocyte that acts directly on antigens to destroy them or produce chemicals toxic to antigens. Tolerance is the ability of the T cell to recognize and accept the body's own antigens as self or friendly. Thoracic duct, this drains lymph from the lower and left side of the body and empties into large veins in the neck. The thymus gland is the lymphoid organ in the mediastinum that conditions T cells to react to foreign cells. Tonsils are masses of lymphatic tissue in back of the oropharynx. Toxin is a poison or a protein that's produced by certain bacteria, animals, or plants. Vaccination is the exposure of an individual to an antigen that provokes an immune response that will destroy any cell with the antigen and will protect against infection. A vaccine is a weakened or killed microorganism, toxin, or other protein that's given to induce immunity to infection or disease. So, quick quiz. Which lymphocyte originates in the bone marrow and transforms into a plasma cell to secrete antibodies? Does anybody remember? It is B, the helper T cell. The formation of antibodies and lymphocytes after exposure to an antigen is B, humoral immunity. Okay, and here we have our combining forms, prefixes, and terminology. Immuno, lympho, lymphatino, spleno, thymo, toxo, ana, inter. And that's the end of lesson 14.1. Welcome to chapter 19. This is lesson 19.1, blood chemistry. Introduction. Blood chemistry and serology tests. These are often performed in the medical office using automated blood analyzers that are designed for use specifically in a small medical office. They perform blood chemistry tests in a short period of time with fairly accurate test results. Blood chemistry is an analysis of the chemical substances in the body that are dissolved in the liquid part of blood, which is the plasma. Blood chemistry testing involves the quantitative measurement of chemical substances in the blood. So remember the difference between quantitative and qualitative. Quantitative gives us a quantity or the exact amount of a substance that is present. Serum specimens are what are required for most blood chemistry tests. So this is both these tubes have been spun out in a centrifuge. This one with no anticoagulant, so the cells have clotted, but the serum gets separated from it. And then with an anticoagulant additive, the blood stays non-clotted, and then there's a buffy coat, and then the plasma is still separated during the spinning in the centrifuge. Quality control. This is methods and means that are done to ensure that test results are reliable and valid. So there's two really important QC or quality control measures that must be performed routinely. Calibration of any analyzers in the medical office, and then running controlled tests on the analyzers. So using a control is a sample with a specific known value, and they're often, made chemically, so we know exactly what value to expect when we run a control. So they're processed in the same way as a specimen, and we know that those results should fall within a specified range. And if the control test does not fall within that specific range, it means there's some sort of problem, right? There's either a problem or error with the analyzer, or it's malfunctioned. There's a problem with the testing technique, or there's a problem with the chemical reagents. So we can start troubleshooting there to make sure that we can fix it. So calibration is the act of checking or adjusting the accuracy of a measuring instrument. So this checks the precision of the analyzer, whatever it is we're using. If a machine is not properly calibrated, it can't produce accurate test results. So one thing that you probably haven't even realized yet that you use every time you come to the lab is the sphygma manometer we use for checking blood pressure. Even those have to be calibrated. And if they are not correctly calibrated, then they will give you an incorrect blood pressure reading. So everything, all our equipment that we use has to be checked regularly. Okay, so cholesterol, this is a white, waxy, and fat-like substance that is liquid that's essential for normal functioning of the body, and it's a really important component of cellular membranes, and it's also used in the production of hormones and bile. So this is an illustration of an artery and some red blood cells in there floating through there, and also some cholesterol cells. So cholesterol circulates in the blood. It's manufactured mostly by the liver automatically, but also a portion of it comes from our diet as well. So this is dietary cholesterol. It's only found in animal products, so like organ meats, egg yolks, and dairy products, meat. There is no cholesterol in plant-based products. So the cholesterol level of any one person, that the amount of cholesterol floating around in their blood, is determined by their genetics. So that can determine how much cholesterol their liver makes. And then it's also determined by the amount of dietary cholesterol that they're eating and consuming, specifically saturated fat. High blood cholesterol means that there's too much cholesterol in the blood. And we do know that this causes atherosclerosis, which is a buildup of fatty deposits known as plaque on the walls of arteries. And as this progresses, the arteries become narrower and narrower until eventually they can close off completely. And that can lead to a heart attack or stroke. High blood cholesterol is a risk factor for coronary heart disease, or I call it coronary artery disease, CAD. So we do put out our best efforts to lower cholesterol, because we know that that is something that we can do to increase a person's chance of living longer, honestly. So here's an illustration of a normal artery, arterial wall. There's no plaque on it. Here's a diseased artery with plaque built up along the inside of the walls, and then it's gotten so narrow that now there's a blood clot there. The blood wasn't able to pass through correctly. So there's two types of cholesterol. that are transported in the blood as a lipoprotein. So lipoprotein is a complex molecule consisting of a lipid and a protein. So the two different types are low density lipoprotein, or LDL, and then high density lipoprotein, which is known as HDL. So LDL cholesterol is what's known as the bad cholesterol. So if you can remember L for lousy, that'll help you remember which is good and which is bad. So the LDL picks up additional cholesterol from ingested fats that we've eaten, and then also from the liver, and it delivers it to our blood vessels and muscles and then deposits it in the cells. As I said, that's often referred to as the bad cholesterol, because an excess in the blood can cause the plaque to build up on the arterial walls, and it can result in atherosclerosis. HDL cholesterol is the good cholesterol. So if you can remember H for healthy, then that'll help you remember which one's good and which one's bad. The HDL removes excess cholesterol from the cells, so it doesn't get a chance to deposit there. It carries it to the liver so that it can be excreted from the body in our waste system. It's also protective and beneficial to the body, which is why it's often called the good cholesterol. So we actually want our HDL cholesterol levels to be high, because that can reduce the risk of heart disease. And we want our, conversely, we want our LDL cholesterol to be low. So a low level of HDL, which would be below 40 milligrams per deciliter for men and 50 for women, that is also a risk factor for heart disease, because it's not enough of that good cholesterol there to remove the bad cholesterol. So remember, we want high levels of HDL and low levels of LDL. So when we're interpreting the results of a cholesterol blood panel, we get the total cholesterol, which is just the total cholesterol is actually the LDL plus the HDL, and then you also add it to the triglyceride levels after you have divided those by 5, and then that's how you get the total cholesterol level. So desirable is you want it below 200 milligrams per deciliter, and then 200 to 239 is considered borderline high, and then over 240 is high. So the high category means that the patient has an increased risk for heart disease. Borderline high means that there's going to be an increased risk if there's other risk factors present, such as if the person is overweight or a smoker, or if they have a family history of heart disease. There's other things that increase the risk factors as well: diabetes, high blood pressure, lots of things actually. And then so when the patient's being prepared to get a blood draw to check their cholesterol levels, if it's just the total cholesterol and an HDL, fasting is not required, but it's usually a panel, a whole panel, which will include a lipid profile panel, right? So that includes the total cholesterol, the HDL, the LDL, and triglycerides, which are also important. So for half of those, the patient needs to be fasting. So we usually just have them fast and get the whole profile done at once, so they can get a nice, good picture of all of the cholesterol, the different types and the levels. Triglycerides are the fat that are in the blood, and your body uses those for extra energy, but if you have too many, they get stored in case they're needed later. But really high levels of triglycerides are not good at all for our bodies, particularly the pancreas. It tends to cause pancreatitis and bad things. So we want, the total cholesterol to be below 200 milligrams per deciliter, and then we want the LDL to be nice and low, and we also want the triglycerides to be low, and the HDL to be high. So again, the triglycerides are a type of lipid found in the blood that your body converts those calories from the triglycerides, right, that it hasn't used into the triglycerides, and then those are stored in the fat cells. And then hormones release the triglycerides for energy between meals. So if you regularly are eating more calories than your body's burning, particularly carbohydrates and fats, you're going to have high triglycerides because they're going to get stored in that form. Okay, so let's talk about glucose. So this is an end product of carbohydrate metabolism. So that means, you know, we're metabolizing our carbohydrates, and then at the very end, glucose is a product of that. So it's our main source of energy for our bodies, and our bodies want to maintain a constant and consistent blood glucose level to ensure a continuous source of energy for our bodies. They're very smart that way. So here in this illustration, you have an artery, you have the white blood cells, and then the red blood cells, and the little platelets, and then the little molecules of glucose there as well, floating around in the blood. So if we ingest more glucose than we need, it gets stored as glycogen, and it gets stored in our muscles and livers for later use for energy. So when no more space is available to store the glycogen, so we've completely filled up our glycogen stores, the excess glucose that we've eaten gets converted to fat and is stored as adipose tissue. So you'll often hear people say, you know, glucose is bad, it's so bad, you don't want to eat glucose. Well, we need glucose to function and survive. I mean, literally, you can't, it's like trying to drive your car with no gas in it. So we have to have glucose to even move our bodies or use our brain or function at all. But you definitely don't want more than your body needs. And everybody's metabolic needs can be different, you know, and they can change depending on your state of health and time in life. So it's kind of like trying to adjust that, you know, to stay healthy is the tricky part, right? Especially since glucose usually tends to come in forms that taste pretty good. So something that we also talk a lot about when we're talking about glucose is insulin. So insulin is a hormone that is secreted by the beta cells inside the pancreas. And insulin is needed to be able to use the glucose in the body as energy, right? So it's what allows glucose to enter the body's cells and then convert it to energy. So it's really super important, right? We also need it to store our excess of glycogen in the liver and the muscle so that we can use it later for energy. So we do blood glucose testing to check the levels and see how our bodies are doing at utilizing the glucose, right? So this is a really common test to, usually we're checking for diabetes, right? And so it's used to detect abnormalities in that carbohydrate metabolism. It can also indicate a condition called hypoglycemia, so low blood glucose, and then liver and adrenocortical dysfunction as well can affect the blood glucose numbers. So the testing comes in different methods. We can do a fasting blood sugar, which is known as FBS, and then we can do a 2-hour postprandial glucose test. Postprandial means after eating. And then we can do a glucose tolerance test, which is known as the GTT. So the fasting blood sugar is measured, obviously, when the patient's fasting. So a true fasting state means that they have not had any food or liquids for 12 hours. So anything other than water. And some places will tell you that black coffee is okay because it doesn't have any calories or glucose or anything like that that will affect the readings. But you want to be careful with that too. So really, I just tell people nothing but water for 12 hours before the test. So that evaluates, it just evaluates how well your body is, you know, processing and using the glucose. So it can be used to diagnose diabetes, but usually it's used to kind of check in on status of a diabetic patient, but you could use it as a routine screening as well. So if the glucose levels are high, then that means potential diabetes. So if the patient's fasting, you usually want to schedule that test for in the morning. So because people tend to get pretty cranky as the day goes on if they haven't eaten, since the evening before. So you think 12 hours, right? So if people have dinner at 7 p.m., by 7 a.m. the next morning, they're going to be hungry and ready for breakfast and cranky. So you want to get them into the lab or wherever they're going to be tested as soon as possible. So the fasting blood sugar normal range is 70 to 99 milligrams per deciliter. And then 100 to 125 is a little bit high, so that would be considered an impaired fasting glucose, which could be pre-diabetes. And then if it's 126 and up, that usually indicates that's enough criteria for diagnosis for diabetes. But it would usually be followed up with additional testing. So running another fasting blood glucose, and then we'll talk about in a little bit a hemoglobin A1C test. So there's other tests that they'll do usually before assigning the diagnosis of diabetes. Let's just go back and talk about that briefly. So we're going to be checking this on ourselves in the lab. We're going to do a blood sugar test reading. And so if you want to get an accurate result, an accurate fasting result, then just keep in mind you want to come into the lab fasting. But if you're not able to, don't worry about it. We can still run a random blood sugar test, and that'll still give us a little bit of an idea of how well our body's processing it. So just keep that in mind. The 2-hour postprandial test is used to screen for diabetes and then monitor insulin dosages in patients that are already diabetic. So for this test, the patient fasts from midnight until breakfast, so no getting up, in the middle of the night to have a snack. And then the breakfast meal should have at least 100 grams of carbohydrates. So it's actually a lot. So they have to kind of add them up on what they're eating. So it's going to be, bread, toast with sugar and cereal and juice, orange juice or something else with a lot of carbohydrates in it and milk. Or the other option is they can get a it's probably a prescription actually, a drink called Glucola, which has 100 grams of carbohydrates in it, which is a lot more than a normal cola. And then they give a blood specimen exactly 2 hours after consuming the high carbohydrate meal. So we're testing, again, how well our body uses those and stores those carbohydrates. So in a non-diabetic patient, the glucose level should be normal, checking that specimen 2 hours after a really high carbohydrate meal. Normal people can process all of that within 1.5 to 2 hours. So in a diabetic patient, though, they're unable to do that. So the glucose level is not normal. It's still going to be very high, probably over 140. Should be milligrams per deciliter. And so that would suggest diabetes and then would probably warrant further testing, possibly with the glucose tolerance test, the GTT. So this provides detailed information about the body's metabolism of glucose, and it can be used to diagnose diabetes, hypoglycemia, and then liver adrenocortical dysfunction. They also often do a test similar to this for as part of prenatal care for somebody who's pregnant to check for gestational diabetes. So I think we talked about this a little bit recently in that module. So fasting state, no food or drink, I would say probably 12 hours prior, drinking that really sugary glucose drink, and then testing the blood 2 hours later. And if it's high still, then that's a potential diagnosis for diabetes. One note is that, just a reminder, it's really important that your patient sits really, they have to just sit calmly and wait for those 2 hours between consuming the high carbohydrate meal or drinking the glucose drink, because if they're moving around, they're exercising, they're going to burn it off at a much quicker rate than if they're just sitting and resting. And so that's not going to help us know what their body's doing on average, right? So there's different forms of it, right? So for this one, they're going to have the patient eat a high carbohydrate diet 3 days before, and then fast coming in for the test for 12 hours. And then they take a fasting blood specimen and then a urine specimen, test them both for glucose. And if they're high, then that could indicate hyperglycemia, which would contraindicate administering a large amount of that glucose drink. So they might do this one first. It just depends, on the provider, honestly, and what their preference is. So if they pass, then they could drink the 100-gram of glucose drink. And then sometimes they'll even collect the specimens at different intervals, so that they know what a normal person, what their levels would be at, say 60 minutes after, or 120 minutes after, or 180 minutes, and then they can check the patient's levels at that time period against what they know should be normal, and see how they're doing, what their ability to handle the increased glucose is. So it's really important to make sure that each specimen is labeled with the exact time that they're collected, and that the patient's following those restrictions during the test. So, sitting quietly, no running around, no smoking, no eating, no drinking, all those things. It's really not fun. Yeah, so you can't eat or drink anything but little sips of water, because those will also affect the blood glucose levels. No smoking, as I said. The patient has to remain there and minimize their activity. Usually, you just recommend that they bring a book or, their phone, so they can listen to a podcast or something like that and just relax. There's definitely some side effects that are normal for patients to experience as their bodies are trying to metabolize these high levels of glucose, especially 2 hours and 3 hours in. So feeling weak and faint and perspiring is all normal. You just have to reassure your patient that it's normal, it's only temporary, it will pass. It's just due to the increase in the glucose levels in their body as the insulin is being secreted in response to that high glucose load. So recall that diabetics are not able to remove that extra glucose from their bloodstream at the same rate as non-diabetics, because their bodies are not making insulin in the right way. So for a non-diabetic patient, their blood glucose level is going to return to normal at each of those intervals, but that's not going to be the case for a diabetic. After they ingest the glucose solution, there's going to be high levels of glucose still present in their urine and in their blood, levels above normal because of the lack of insulin in their bodies. So management of diabetes. It's really, really important for diabetic patients to manage their condition well. And the main way they can do that is keeping blood glucose levels as close to normal as possible. So diabetic patients who maintain good blood glucose control generally experience fewer symptoms, and they can delay or prevent the long-term complications of the disease, which can lead to a longer life and a much better quality of life too, honestly. Diabetes is a very, very dangerous disease that people often underestimate. So tests for managing diabetes. 2 methods are usually used. The patient can self-monitor with a home blood glucose
monitor, and that's usually called a glucometer. And then also they can get routine hemoglobin A1C tests checked. That has to be, no, it's normally run in a lab. We do actually have a little point of care unit that measures that in our lab that you'll get to use next semester as a level 2 with just using the capillary stick on the finger, and can give you the A1C results, which can be very helpful too. So again, home blood glucose levels are measured using a glucometer, and the results are displayed in milligrams per deciliter. And diabetic patients should keep a record of their test results, just so that their provider can review it periodically, and it helps assist them with their management plan, especially if they are self-administering insulin. That's usually based off of their home glucometer test results. So often the MA needs to reinforce the advantages of the blood glucose testing to the patient, because they have to puncture their skin, right? So the patient has to assume the responsibility for their self-management decisions. So we have to kind of help them feel confident in that. Glucometers are often used in the medical office. Reminder that they quantitatively measure blood glucose levels because they give us a specific amount. And the fasting blood sugar is the most commonly performed test using the glucometer. The two test strips are reagent, and then the results are displayed as a digital readout on the screen in milligrams per deciliter. Okay, so just a really quick little side note about diabetes. I mentioned that it's very commonly underestimated. Oops. And but it can cause a lot of problems. It's very, very dangerous. People can lose toes, feet, limbs, due to it, insufficient blood flow from diabetes. It gives us an increased risk for heart disease and stroke. People have gone blind from diabetes before, from just not managing their blood glucose levels, for a chronic time period. So we often call that just managing their sugars, or sugars are well controlled or sugars are not well controlled. And especially over a long term, that can have devastating effects on patients. So it's really important that we, as healthcare professionals, reiterate that to our patients and encourage them to take charge of their own blood sugar levels when they're diabetic or pre-diabetic too. Okay, so the hemoglobin A1C test, this helps assess if the diabetic patient's blood glucose level is under control on a more chronic level, because this measures the amount of blood glucose over a 3-month time period. So it gives you kind of an average over 3 months, which is really great. So here we have a low hemoglobin A1C with very few sugars attached to the red blood cells, and then high, there's lots of sugars attached to the red blood cells, which is not good. Right, so those kind of collect cumulatively over about a 3-month time period. So this is known as glycosylation. That's the process of the glucose attaching to the hemoglobin on the red blood cells. And this occurs in all individuals. It's normal. And it forms a compound known as the hemoglobin A1C. So the amount of glucose that attaches to the hemoglobin is proportional to the amount of glucose in that individual's blood. So the more glucose in their blood, or the higher the glucose level, the more hemoglobin will become glycolated onto the red blood cells. So the higher the A1C level. So it's a really good way to check
to see how well the diabetic is self-managing their blood sugar levels. The glucometer just gives us an instant reading of what the blood sugar level is at that second in time, but that can change quite frequently. So when interpreting these results, a normal A1C level without, in somebody who doesn't have diabetes, basically usually would be 4 to 5.6%. And then from 5.7 to 6.4% of A1C, that's an increased risk for diabetes or pre-diabetic. And then 6.5% and above is typically how an unmanaged diabetic, A1C level would be. But it is possible for a diabetic, who's managing their blood sugar levels well, they can drop A1C level down to a normal range, with the use of, with the help of diet and insulin or other diabetic medications, right? So the ADA recommends that an A1C level of less than 7% for diabetics is what we're shooting for, right? Because then the patient has a better chance of delaying or preventing complications from the diabetes. So for every 1% drop in the A1C that a diabetic can lower it, there's a 35% reduction in the risk for the diabetic-related complications. So that's really huge, actually. That's a huge reduction for just a 1% drop in the A1C. It's pretty amazing. So here's some approximate conversion levels from, so for the A1C, if we're getting a result of 9, 10, 11, 12%, that means that the glucose level, which I'm used to seeing in milligrams per deciliter, is probably around 240 to 345, which is not good at all. 8% A1C with the 205 glucose is definitely cautionary. And so for a diabetic, if they can get their A1C to 6 or 7, that means that their blood glucose level is probably 135 to 170, then that's doing pretty good for them, at least according to the American Diabetes Association. So that is the end of lesson 19.1. Immunology testing. So immunology or serology is the scientific study of antigen and antibody reactions. An antigen is a substance that can stimulate the formation of antibodies in a person. So an example would be bacteria, viruses, bacterial toxins, allergens, and then blood antigens. An antibody is a substance that is able to combine with an antigen, which creates an antigen-antibody reaction. So laboratory testing in immunology deals with studying those antigen-antibody reactions. This is done to assess the presence of a substance, such as blood typing, or to assist in the diagnosis of a disease, such as mononucleosis testing. Okay, so examples of immunologic tests. Oh, gosh. So hepatitis tests are used to detect viral hepatitis. There's quite a few different types of viral hepatitis. A, B, and C are the ones that we're most familiar with. But there are 5 different types, actually, 5 different viruses that cause viral hepatitis, A, B, C, D, and E. Hepatitis basically is a liver infection, right, that causes inflammation and damage of the liver, which can cause this horrible yellow bloating of the liver, or cirrhosis, unfortunately. So the test determines the presence of the virus, and then it can tell which specific virus it is. So it can help determine which type of hepatitis. HIV test, that's another immunologic test that screens for the presence of the HIV virus. There's rapid screening kits that are now commercially available, so that's great. The negative result, though, is not necessarily conclusive for the absence of HIV infection. If an individual has become recently infected with HIV, the antibodies may not have had time to develop, so the test could come out negative even though the patient actually did contract the virus. So it can take anywhere from 2 to 12 weeks to develop the antibodies. So, or even up to as long as 6 months for the antibodies to appear. The rheumatoid factor, or RF, is a test done to screen for rheumatoid arthritis, which is known as RA, which is just an awful disease. You can see how it progresses, how it can progress. It's a chronic inflammatory disease that affects the joints and can just cause them to be disfigured and painful. So the blood of a patient with rheumatoid arthritis will contain the antibody known as the rheumatoid factor, or RF. So the presence of RF antibodies in the test would indicate, a positive test that the patient does have rheumatoid arthritis. Rapid mononucleosis testing. Mononucleosis is an acute infectious disease that is caused by the Epstein-Barr virus, or known as EBV. The EBV can actually cause a host of different chronic illnesses, but the most frequently contracted one is mononucleosis, which often affects children and young adults. It's transmitted through saliva by direct oral contact, so that's why it's known as the kissing disease, because, you could obtain it by kissing somebody who has the virus, or sharing straws, sharing drinks, or, in the case of young children or toddlers, they're always putting toys in their mouth and then putting it down, and then the next toddler comes along, puts it in their mouth. So that's the way they can contract mono. Symptoms are extreme mental and physical fatigue, fever, sore throat, severe weakness, headache, and then swollen lymph nodes and hands. So a rapid mono test is often performed in the medical office. It provides fast and reliable results. So individuals who are infected with mononucleosis produce an antibody called heterophile, and that's usually produced 6 to 10 days into the illness. So that's what the rapid test is detecting, is that antibody. Some other immunologic tests are blood typing, so ABO and RH blood typing. So this determines what type an individual's blood is. And the purpose is really, it's good to know that if the person needs a blood transfusion or a transplant. And so it's really important to know what type they are to prevent reactions. And then also RH, we talked about recently. That's one of the hemolytic diseases of newborns, so it's really important to type a mother and father for RH. So blood antigens. So every individual has a blood type, and that depends on the antigens that are on the surface of their red blood cells, or RBCs. So the antigens are proteins that are inherited through genes, and they appear on the surface of all red blood cells in the body. So there's two antigens, right? A and B. Here's a nice illustration here. Let's see. So they're grouped into categories known as blood group systems, right? So the ABO blood group and then the RH blood group. So you can have either A antibodies on your red blood cells, or B antibodies, or you could have a combination of both A and B. And if you have none of those antibodies, then you would be classified as type O blood. So within that system, as I said, there's 4 different types, A, comma, B, or AB together, or O. And the blood type depends on which antigens are present on the surface, right? So again, blood type A has antigen A on the erythrocytes. Type B has antigen B. Type AB has both antigens. And then neither antigens, so no A and no B, is blood type O. And blood type O is considered the universal donor because blood type O can be given to any other blood type, right? So again, A, AB, just B, or type O. So it just depends on the antigens that are present there. Did we talk about the reactions? Let's see. Yeah, so again, the antibodies are the proteins that are naturally present in the plasma, and they combine with the blood antigen. So you have the antibody that contains antigen binding site, and the antigen fits into that perfectly. So if a blood antigen and then its corresponding blood antibody combine, this can cause a very serious reaction, and it can be life-threatening. So that's why, so our bodies never produce a blood antibody that would combine with its own blood antigen. So if a person's blood type is A, and then there's blood plasma that contains the anti-B antibody, the anti-B antibody won't combine with the A antigen, right? So they don't fit together. So they cannot receive a blood transfusion of B or even AB blood, right? If you're type A, so you can only receive a transfusion from somebody who's the same blood type. So again, type A here, they can receive A blood. And then, as I mentioned, they can also receive O blood right here because that is universal. It doesn't contain any B antibodies either. But they cannot take AB or just B. So again, the antibodies present are going to be the opposite, right? So if you're type A blood, then that means you have A antigens and then B antibodies present in the blood. And then conversely, for type B, you're going to have the anti-A antibodies, you're going to have the B antigens, and they do not mix. Type O blood has both antibodies present, the anti-A and the anti-B, so that's why it has neither antigen on its surface. And then type AB also does not have, it has no antibodies because it has both A and B antigens on the red blood cells. So this can be confusing. But this little chart right here, I would say, is probably one of the best ones to memorize. You're going to want to make sure you know which blood type has which antigen and which antibody in the plasma. Okay, so which antigen is on the red blood cell and which antibody is in the blood plasma for each blood type. Okay, so make sure you memorize that. Here's another good little chart. Actually, this is a nice one as well. So you have the red blood cell type. Okay, so group A has the A antigen right down here. You can see that. Group B has the B antigen, right? And so it has the anti-A antibody. So it's always opposite. They're gonna have the opposite antibody from the antigen, except for in the case of AB. Because they have both antigens, they're going to have 0 antibodies. They're going to have neither. And then group O has no antigens, so it's going to have both antibodies present. Okay. So the other blood group system is the RH. Again, I believe that we covered that a little bit before, but we'll talk about it more. So RH was discovered by the scientists that were working with the rhesus monkeys, which is why it's called the rhesus antibody. So most people have the RH antigen present on their red blood cells, which means that they have RH positive blood, right? So if they have the antigen, then they're RH positive. So people with no RH antigen on their red blood cells have RH negative blood because they don't have the antigen. Okay. So it's another antigen in addition to either an A or B or both AB or neither in the case of type O. So it's separate from the ABO blood type group. So the antigen antibody reactions that occur in the blood, right, result in clumping of red blood cells. So this is known as agglutination. This can be very serious and fatal, especially if it occurs, if it occurs in somebody who's alive, it's serious or fatal. Because clumped red blood cells cannot pass through the small tubules of the kidneys. They can lead to kidney failure, and then it eventually leads to the complete hemolysis of the red blood cells or destruction of them. So it's very serious. So these reactions can occur if the wrong blood type is given to a patient during a blood transfusion. So, for example, if somebody has type A blood and they're given type B blood through a transfusion, the anti-B antibody of the patient would combine with the B antigen of the donor blood, and it would cause the red blood cells to agglutinate or clump together because the blood types are incompatible, and this can be fatal. So it can cause serious injury or death to the patient. Oh yeah, here's a good little donor chart here. So this is showing if the recipient has this type of blood, what donor blood can they give? Right. So as I said, the type O is considered the universal donor. And actually, I need to clarify that a little bit further. Type O negative, right? So the negative and the positive, that's talking about the RH factor. So each ABO type, again, either has a positive or negative RH factor. So O negative is universal. A donor with O negative can donate to every single other blood type, right? So they can donate to all the ABs, all the As, all the Bs, and all the Os, whether they're RH positive or negative. Now the O positive, so they have no A or B antigens, but they do have the RH antigen. They can only donate to the other positive blood types, right? So the other RH positive. So O positive can give to the AB positive, the A positive, the B positive, or the O positive. Okay. Oops. So this is another really good chart too, right? So the negatives, the RH negatives can give to their blood group type, whether they're positive or negative, but the positives can only give to a positive. So hopefully that makes sense. So agglutination is the basis for the ABO and RH blood typing. We always perform tests to see if the antigen or antibody reaction occurs. Obviously, in the lab, we don't want it to happen in the body, so there's no threat to life. So this would be blood typing. An anti-serum is used, so it would be a serum containing the antibodies, and that's added to the blood specimen. So, if we draw your blood and we want to type it, then we're going to add an anti-serum for each type. So in this example, we're adding the A antibody to your blood specimen. And then, so if the A antigen is present, then it's going to agglutinate, right? So we can see that occur in the lab in the test tube. So then we know that that patient has type A blood. So they just keep going down the line and adding the serum with all the different antibodies to see which one causes agglutination. So another example would be antiserum containing the B antibody is added to the blood specimen. And if the B antigen is present, it combines with the B antibody and it results in agglutination, which means that that is type B blood. Okay. And if agglutination occurs when they've added both an A antigen and a B antigen, antibody, then we know that it's type AB. And if no agglutination occurs when adding the A and B antibodies, then that means there's no blood antigens on that red blood cell, so that means that it's type O blood. And so when this is happening, we can actually see it, in the test tubes. You can see the red blood cells agglutinate and clump together. It's pretty amazing. So fun facts, is blood thicker than water? Yes, actually blood is about twice as thick as water normally, thanks to all the cells and other bits that float in it. And then how long does it take a drop of blood to travel away from the heart and all the way through the body and then back again to the heart? That can be anywhere from 20 to 60 seconds. So that's still pretty quick. So the amount of time that you've sat there listening to my lecture, a single drop of blood is already rotated through your body, and back to the heart. At least, what are we at, 19 times, if not, twice as many. And then is all blood red? So no, some crabs actually have blue blood because their blood contains copper instead of iron. So the iron in our blood is what makes it appear red. Earthworms and leeches have green blood because they have a substance called chlorocruorin, which is a byproduct of iron, so it causes their blood to turn green. And then other invertebrates like starfish actually have clear or yellowish blood because they don't have any heavy metal in their blood like we do. And this is a little shameless plug to consider becoming a blood donor. You can donate your blood and make a huge difference and support the blood bank. Okay, so that's the end of 19.2. Hey students, Instructor Hannah here, and this is going to be our very first injection lecture. Okay. So, welcome to injections, injection basics. So, giving injections is both a skill and an art. And we must have the knowledge to give injections correctly. We need to be able to build a rapport or a relationship with our patient and their family. We need to have effective communication. We must be able to inform our patient what we are giving them and what it is for. It's really important to be able to provide comfort, especially to pediatric patients. We must work safely, and we must document correctly. Medical assistants and the law. Remember that a medical assistant must work under the license of either a physician or a nurse practitioner or a physician assistant. Not only immunizations, but all medications that we administer and tests must be ordered by a licensed provider, such as an MD, DO, NP, or PA. And we must have this order before administering a test immunization, medication, anything. The ordering provider should ensure our competency in administering the medication or immunization correctly. And mistakes must always be reported to the ordering provider as well as your supervisor. Now, mistakes will happen. We are human. It happens. The most important thing is to not be too scared, nervous, or embarrassed to report it, because not reporting it will do much more harm to the patient and to ourselves. Okay? Why do we give injections? One is for disease prevention, such as vaccines, immunizations. We do tuberculosis testing by injection. There's certain injections we need for school, work, camp, travel immunizations. If you're going to a certain area of the world, then you need certain immunizations. Allergy testing and treatment. Diabetic treatment, such as insulin. Anticoagulant treatment, which is a blood thinner. Heavy-duty antibiotics we can give via injection. These will start working much faster than oral antibiotics. We can give vitamin injections if somebody's very deficient on vitamins. We can inject hormones. And then the standard treatment for anaphylaxis, epinephrine, is often given via injection. Okay, so let's have a little review of our bloodborne pathogen terminology. Remember our BBP from last semester. Pathogenic means that something's capable of causing disease. A pathogen is a microorganism that produces disease. So those two are kind of intermixed, right? A bloodborne pathogen is a pathogenic microorganism that's in human blood that can cause disease. Asepsis means that something is free from infection and pathogens. Medical asepsis, this is a practice that we use to reduce the number of and lower the transmission rate of pathogens. Hand hygiene is the process of cleaning or sanitizing our hands. Antiseptic is an agent that's applied to body tissue or objects that can kill disease producing microorganisms. Parenteral means that something's taken into the body through piercing of the skin or the mucous membranes. So basically needles, right? Injections. Contaminated means that there's the presence of blood or other potentially infectious materials on an item or surface. Remember, we call those OPIM. A safer medical device. This is a device that would make an exposure incident involving a contaminated sharp less likely. Personal protective equipment, or PPE. This is clothing or equipment that protects an individual from contact with blood or other potentially infectious materials. OPIM. Occupational exposure. These are reasonably anticipated skin, eye, mucous membrane, or other parenteral contact with blood, or OPIM, that result from the performance of an employee's duties. So occupational means at work. An exposure incident is when a specific incident occurs, something with the eye, nose, mouth, other mucous membrane, non-intact skin, or parenteral contact with blood, or OPIM, that results from an employee's duties. So these two can get confusing often. So occupational exposure is basically the risk, right? So we know as medical assistants that we are faced with occupational exposure every day. The risk is there of becoming infected with blood or OPIM during our jobs, doing our duties. So that's the occupational exposure. So it's reasonably anticipated that this could happen, right? I can go many years without having an exposure incident, even though I have occupational exposure every day. So when that actually happens, that is the exposure incident. When something actually occurs and you are, in reality, potentially infected. Okay, so OSHA is the Occupational Safety and Health Administration. This is the governmental body that established the bloodborne pathogen standard in 1992 to help employers provide a safe and healthy work environment for employees and reduce their risk of exposure to infectious disease. So, standard precautions, more review. These are a set of infection control practices issued by the CDC to help prevent infections in healthcare settings. The standard precautions include hand hygiene and gloves to prevent transmission of diseases that can be acquired by coming into contact with blood, body fluids, secretions, excretions, non-intact skin, and mucous membranes, as well as rashes. There's a typo right there. These measures are used when providing care to all individuals, whether or not they appear infectious, whether they have symptoms, whether you know if they have HIV positive or not. Okay, so we always apply standard precautions every time we see a patient, no matter what. Okay, we treat them all the same as far as hand hygiene, wearing of gloves, etc., to protect them and protect us. We don't need to go digging around in their chart to see if they have any communicable diseases, because we just always use standard precautions. So we're always safe. So doing this reduces the risk of transmission of microorganisms from both recognized and unrecognized sources of infection. Under standard precautions, blood and certain body fluids of all patients are considered potentially infectious, right? So it doesn't matter if I looked at that patient's chart last week and I ran an HIV test on them and it was negative. If I'm drawing blood again this week, I am going to consider it potentially infectious. Okay. So aseptic technique, that is a set of specific practices and procedures that are performed under carefully controlled conditions with the goal of minimizing contamination by pathogens. The purpose is to maximize and maintain asepsis, which is the absence of pathogenic microorganisms in the clinical setting. The goal is to protect the patient from infection, and us too. We'd like to be protected as well. Engineering controls. These are controls that isolate or remove health hazards from the workplace to eliminate or minimize the risk of occupational exposure. Remember, we always have that risk, but we can have controls put in place to help eliminate or minimize the risk, such as having hand washing facilities easily accessible, having safer medical devices, having biohazard sharps containers close by, using biohazard bags. Okay, those are the engineering controls. Work practice controls, these alter the manner in which a technique is performed to reduce the likelihood of exposure. So both of these are to reduce risk of exposure, right? But these are things that we actually do. Okay. Engineering controls are things that we use or things that we set in place. And work practice controls are something that we are practicing, okay, such as observing the biohazard warning labels. Okay. Putting bandages over any cuts that we might have on our hands before putting on gloves to treat our patient. Sanitizing our hands before and after every single patient contact. Those are our work practice controls that we do every day, all day long, to minimize risk. Wearing appropriate PPE, personal protective equipment. Never remove, recap, or bend a contaminated needle, right? Just don't do anything with it. Once your needle is contaminated, The only thing you should ever do is put it in the sharps. Immediately disposing of contaminated needles in a biohazard sharps container. So these are things that we can do, that we can control, that minimize our risk, right? So these are kind of like actions that we get to put into place every day. You should never, ever store your lunch, food, drinks anywhere in the lab, okay? None of the refrigerators, freezers, cabinets, or shelves where any blood, OPIM, or honestly any medications, vaccines, nothing, okay? No food or drink should ever be in any lab area, ever. Okay, and then if exposure does occur, make sure you perform first aid measures immediately. That is always the first thing you should do, right? If you get an accidental needle stick, you're not gonna drop the needle and run and go show your boss, right? You're going to perform first aid first, immediately. Okay, so infection control principles. The MA should always follow both the standard and universal precaution guidelines. The MA should always use aseptic technique. Hand hygiene should always be performed before and after contact with a patient. And selection of our PPE will depend on the type of patient interaction, okay? If you're working in a more hospital type setting, it's going to depend on what precautions that patient is on, right? If they're on droplet precaution, airborne precaution, etc. Always, always wear gloves when handling any blood, any body fluids, and non-intact skin. Okay, so we have our use sharps disposal guidelines. You will go over this in the lab with Ashlyn as well. So all of our needles in the lab have safety devices on them. Okay, these are engineering controls to help keep us safe. These should be activated immediately after use of the needle and immediately discard the whole thing, needle and syringe, in a sharps container, right? So you're going to give an injection, you're going to withdraw, you're going to activate your safety, and you're going to put it in the sharps. All just kind of one smooth motion. The sharps container should always be leak-proof, puncture-resistant, and either red or orange, something really bright, right? And they should always be labeled with a biohazard label. Used needles should never be recapped, bent to the side, cut, or removed from the syringe. Don't ever mess with a used needle. And don't ever overfill those sharps containers, okay? They need to be locked up and discarded after they're 2/3 of the way full, or when the contents are at the full line, which is indicated on the containers, should be about 2/3 of the way full. All right, so let's go over some key terms of injections. A drug. So this is what we refer to any chemical that we use for treatment, prevention, or diagnosis of disease. Okay, so I know it can be a little strange, to go to work and hear people talking about drugs. Well, what drugs have you tried? What drugs have you given them? Because we just immediately assume that we're talking about something illicit or illegal or something you buy on the street corner or something, right? So in medicine, drugs are what we give patients every day, all day, right? So it's not a bad word at all. Dose is the quantity or amount of the drug to be administered at one time. So each administration has a specific dose. A vial is a closed glass or plastic container with a rubber stopper that can hold either single use or multiple doses of a medication or immunization. An ampule is a small sealed glass container that holds a single dose of medication. Reconstitution is the process of adding a liquid to a powdered drug. Okay, so some drugs are manufactured in powder form because they last a lot longer and they don't go bad, So you reconstitute it right before you administer it. Make it liquid. The diluent is the liquid that is used to reconstitute a powdered drug, and it's usually sterile water or saline. Okay, so there are 3 injection types. Intradermal is when the medication is being introduced just into the dermal layer of the skin. Intramuscular is when the medication is being administered into the muscular layer of the body. And subcutaneous is when that's administered beneath the skin and then into the fatty layer of the body, which is adipose tissue. Okay, so it's in between the dermal and the muscular. Okay, so here's our parts of a needle and syringe. We have the hub. This is the needle right up here at the top. The base is the hub. The hilt is where the metal needle part meets the hub. The lumen is the opening on the end. It's kind of an oval shape. Then you have the point at the very tip that's sharp. The bevel is includes the lumen and the point. So it's all of them, both of them together. And then just the long part is the shaft. In the syringe, you have the plunger. You have the flange, which is the part that you should always hold it by. Okay. You have the barrel, which is the part with all the measurements on it. And then you have the tip here. Okay. Some of the syringes you'll see have a luer lock mechanism. So actually the tip actually has kind of some threadings on it, like a screw. And the hub of the needle will have the threadings that match on the inside so that it actually screws into place on the syringe. Okay, so we discussed all of those. I was always taught this too, that all injections should be given with the bevel facing up. There's some, and that is true with intradermal injections, always bevel up. But as far as subcutaneous and intramuscular goes, we'll look at the data a little bit more, but I don't think there's any data that shows that that's true. So we can talk about that more. Okay, so when we talk about needles, we are always talking about 2 things. The length, which is how long the needle is, right? So we have really, really short needles and we have really long needles, okay? And this is going to depend on what type of injection we're giving, right? So do we need that needle just to get into the dermal layer? Do we need to get it down further into the subcutaneous level? Or do we need to get it even further into the muscular level, right? So we're going to pick a needle accordingly. And then the size of the patient has a lot to do with it, right? So if I'm, want my medication or immunization to end up in the muscle, in the deltoid muscle of a patient who's very, very, very thin and has very little muscle, I'm not going to use the same size needle as I am as a big, 200-pound guy with big muscular arms, right? And then the gauge, okay? The gauge is the needle opening or the diameter of the lumen, right, which is the opening. And so this can be confusing because the larger the gauge, right, so the higher the number, actually means the smaller the diameter is. And then the smaller the gauge, so the lower number, means that it's bigger, okay? So the 18 gauge right here is actually pretty darn big. You're really not going to put that into a human patient, not too likely. These are great for drawing up really thick, viscous medications that you may have just reconstituted, and then putting on a smaller needle that's appropriate for your patient size, right? And then 25 gauge is kind of standard. That's a pretty reasonable size. Okay, I think we talked about all of those as well. Okay, So the hypodermic syringes, these are used most oftenly to administer IM injections, intramuscular. Okay, and typically the barrel, the amount that it will hold will be 2 mLs, 3 mLs, or 5 mLs. Okay. You'll also see it calibrated in cc, which is cubic centimeters. Milliliters and cubic centimeters are equivalent, right? So 1 ml is the same as 1 cc. Okay. Yeah, cc's, that's kind of an older term, and you don't see it as often. Milliliter or ml is more commonly used. So this is a 3 ml syringe. That's the total amount that we can put in there. Okay. We also have insulin syringes in the lab, and your very first injection, you're going to be injecting yourself subcutaneously in the abdomen with an insulin syringe, just like diabetics do every day. Okay. But insulin syringes are calibrated special. They are calibrated in units, which is different than a milliliter or a cc. Okay. So typically you'll see either a 100 unit syringe or a 50 unit syringe. Okay. If it's in 100, usually each tick calibration is 2 units. And if it's the 50, then they'll usually be in increments of 1. Every insulin syringe that you see should have an orange cap on it, okay, to indicate that it's an insulin syringe, and you should not be using it to draw up a regular medication or immunization. Okay, so we also have special tuberculin syringes, right? And these are what we use most commonly to administer the Ma125 PPD, purified protein derivative tuberculin tests. These are the old school TB tests for tuberculosis that we do intradermally, right? And they make that little wheel. And you've all probably had it done before. So these are very small. Their capacity is 1 ml, and their calibrations are divided into tenths and hundredths of that milliliter. Okay, so we give a very small amount of medication. For the PPD, if we're administering a PPD, it's always just 0.1 mLs. So it's actually quite bigger than we even need it to be, but they're pretty small. Okay, so vaccine information statements, the VIS. All right, these are put out by the CDC, and they are updated periodically. They're always going to have a date on them. And so you have to make sure that you are always giving it to your patient or your patient's caregivers, parents, or whoever their guardian is, legal guardian. It's required by federal law, okay? There's the National Childhood Vaccine Injury Act of 1986 that says that we have to provide this to the patient, okay? It provides information about the benefits and the risks of the vaccines. We should be giving this to the patient before we administer the vaccine, right? It doesn't really make sense to administer the vaccine and then say, here you go, now you can read about the risks and benefits of it, but you already have it. So how can people make an informed decision, right? It usually answers most of the patient's questions or the parent's questions, or it will bring up questions for them that they can then ask the provider for clarification. It includes information on potential reactions, kind of like the most common ones to be on the lookout for. So any provider that gives vaccines must give a VIS, okay, to the patient or the parent or legal guardian before administering the vaccine. This is very important. Each and every time the vaccine is given, right? So not just with the first dose. If you're getting the Hep B or Hep A series, you should be provided with that VIS every single dose, okay? And we have to document that. We have to record and document in the medical record that we gave the vaccine, the VIS, and the date on the VIS, right? The most recent version. We always have to give the most recent version. Make sure you're not giving an expired version, okay? That must be documented. At PAMF, you'll see they have them sometimes laminated in the exam room, right? And so then they'll hand it to the patient to look at while they're going and preparing the vaccine, and then come back, and then they can just take it back and put it back on the thing in the wall. They can reuse it, right? They can sanitize it, reuse it over and over, because most people don't actually want to bring the handout with them home. But of course, they should always be given that option. If they want to actually take a paper handout with them home, they should be provided that. Okay, so we're going to take a little break here before we move on to injection guidelines. Okay, we're back. So, injection guidelines. Always work in a quiet and well-lit atmosphere that is free from distractions. Okay. Always ask if you have a question about the medication order. So ask the ordering provider. Don't just guess. Don't go, oh, I'll figure it out later. Always ask the questions first. You need to be familiar with the drug that you've been ordered to give, okay, and know the abbreviations for it. You should know any common side effects, all the things, right? If you're ordered to administer something that you are not familiar with and you've never given before, which is going to be the case when you guys are first getting out there, stop and look it up, get to know it, right? Grab a PDR, physician's drug reference. Most of the electronic medical records where most of your orders are going to be coming through will have links in there, like a lexicomp, where you can look up the drugs. Okay. Always perform hand hygiene before preparing, administering, and after giving your injections. Okay. Always prepare all medications using medical aseptic technique. Okay. And I just want to go back to number 1 here. Most facilities will have a designated area with big signs that says quiet, quiet med prep area, something like that. And it's kind of off, hopefully, not in a high traffic area, because the studies have shown that most mistakes occur when people are preparing a medication and they get distracted or they get rushed because there's a lot going on. It's busy, it's a busy urgent care or something, or their coworker comes up and starts talking to them, asking them about patient in patient room 4, but they're preparing a med for the patient in room 8. Get confused, mistakes happen. So hopefully where you go to work or do your externship will have a designated area. Quiet, lots of good lighting, free from distractions. Okay. Make sure you always select the proper drug according to the order, right? We're always going to do 3 checks of the drug and make sure it's the right one. If you're not sure, ask. Okay. You're always going to check the expiration date, right, before preparing the drug. Make sure it's not expired. Don't use it if it's expired. Don't use it if there's a missing label or if it's difficult to read, if it's been like scratched off. You're going to inspect the color of the medication as well. If it looks off, might have gone bad. If there's any precipitate in there, anything chunky, floating, anything that looks unusual, strange odor, don't use it. It's really important that you prepare the proper dose of the drug, right? That you administer the exact dose that's ordered. You make sure you check that 3 times. And then you should label the injection with the patient's initials, the name, the dose, manufacturer, lot number, expiration date. Yeah, a lot of ones are kind of nice. They'll have little stickers with that information on it, so you can just grab it. But yes, you will need all of that information in order to document in the patient's chart once the injection has been administered. Okay. You're going to go to the room, the patient's room, sanitize your hands, right? Ask the patient to state their full name and date of birth. Now, let me backtrack just a step. Okay, so if you are giving a single, if what you're giving comes in a single dose A lot of flu shots come already drawn up and prepared in the syringe. It's amazing. It's so wonderful. Okay, so all you have to do is go grab it, take it to the patient's room, done, right? You don't have to draw it up or anything like that. Okay, there are some that come in single dose vials, right? You can take those into the patient's room and prepare it there in front of them, all right? Multi-dose vials, so anything there where there's enough doses in there for 10 patients in the vial, those always have to stay in the preparation area where they are stored. Okay, you cannot ever take a multi-dose vial into a patient's exam room. It's now contaminated and no other patient can use it. Okay, so those you prepare in your quiet, well-lit area. Single doses you can prepare in the exam room in front of the patient, okay, as long as your site policy supports that. I actually prefer to do that, but it's, there might be policies. Just check that. Okay. You're going to check the patient's medical record. You're always going to ask them about any allergies, right? Any allergies to drugs, immunizations, anything like that. And you're going to check the record too, because people forget. So some people don't even know, like pediatrics. You're going to determine the appropriate route and site. Okay, so the order should have specified what route you're going to use, or if it's a flu shot, you know what route to use, right? It's an intramuscular. If you weren't sure, you didn't know, check the product insert, right? It'll tell you. It'll tell you the appropriate route to use, and it might even tell you what site you should use, okay, to administer the injection. So make sure you know what you're doing there. You're going to prepare the patient's skin, right, usually with an alcohol prep wipe. Apply clean, disposable gloves, always, always. Administer the injection using proper technique. Lock out the safety, dispose it in the sharps, okay? Attend to the patient. Sometimes the little blood comes out, okay? You're going to put gauze on the blood, put a little bit of pressure on there, make sure it's done bleeding, put a Band-Aid if they want it, okay? Make sure they're okay. Oftentimes, you're going to have them wait for 15 minutes before they leave to make sure they don't have a reaction, okay? And then you're going to immediately document the procedure, right? So that your timestamp is there and you're going to document all of the information. Okay, so we always perform 3 checks. Okay? Anytime we're giving a medication, immunization, anytime we're giving anything to a patient that they're putting in their body, you check it 3 times, okay? First time you're going to check it is when you take it out of the shelf or out of the fridge, wherever it's stored, okay? You're going to take it, you're going to look at it, you're going to check it against your order. You're going to make sure that the name matches perfectly and the appropriate dose matches perfectly, or amount, milligram strength. Right? You're going to check the expiration date, and you're going to check the integrity of the medicine itself, like we talked about. Color, clarity, the vial, make sure it doesn't look tampered with. Then you're going to take it to the area where you're preparing it, okay? And you're going to check it again. So before you draw it up, before you mix the diluent in, you're going to check all of those things again, every single one, okay? Checking the order, making sure that it matches your patient's name and the medication. Then you're going to prepare it, right? If it's an injection, you're drawing it up. If we were giving oral medication, right, you're pouring it out into med cups, something like that, okay? And then you're going to check it again, right? And so if it's a multi-dose vial, you're checking it a 3rd time before you put it away. Always do your 3 checks. If you do that, most of your mistakes will be caught, okay? Same with the 7 rights, right? We always want to follow the 7 rights, okay, each time we do a check. So we're checking all 7 of these 3 times for 3 checks. Okay, so we always want to check and make sure we have the right patient. Are you John Doe? Okay, good. My order is for John Doe. Okay, we're always going to check the dose. All right, okay, I'm giving 1 milligram. The order says 1 milligram. Okay, is it the right drug? Right, this is for, I don't know. What would we get? Flu shot, right? Influenza vaccine, okay? The order's for an influenza vaccine. this is an influenza vaccine I'm holding here that I'm going to give. Okay. Is it high dose, right? Make sure. Okay. Check the right route. All right. Make sure that the order and then the medication that you're giving, the route indicated, is what you're going to do. Okay. What you're getting ready to do. And the right route also includes that you're using the right technique for that route. Okay. Which is what you'll learn in lab. Make sure it's the right time. Okay. So this means that if you're giving a vaccine to a pediatric patient, you're responsible for checking and making sure that it is that they're correct age, right? So you're going to have the charts from the CDC as far as the correct age when they can receive those vaccines. Okay, don't just rely on the provider. You're the one giving it, so you're the one who's ultimately responsible for it, right? You could catch a mistake that the provider might make. Okay, if it's vaccines that are given in intervals or medication that's given in intervals, such as the depot, right? The birth control injection, right? Depot, I think we give every 3 months. Okay, you need to check and make sure, when was the last time this patient got it? Is it the appropriate time interval, right? Make sure it's not too soon or too late for the vaccine, in which case call attention to it to the provider. Okay. Checking the right time also means checking the time on the drug, right? Making sure that it's not expired. Okay. And then our last one is making sure that we document it correctly. Okay. So my little mnemonic for the 7 rights, because you should always have these memorized, is patients do drugs round the day. Okay. Patients, the right patient, do, dose, drugs, drug, round, route, the, time, day, documentation. So it's PDDRTD. Patients do drugs round the day. Okay, hopefully that helps you remember it. Come up with your own if you like. Okay, so we might be documenting on paper. Okay, we definitely documenting electronic. Pretty much every facility you go to should have electronic medical records. And then you might be documenting on an immunization card like this. I have one like this. People old like me have these. But make sure you do it. Make sure you're documenting the date and time given, the name of the medicine, the dose that was given, the route that you gave it through, the site that you used, right? You always want to document left deltoid, right deltoid, left forearm, right forearm, okay? Wherever you administered it. The manufacturer name, okay, it's going to be on the medicine. The lot number, every single medicine has one, okay? The expiration date, you need to document that, okay? Any unusual observations, any unusual patient reactions, you're going to document, okay? And your name and title, right? So Hannah Forbes, certified medical assistant, you're going to make sure that you document that as well, okay? Now, a lot of electronic medical records will automatically, put in your name and title on your documentation. They'll automatically date and timestamp, right? Which is very handy. But you always need to make sure you're documenting all of these things. If you didn't document them, they didn't happen, okay? If your patient has a reaction later on, the lot number, expiration, manufacturer name, these are going to be very, very important to track, right? And it's very, very important to protect yourself as well, that you can prove that you gave the correct medicine, okay? So patients don't try and blame you, say you gave them the wrong thing. Okay, and we're always going to document the VIS that we gave to the patient and the most current date of the VIS that we gave them, right? The dates, it'll be printed on there. Okay, and we're documenting the date that it was given to them. Should be the same date that we're administering the vaccine, right? That would make sense. Okay, here's an example of how you would document on a paper chart. Okay, you have your date, you have your time. This was an MMR. And it was 0.5 mLs, so that's the dose, route, sub-Q, site, right upper arm. The manufacturer was Merck. Here's the lot number. Here's the expiration date, how the patient tolerated the procedure. The VIS with the date on it was given to the patient, right, on this day with your sign off. Okay. Initial of your first name, comma, last name, comma, your credentials. In here, you will be SMA, right, student medical assistant. Okay. Thank you. I think that is the end of injection basics. We'll see you next time. Hey there, students. It's instructor Hannah here, and we're going to talk about subcutaneous injections. So these are usually known by sub-Q or SQ for short. And these injections are given into the fatty layer underneath the skin. And it's used for smaller doses of non-irritating drugs. Okay, so the volume in your syringe must be smaller than 2 mLs. Okay, so you have anything greater than 2 mLs, it shouldn't be given into one site and into the same subcutaneous layer. Medication that's injected into the fatty tissue is absorbed much more slowly than when we administer into muscular tissue. Okay, so this is really important to know the differences, right, of why are we giving something in the subcutaneous layer and why are we giving it in the intramuscular layer. So absorption is much more slow in fatty tissue, okay? And that's because there's very little blood flow to fatty tissue, right? And muscle tissue gets a lot of blood flow. So it's absorbed more quickly in the muscle. Okay, so just a little overview of our sub-Q injections. Most commonly given are insulin, heparin, allergy shots, vaccines, epinephrine, and some infertility drugs. So the route is the fatty or adipose tissue underneath the skin layers. We're going to typically use a 1 ml to 3 ml syringe, or we're going to use a special insulin syringe that, recall, is measured in units. And the needle gauge most commonly is 25, but it could be 23 to 25, okay, depending on the size of the patient. Insulin syringes are much smaller. Typically, they are 29 to 31 gauge. So remember that those big numbers there, 31 is really, really small, right? And the 23 gauge is bigger. Standard length for a sub-Q injection is 5/8 of an inch long, the needle. But insulin syringes are shorter than that. They're 1/2 an inch. And for newborns, we're going to use smaller needles as well. Okay, so the most important thing is that the needle is the right length, okay, that it gets through the dermal layers into the sub-Q tissue and doesn't go through the fatty tissue to the muscle. All right, so it really depends on the size of your patient and the site location and how much adipose tissue there is there, and how much adipose tissue your patient has, okay? So typically we're gonna inject at a 45-degree angle to ensure that we get through the dermal layers into the subcutaneous tissue where the fat is, and we're not hitting the muscle tissue. Okay, so for a 5/8 inch needle, we're pretty much always gonna go 45-degree angle to the skin surface. Okay, if we're using a small needle, the 1/2 inch,
which would be for insulin or heparin, we're just going to go straight in at 90 degrees. That's usually given in the abdomen and the belly fat. So even the most skinny people, you can usually find a little bit of that if you scrunch it up. Okay, so typically we're just giving 0.5 ml to 1 ml, so 0.5 to 1. Again, we're not ever going to give more than 2 mLs in one syringe in one injection site at the same time. Okay, we're always checking our medication 3 times, right? We're always doing our 3 checks of our 7 rates. Okay, so insulin. We're going to talk about insulin because a lot of your patients will be taking insulin. Now, in the state of California, it is not within the scope of practice for medical assistants to administer insulin. But there are other states that I believe it is. So that's why that's another reason why we're going to talk about it, because you're, when you're done with this program and you get certified nationally, you could go move to any state and go work wherever, right? So we want to make sure that you're well prepared and you know everything you need to know. Okay, but just remember that when you're going to your externship site and when you're working in California, you're never going to be giving insulin. Okay, insulin and heparin are both very high risk drugs. Okay, there's a high risk of causing great harm to your patient if given incorrectly or if the dosage is given incorrectly. So it's really out of our scope of practice. Okay, but insulin is always measured in units, should always be stored in the refrigerator. You always want to use a special insulin syringe. Okay, usually when we're giving insulin in the hospital, okay, as a nurse, we're giving 2 different types and typically mixing them. One is a short acting and one is a long acting, just for your information. The abdomen is usually the most common site and easiest to get to, and where even, like I said, the skinniest of patients have adipose tissue, and it's absorbed more quickly there. And you're never going to rub or massage the site after the injection, especially with heparin. Okay, so again, abdomen's the preferred site. You never want to give it closer than 2 inches to the umbilicus, the belly button. And with these, you always want to rotate the site, so you never want to give it in the same site, every day. You want to inject this drug slowly and leave the needle in place for 10 seconds after injecting and then withdraw it. And you never want to rub or massage the site after a heparin or insulin injection. Okay, so let's talk about vaccines, how much we need them. Okay, so there's some diseases that are still common in the US, such as varicella, pertussis, hepatitis B, and influenza, pneumococcus. Okay, and it's kind of cyclical, right? When there are lower immunization rates for these diseases, the cases go up, right? Less people are immunized, so more people get them. And you can see it on graphs. And the 2 are directly correlated. Okay, specifically measles and mumps and Hib. We've seen those increase over the past 10 years or so. International travel, right? You always want to make sure that you've got immunizations for polio, rubella, diphtheria, measles, mumps, because just a plane ride away, you can go to a country where these diseases are running rampant, right? They're very prevalent. And then tetanus, we will never be able to eradicate, right? It's always there out in the environment, unfortunately. But we can protect ourselves really easily by getting a tetanus vaccine. Okay, here's a long list of diseases that are preventable by getting a vaccine. It's pretty cool, right? You don't have to memorize this list, okay? But just be aware, right, that there's a lot of them, a lot of diseases that we can prevent with immunization. Some of them are kind of awful, right? Like whooping cough, that's horrible to see. Tetanus in a baby, scary. This is a really extreme case of varicella or chicken pox that looks horribly painful. Polio, that's another one, really awful, debilitating, crippling, right? Measles, influenza, yeah, we all get it, right? So the best thing you can do to protect your health and your patients is cover your bases and get all your immunizations, right? So our most common ones are Tdap, influenza, hepatitis A, hepatitis B, varicella, MMR, that's the measles, mumps, rubella, it's a combo vaccine. So is the Tdap actually. Tdap is tetanus, diphtheria, and pertussis. Okay, pertussis is whooping cough. That's another one that we had a outbreak of in Santa Cruz, I remember maybe about 5 years ago. That's a horrible one for little kids to get. And then of course COVID-19, which we've all heard a lot about lately. Okay, so let's talk about vaccine safety. So vaccines are held to the highest standard of safety for pretty much for anything that the CDC reviews and the FDIC. The US has the safest and most effective vaccine supply in history. So that means based on the vaccines that we have and the vaccine injury rates, ours are the lowest. Vaccines have to undergo typically years of testing before it can be licensed, right? So even the COVID-19 vaccine is not technically licensed yet, right? It's approved under emergency use, but it takes years and years of testing before it can be licensed. And then once that happens, they're continually monitored for their safety and effectiveness. Okay, so it's not just a one-time thing. But just like any medication, any drug, any procedure, anything that we do to our patients, they can cause side effects. Okay, so that's why we always give our patients the VIS, the Vaccine Information Statement, so that they're well informed about the typical, and possible side effects. Usually they're pretty mild, but you want to make sure your patients are informed. Okay, for each and every single vaccine that they're getting. That way they can review the risks and the benefits, right? So the main thing with anything we do in medicine is that the benefit has to be greater than the risk. Okay, so if we're talking about a very risky procedure and it has a very low possible benefit to the patient, typically, a physician is not going to move forward with that. So they have to weigh that cost first for them because they don't want to harm their patients, right? And then the patients really need to weigh that as well, even if they're given the option of doing something that has a low benefit but high risk. Okay, and so bottom line, vaccines and immunizations have a very high benefit and a relatively low risk. Okay, so that's the most important thing to remember with everything in medicine, but particularly vaccines because they are kind of a controversial topic. Okay, I'll get off my soapbox. So when we're documenting our administration of a vaccine, here's an example, right? You always want to put down that you gave the patient the VIS and the date on it. Okay, that always has to be documented. And typically you're going to have the patient or the parent sign a consent form prior to giving the vaccine, right? Okay, so there's different types of vaccines, and each one is designed to basically teach your immune system how to fight off those germs and diseases that it's designed for. Okay, so when they're created, the factors that are considered is how your immune system is going to respond to the germ and who needs to be vaccinated against it, and then what's the best technology or approach for delivering the vaccine. And then the type relies on these factors. Okay, so there's now 6 main types of vaccines. There are live attenuated, inactivated, toxoid, subunit, which are recombinant, polysaccharide, and conjugate vaccines, mRNA vaccines, and then viral vector vaccines. So we'll just touch on each of these a little bit. So the live attenuated vaccines use live viruses or bacteria, but they have been weakened. Okay, so they're kind of diluted, and that's what attenuated means. It means that they've been weakened. So they're live, but weak. Okay, and this is done by repeatedly culturing the bacteria or virus. So it's rendering them unable to actually cause the disease, but it can still stimulate your immune response that can protect against future infection. Okay, so protection from a live attenuated vaccine lasts longer than those by a killed or inactivated vaccine. So they're more effective. Okay, so examples of these are the MMR, measles, mumps, rubella, varicella, the nasal influenza, the zoster, which is shingles, and then rotavirus. So inactivated vaccines do not contain any live viruses or bacteria. They are killed using a chemical treatment or high heat. So they are unable to replicate, and they can no longer produce the disease in the body, but they still stimulate our body's antibody production, which create immunity to the disease. And these ones always require multiple doses because they're not live, right? So it takes a couple opportunities of introducing this killed virus or bacteria into your body in order for it to create the antibody production. So examples are the inactivated polio, which is IPV, hepatitis A, and the rabies vaccine. Okay, toxoid vaccines. These are for the bacterias that the diseases that are not actually caused by the bacteria itself, but by a toxin, like a byproduct that's produced by the bacteria. Okay, so these immunizations are created using the inactivated toxins from the bacteria. So these are considered inactivated vaccines. They're very similar to the last ones that we talked about. But they're given their own category because they contain the inactivated toxin, not actually the bacteria itself. So examples of this are diphtheria and tetanus. Okay, and those are usually part of a combination immunization with pertussis, right? So you can have diphtheria, tetanus, pertussis all together. The DTaP or the Tdap. And then the tuberculosis or BCG vaccine is a toxoid vaccine. Subunit, recombinant, polysaccharide, and conjugate vaccines. These all vary in the manufacturing. The subunit, polysaccharide, and conjugate vaccines contain only pieces of the pathogen that they're protecting against. Recombinant vaccines are produced through recombinant DNA technology. And these different types of vaccines allow the options to vaccinate almost everyone, including young, elderly, people with weakened immune systems, and long-term health problems. The limitation of these vaccines is that you need a booster shot to get ongoing protection against the diseases, so to re-stimulate antibody production. So we'll compare the conjugate versus polysaccharide.
So in the polysaccharide, only the sugar part of the bacteria is used, so the capsule of the bacteria. The conjugate vaccines are polysaccharides that are attached to a more complex protein. The conjugate vaccines can stimulate cells in the immune system that polysaccharides cannot, okay, because they're more complex. And the conjugate vaccines are more potent, and they're considered to provide superior long-term protection. And the decision on which to use is based on the patient's age, their medical conditions, and other factors. So you have the PCV13, which is the pneumococcal conjugate vaccine, or you could get the PPSV23, which is the pneumococcal polysaccharide vaccine. So both of these vaccines are offering protection against pneumococcus, but in different delivery systems. Okay, hopefully that makes sense. There are other examples of these are the influenza, the meningococcal, we talked about the pneumococcal, pertussis, that's whooping cough, which is usually combined with in the DTaP or Tdap, HPV, human papillomavirus, hepatitis B, shingles, and Hib, which is Haemophilus influenza type B. Okay, so the messenger RNA vaccines, mRNA, these are the hot topic right now, right? So this technology has actually been in development for decades. I think 1970 was the first time it was used. So it has a very short manufacturing time and very low manufacturing costs, right? So it doesn't cost very much to make, and they can make it very quickly, which is why this delivery system was chosen for developing the COVID-19 vaccine. The only problem with them is that they're very fragile and they have to be kept at low temperatures, and they go bad pretty quick when outside of those low temps. Okay, so they work by triggering an immune response from proteins that they chemically combine. And so they induce immunity both cellular, on the cellular level, and with B cell antibody production. So COVID-19 is the first mRNA vaccine that's been approved. They have used mRNA delivery systems in other areas, such as chemotherapy type of drugs, but this is the first vaccine, right, using this technology. And contrary to popular belief, mRNA vaccines do not alter a person's DNA, right? They're just messengers. So they just tell the cells how to respond. All right, so viral vector vaccines. These actually modify another virus and then use that to transmit and deliver protection from the intended virus. So these ones that are used as vectors are the adenovirus, the influenza, the measles virus, and vesicular stomatitis virus, VSV. So the most recent use of this was for the Ebola virus and then COVID-19. And studies are still being used for Zika, flu, and HIV ongoing for the viral vector. Common vaccines given subcutaneously. MMR. Remember, do not ever administer the MMR to a pregnant patient, and they should avoid pregnancy for 3 months after receiving the vaccine. Varicella. MMRV, which is the measles, mumps, rubella, and varicella all together. Nice big combo. Zoster, inactivated polio. This can actually be given sub-Q or IM. Pneumococcal polysaccharide also can be given sub-Q or IM to anyone over the age of 2. And that's the Pneumovax 23. So these are like the brand names for these, a lot of these vaccines. Varavax is a varicella. Proquad is this 4 combo. Zostavax is for the zoster. Ipol is for the inactivated polio, and the Pneumovax 23 is the pneumococcal polysaccharide. Okay, so let's talk about the injection sites for subcutaneous. Okay, so the most common one for immunizations is the fatty tissue that's over the triceps muscles on the back of the arm. You can also use the fatty tissue over the anterior lateral thigh muscle. Okay, right here. You can use the abdomen. Just make sure that you're avoiding 1 to 2 inches from the navel. So find the umbilicus and then make sure you measure out like a 2-inch, circle radius around it and don't administer there. Upper back. I've never given one in upper back. This is probably supposed to say lower back. The flank area, right? That's a good spot, actually. What do they call it? The muffin top. Okay, but for vaccines, these are our recommended injection sites, right? For babies up to 12 months, on the thigh, and then for anyone 12 months and older, usually they go on the tricep. For insulin and heparin, typically it's the abdomen. For pregnant patients, that then usually move around back to the flank, right? Easily accessible fatty areas. And the insulin is actually absorbed faster when it's injected into the abdomen. Okay, for anything that a patient's getting regularly, you want to make sure you're rotating the injection sites to keep the skin healthy, and make sure that each injection site is at least 1 inch from each other. Failing to rotate sites can cause scarring and then hardening of the fatty tissue, which is uncomfortable. Okay, so important considerations. We always want to ask our patient about any allergies to medications before we administer anything, right? Make sure for sub-Q that the drug is non-irritating and ensure that it's less than 2 mLs. And all refrigerated medications must be kept within a controlled temperature range. So there'll be a special refrigerator, and it has to be checked twice a day. If you're ever become a lead MA, that's probably going to be one of your job duties, is to check the temp and log it and make sure that it's staying within its parameters. All right, you want to make sure you separate your injections by at least 1 inch if you have to give multiples. Rotate the injection site if it's something that the patient's getting regularly. Never inject into any hardened areas, inflamed, reddened, burned, edematous, because these will not absorb properly. Okay, so anytime you're giving any injections, make sure that your site is stable. Okay, this is my little acronym here. STABLE. Okay, so look for scars, tattoos, arteries, bruises, lesions, and erythema, which is what? Basically just redness. Okay, so if it's stable, then don't inject there, right? Never massage after administering insulin or heparin. And if the patient bruises easily, apply ice to the site for 5 minutes after injecting. So especially with patients who might be on anticoagulants. Okay. Go get help if after administering the injection that the site continues to bleed. You can't control the bleeding. If the patient's having a lot of pain, right? There's discomfort, but they should not be in pain. Okay, if you accidentally inject the medicine into the wrong area, all right. If a rash develops around the injection site, if the patient develops a fever, and any sign of an allergic reaction, right? Hives, any signs of anaphylaxis, scratchy, itchy throat, swelling lips, difficulty breathing, anything like that, go get help. So a patient can have an allergic reaction, right? Obviously, after being administered a drug. Usually it's mild, but worst case scenario, anaphylaxis, right? A severe allergic reaction that occurs suddenly and immediately. So that's the thing that people forget about anaphylaxis is it comes on right away, right? So the patient will still be in the office, thank goodness. The only time usually that people experience anaphylaxis out, about doing their daily duties is if they are allergic to, say a bee sting and they get stung by a bee, if they're allergic to peanuts and they actually ingest a peanut, something like that. So it comes on very quickly and suddenly. It is a very serious condition that requires immediate medical treatment. Okay, signs and symptoms of anaphylaxis. So you always want to screen your patients after administering any medication to them. Okay, so pruritus or itching, urticaria, which is hives, dyspnea, difficulty breathing, dysphagia, difficulty swallowing, signs of shock. Okay, so that would be like uncontrollable shaking, right? If their pulses get weak and thready, convulsions, right? And loss of consciousness. Okay, these are all very serious signs and symptoms. Death can occur if these are not treated quickly. Okay, so after we give an injection, this is per site policy, but typically you're going to have the patient wait in the office 10 to 15 minutes after receiving an injection to screen for anaphylactic symptoms. Okay, you want to especially be alert for those symptoms after administering allergy injections or penicillin. So those are kind of more commonly known to cause anaphylaxis. You should have an EpiPen available at all times in your medical office, and you should know how to use it. Okay, they're pretty easy. Pull it out of the box, pull the cap off, and just push it into the patient's, usually the leg muscle, right? So this is an IM injection. So it's automatic, and it contains a pre-measured dose of epinephrine, which is great. So you don't have to worry about measuring it out. Okay, so you want to get that patient the EpiPen immediately after an anaphylactic reaction occurs. Once the patient's stabilized, then the provider will probably order an injection of antihistamine. And you always want to make sure that there's emergency crash carts on site in your clinic and that they have non-expired supplies such as EpiPens. Okay. So that's the medical assistant's role there in treating anaphylaxis. And I believe that is the end of our lecture. Yep, we'll see you next time. Hello students, welcome to Injections Lecture 3 on intramuscular injections. So IM injections are given deep into the central area of a muscle. This is away from large nerves and blood vessels. IM medications are absorbed more rapidly than through sub-Q route. Recall that muscular tissue is much more vascular and has a lot more blood flow than adipose fatty tissue. Muscle tissue can also typically hold a larger volume of fluid without causing discomfort, such as sub-Q would. And large muscle sites are used for irritating medications. So the route is into the muscle tissue. Syringe types are 2 through 5 milliliters hypodermic syringe. The dosage range is going to be 0.5 through 5 milliliters. But doses over 3 milliliters should be divided and injected separately. The needle gauge should be 22 through 25 gauge needle. Most commonly is 25. Needle length should be 5/8 of an inch to 1.5 inches long. And 1 inch is the most commonly used length. For large patients, you may need a 2 to 3 inch needle depending on the site. The needle should be long enough to reach the muscle mass. And remember, it has to get through the dermal layer of the skin and the subcutaneous layer into the muscle underneath. This is to prevent the vaccine or whatever's being injected from seeping back into the subcutaneous tissue. You don't want the needle so long that it goes through the muscle and involves any underlying nerves, blood vessels, or even bone. This can happen. The decision on your needle size and length needs to be made for each individual patient based on the size of the muscle that you're injecting into and the thickness of the adipose or fatty tissue at the injection site, as well as the volume of the material that you're administering. Intramuscular injections will always be at a 90-degree angle. That's so that they can get through the skin, the fatty tissue, into the muscle. Aspiration. Okay, so this is a technique that we use that involves pulling back on the plunger of the syringe after the needle has been inserted, but before injecting, to ensure that the needle is not in a blood vessel. So when you pull back on the syringe ever so slightly, if the needle is in a blood vessel, you will see a flash of blood down at the hub of the syringe. If you see this, you're going to withdraw the medication and dispose of it, and you have to start over with a fresh one in a new site. Now, the CDC does not require aspiration for vaccines and immunizations, either IM or sub-Q, as well as with insulin or heparin. And that's because where we give insulin and heparin in the abdomen, there are no large blood vessels there. And they have decided that vaccines and immunizations are still okay if they do enter into a blood vessel. But any other medications that you are administering, you want to aspirate and cancel the administration of that medication if you find blood in the syringe. Okay. So, any medication other than a vaccine or immunization, you should aspirate on. And you should be practicing this in the lab when you're giving injections into the muscle. Common IM injections are vaccines, antibiotics, hormones, fertility drugs, vitamin B12, epinephrine, antiemetics, analgesics, anti-inflammatory drugs, cortisone, contraceptives. Most commonly, antibiotics are rocephin and bicillin. Most common hormones are testosterone, estrogen, and other fertility drugs that stimulate ovulation. Antiemetics that are commonly given are Zofran, Phenergan, and Reglan, as well as epinephrine in the setting of an anaphylactic shock. We give lots of vaccines via IM. COVID-19, DTaP, Tdap, DT, TD, Hib, all of these combo ones, Hep A, Hep B, etc. Influenza, lots and lots of them. You can see the long list. We're going to talk about our 3 intramuscular injection sites. You should also have a chart such as this one handy that separates out the recommended needle length and volume based on your patient's age, as well as the site that you're injecting into. So you can see that the deltoid is not recommended for infants, and then for toddlers, these are the sizes that you should be using, as well as the maximum volume amounts that can be administered per site based on the patient's age. So for vaccines, we only use 2 of these sites. Deltoid is the most commonly used, and if that's contraindicated, we can use the vastus lateralis. And this depends as well on the age of the individual and their degree of muscle development. There's no major nerves or vessels near these sites when it's administered properly, so they're fairly safe. So for a newborn, the vastus lateralis is the recommended vaccine site. For an infant as well, vastus lateralis. For a toddler, we still typically use vastus lateralis, but if the deltoid muscle is large enough, if you have a large, well-developed toddler, that can be used. For older children, we tend to prefer the deltoid, but we could use the vastus lateralis if needed. And for adults, deltoid is preferred, recommended, but the vastus lateralis could be used. For deltoid injections, typically you're going to use a 22 or 25 gauge needle into the deltoid muscle of the arm. And then here's a nice chart depending on how large and the gender of your patient, kind of a standard needle length. So for small patients, we're going to use a 5/8 of an inch needle. Okay, as long as you're not bunching up the subcutaneous tissue on the outside of the arm and it's given at a 90-degree angle. For very large patients, we will need a 1.5 inch length needle to get down through the subcutaneous into the muscle. Now, if you have a patient with a very small arm, fairly small deltoid muscle, if you put in a 1 inch needle, especially a 1.5 inch, you could hit their bone. Okay, and that is a rather disconcerting thing to have happen. So always look at your patient, assess the site, and choose your needle size accordingly. We're going to be administering in the central and thickest portion of the deltoid muscle. You want to make sure your patient is in a sitting position. It's going to be difficult if they're laying supine. You want to make sure their shoulder and arm is fully exposed. And this is super, super important. Make sure their arm is loose at their side and the muscle is relaxed. If they are tense and they have their deltoid muscle contracted, it's going to be impossible to get that needle in there in a smooth and comfortable manner. You always want to locate the acromion process, which is the bone at the top, at the shoulder, where the collarbone connects. And then you want to locate the axillary line. So you just look at the front and the back, where the crease is at the beginning of the armpit. And you're going to measure about 2 to 3 fingers below the acromion process. That should be your injection site, right in the center of the arm. And it should be above the axillary line or the level of the armpit. You don't want to ever inject below there. Make sure you're using a needle long enough to reach the muscle. Insert the needle at a 90-degree angle with a quick darting motion. Administer the medication slowly and steadily. Use the patient's non-dominant arm if possible. Use a maximum volume of 1 ml in the deltoid. Vastus lateralis. This is on the anterior and lateral aspect of the thigh, which is why it's often called the anterolateral thigh. It's generally thick and well developed in patients of all ages, even babies, and it's not located close to any major vessels or nerves. It's also easily accessible to both the provider and the patient who might be administering IM injections at home to themselves. Put the patient in a supine or sitting position. Locate the greater trochanter and the lateral femoral condyle. Measure a hand's width above the knee and a hand's width below the greater trochanter. And so you're pretty much right in the middle third of the thigh in the central and thickest part. That's going to be your injection site. Make sure you use a needle long enough to reach the muscle. Insert at a 90-degree angle with a quick darting motion. Administer the medication slowly and steadily. Use a maximum volume of 2 mLs in the vastus lateralis. So here, this MA has their left hand on the greater trochanter, and they've located the condyle there, and they're measuring a hand's width, and they measured a hand's width from both sides, and so they're pretty much right in the middle. Okay, and this is their injection site. Nice big muscle there that you can hold and visualize. The ventrogluteal is the preferred location for large volume and deep muscle IM injections. And you can put up to 5 mLs in one injection, depending on the age and size of the patient. The medications are absorbed quickly into the bloodstream, so this is a good way to deliver treatment in a fast manner. And it's pretty safe, reliable, and accessible. And it also has good bony landmarks to help you locate the correct injection site. And there's very little danger of hitting any blood vessels or nerves. Okay, so these are our landmarks: the greater trochanter, the anterior superior iliac spine, and the iliac crest. So step 1, you're going to have your patient lie on their side on the exam table. So if you're injecting into their right side, you're going to use your left hand to landmark. And if you're injecting into the patient's left side, you're going to use your right hand to landmark. So right here, this MA is using their left hand to landmark the patient's right side. You're going to locate the greater trochanter, which is the outside of the top of the femur where it enters into the hip, into the pelvis. You're going to locate that, and you're going to put your palm right on there. It's going to feel firm and round like a golf ball. Okay, so palms right over the greater trochanter. You're going to make sure your thumb is pointing towards the patient's groin. Okay, and then you're going to locate the anterior superior iliac spine with your index or pointer finger. Okay, you should be able to feel it unless your patient's very obese. And so I like to call this the as is. A for anterior, S for superior, I for iliac, and S for spine. So remember, as is, with your point to the as is. Then you're going to spread your remaining fingers away from your index finger and point towards the iliac crest. And your injection site is going to be right in the center of the V that you have formed with your fingers. Okay, right in between where the knuckles are. That's your injection site. Okay. This MA went ahead and injected right into the dummy for photographic purposes. But you want to be really careful doing that if you still have your hand there. You want to make sure you don't accidentally hit your hand. So as long as your site allows it per policy, you can often use a fresh alcohol antiseptic wipe and place it on the patient with the corner pointing right towards your injection site after you've landmarked it, and then you can remove your hand. And this, I think, is a much safer way to insert the needle into the patient and make sure you're still going into the correct injection site. You're going to always go to 90-degree angle. You're going to aspirate if it's a medication, and you're going to inject the medication slowly and steadily. Okay? For demonstration purposes, gloves were not worn in these photographs, but you're always going to make sure you wear gloves when you're administering any injection. The dorsal gluteal site is no longer recommended. In fact, at PAMF, I don't think you're even allowed to use that. And the reason is because it's very close to the sciatic nerve, so there's a high possibility of accidental injury to the nerve, which can cause the patient a lifetime of pain. So caution must be exercised if you're ordered to use this site. Okay, and you have to carefully identify your landmarks. So this is our last resort if no other muscle site can be used. You never want to use in children under 3 years of age unless they've already been walking for a year, so they have well-developed gluteal muscles. And then, as always, large and obese patients will require a longer needle to make sure that it gets to the muscle. So you're going to basically divide the gluteus into 4 quadrants by drawing 2 imaginary lines. Okay, so you're going to draw a line splitting it in half vertically, and then a line splitting it in half horizontally. And your injection site is going to be in the upper outer quadrant. See here, we have an X here or an X here. And of course, you're going to insert at a 90-degree angle. You also want to be able to locate the posterior superior iliac spine, as well as the greater trochanter. And you're going to draw an imaginary line between the two of them, kind of a diagonal line. And then that helps you also find your upper outer quadrant. So you want to make sure you never cross that line because you're going to have your sciatic nerve there. As always, inject at a 90-degree angle. The Z-track method. So this is a method used in IM injections that seals the medication deeply within the skin. And this allows no exit path back out into the subcutaneous tissue or the skin. So what you do is you use your non-dominant hand to pull and stretch and move the patient's skin and tissue. And so you're going to displace it about 1 to 1.5 inches to the side prior to injecting. And then you insert the needle, inject the solution, and then release the tissue immediately after the injection. We use this with dark colored medications, such as iron, because these can stain the subcutaneous tissue or skin if they leak out into it. We also use this with very irritating medications, so that they don't get into the subcutaneous or skin tissues. You want to make sure that you use a separate needle to draw up the medication and then discard that and use a new needle for injection. Why do we think that would be? Right, because the needle that's used to draw up the medication is still going to have that medication inside it as well as on the tip and the bevel. So it'll still get into that tissue that we don't want it to get into. So that's why we use a fresh tissue to minimize any staining or irritation. Aspiration will likely be required because this would not be a vaccine or an immunization that we're giving via the Z-track method. And you never want to massage the injection site because that will encourage that fluid to leak out, which is exactly what we don't want. Always, always ask the patient about any allergies to medications as well as latex or anything else you might be using in your equipment. If your dosage is 3 mLs or greater, typically you want to divide your dose into 2 syringes and inject into 2 separate spots. But this you want to check with the ordering provider on if what they've ordered is greater than 3 mLs. Always assess the patient's age, size, and muscle condition of the site that you are using while you're deciding which route and site to use. And don't ever give an IM injection at a site where there is any indication of pain or tissue damage, such as bruising, hematoma. Don't ever inject into a muscle where the size and condition does not seem large enough or adequate. For large patients, probably will need a 2 to 3 inch long needle to ensure that the medication is injected into the muscle. And if the patient jerks away or moves or anything like that where it seems like only a partial dose of the vaccine or medication is administered, unfortunately, you have to repeat it. If a patient's getting frequent injections, make sure you rotate the injection site so no scar tissue will build up. And if multiple vaccines are being administered at the same time, use a different muscle site if possible. For infants and younger children, usually it's easier to give into the same limb fairly quickly. So the thigh is the best site to do that because it's a large muscle and you can inject multiple syringes, and poke multiple needles into the same site and the same muscle. Just make sure you always separate them at least by 1 inch. So for older children and adults, if the deltoid muscle is large enough, you can use it for more than 1 injection. Again, make sure that you're separating it by at least 1 inch. And this is probably something you'll practice in the lab. And then if we have anything that's very reactive or has the high potential for side effects or reaction, definitely use different limbs and different muscles if possible. That way we limit the reaction to one site. And always use combination vaccines if possible. Hopefully they're ordered by the provider, but if not, you can always question the order, right? If you know that you have a combination vaccine on hand and the provider orders them all separate, you can definitely bring that to their attention and see if they want to change the order. Because this way, this reduces the number of injections and the number of needle sticks that the patient gets. Always document the location of all of the injection sites in the patient's medical record. Right? So if you're giving a Tdap in the right arm and you're giving an influenza in the left arm, make sure you document that specifically in case they have a reaction or a local infection. That way we know for the future that they possibly have an allergy to that specific vaccine or medication. Special considerations need to be made for patients with bleeding disorders or if they're taking anticoagulant therapy, which are drugs to, quote, thin their blood, unquote, because they're more likely to develop hematomas after the injection at the site. So you want to make sure the provider has considered this and has decided that their bleeding risk is low and that the vaccine or medication can be administered with reasonable safety. The patient or family should be instructed about the risk of the hematoma from the injection. Always use the smallest possible size and gauge needle. Now recall that hematomas are just when the blood seeps into the surrounding tissues. And apply firm pressure to the site for at least 2 minutes after injection to hopefully keep that blood from seeping out. But never rub or massage the site because that could have the opposite effect. Always consider if your patient has a latex allergy and determine if what you're administering, the vial or syringe, has any latex, because we don't want to cause a severe anaphylactic reaction unless the benefit of that vaccine or medication clearly outweighs the risk of allergic reaction. If the patient has a local or contact sensitivity to latex, that should probably not be a contraindication to the vaccine. So fainting or syncope may occur during vaccine or any medication administration, especially with adolescents, so preteens and teens and adults. The patient may fall and could potentially become injured. So you want to make sure that you have your patient in a sitting or supine position during injections. It's not that common, and it's not an allergic reaction. Okay, so sometimes patients will say, well, the last time I got my influenza shot, I passed out. Okay, well, that's not a reaction to the influenza shot. That's just a reaction to the experience of getting an injection, right? So if the patient faints, observe them, provide supportive care until they've recovered. Tips for minimizing your patient's pain. Always let the alcohol that you've used to clean the site dry thoroughly. I see this happen all the time out there. People are in a hurry and they just give a quick swipe of the alcohol wipe and then boom, stick that needle in right then. Okay, one, it's going to be uncomfortable because they've just pushed that fresh alcohol into the tissues. It's going to sting, right? But two, the process of drying with the alcohol is what gives it the aseptic property. So if you don't allow the alcohol to dry completely, then the bacteria and germs that you're trying to kill probably isn't killed. So you could just be pushing that right into the patient, which could potentially cause an infection. Always make sure the patient's relaxed and that the muscle in the injection area is relaxed. If it's tensed or contracted, stop, have the patient help them relax. Sometimes I have to put my arm, my hand on the patient's like shoulder if they've got their arm tensed up, and kind of give them a little, almost like a little massage to help them relax. A lot of times people have no idea that they're doing this. Making sure that you are quickly penetrating the needle through the skin using a smooth and continuous darting motion will make a huge difference in the pain level for the patient. Okay? If you insert that needle slowly because you're nervous and you don't want to hurt the patient, you're actually hurting them more. Okay? So getting it in a quick, smooth motion, almost like you're throwing a dart, is going to be much more comfortable for the patient. And then you want to inject the medication slowly and steadily. Okay? Don't start, stop, start, stop. Just slowly and steadily until it's all gone. And then when you're removing the needle after injecting, don't change direction, okay? If you've gone straight in at a 90-degree angle, come straight out at the same angle. Because if you change direction, that hurts. Yikes. So possible side effects. Most side effects are a result of the actual drug that's injected and not the procedure itself. So we usually observe the patient for 10 to 15 minutes after any injection for signs of a drug reaction. Remember, we call this a med watch, and it's per site policy how long you're going to do that for. Possible side effects, minor discomfort and pain at the injection site. That's really common, right? The muscle's going to be sore. You've just, poked a needle in there and disturb the tissues, so your patient's going to have soreness in the muscle for a couple days. And it's not uncommon to get localized redness, swelling, and of course bleeding at the injection site after you remove the needle. And it's also not uncommon for the patient to have a low-grade fever for a day or two after. Now that's usually from the vaccine doing its job, creating antibodies in the immune system. So adverse reactions and complications are different from side effects. Make sure you know that. So adverse reactions are undesirable reactions that occur. Okay, and then severe reactions and complications are rare. Anaphylaxis being the most severe allergic drug reaction. Excessive pain, burning, or numbness. Okay, so again, they're going to be sore and there's going to be a little bit of pain, but not excessive. And if there's any burning or numbness there, unfortunately, that indicates that there's probably some nerve damage, which is not normal. And then a high fever would not be normal. A rash around the injection site would be a sign of an adverse reaction. And then infection at the injection site. Okay, and then if it doesn't stop bleeding after a few minutes, that would be a complication. And if the medication accidentally got injected in the wrong area, that's definitely a complication that needs to be reported immediately. As always, in case of an emergency, call 911. We're going to document the date and time that we've given the injection, the name of the medication, the dose, the route, the site that we used, the manufacturer name, the lot number, the expiration date, the patient's reaction, and your name and title after you've administered the vaccine. And always the VIS date, the publication, as well as the date that it was given to the patient or the parent guardian. So here's a charting example. On 2/14/21 at 9:45 a.m., Hep B was given 0.5 milliliters intramuscularly in the left deltoid. It was made by Merck. Here's the lot number, the expiration, 05/21. No adverse reaction was noted. The mother of the patient was given the VIS. The VIS publication date was May 17th of 2019. That was the last time it was updated. And this is signed by a student, SMA. Okay, so that's the end of intramuscular injections.